It's my privilege to introduce our first keynote speaker, Dr. Bruce Johnson. He's the head of the Lung Cancer Project at the Dana-Farber Cancer Institute, as well as its Chief Clinical Research Officer. He's also the immediate past president of the American Society of Clinical Oncology. He's been involved in making many of the major advances that have really significantly changed the paradigm of how we treat advanced lung cancer. So it's my privilege to welcome Dr. Johnson up to discuss the oncologist approach to TKI therapy.
Thank you. It's my privilege to be here. One of the things that is critical for those of us who have the privilege of taking care of lung cancer patients is to first have the characterization of the tumor that's dictating it. Now, one of the things that happens, if you read the New York Times, there's some stuff about disclosures. I wasn't exactly sure how they were going to handle it, but I decided to put a disclosure slide into my talk that's not in with your slides. I have, the thing in particular, I have post-marketing royalties for EGFR mutation testing. So I do get a few checks. Please keep ordering the tests, and please keep paying the royalties. One of the things that's critical about having the biomarkers is, and a lot of you in the room know the problems of this, is having to go back and redo a test. And one of the things I'm going to go through here is the pace at which they're coming and changing. So, we had our first approval with a biomarker by the EMA in 2009 for EGFR mutation testing. It took us till 2015 here in the U.S. to get approval for gefitinib. There's approval for others, but I put the first in the class down for each of these. Oh. I failed my intelligence test. All right. So the next one that came up was ALK in 2011, a provisional approval. Then they started to come faster now with ROS1 in 2016, BRAF V600E in 2017, and there's two that are under priority or breakthrough status for 2018. So as you can see, the pace is picking up, and one of the things that we don't want to do is have to go back and retest for a new approval. I know Dr. Lindemann's going to be speaking. This is his list of the genes that we get. I go through each and every one of them when I get back the report. And the reason for this is I'm going to show you an example of a few of the patients. I don't know how many of you look at CT scans, but this whole thing came about because we made the observation that there were people who had these dramatic responses, are now called super responders or exceptional responders. And these are the CT scans of a lady who is a never smoker and it was her first treatment of gefitinib. We had an expanded access trial. At the time, we didn't know why some people responded and some didn't. And she had this rather dramatic response with clearing bilaterally of the white infiltrates. Now, the one thing that happens, and this went on for 2.5 years, the typical length of response at the time for chemotherapeutic agents was between 4 and 6 months. So this was, somewhere between 4 to 8 times what we would typically see. So this one was dramatically different. The good news, it wasn't that complicated because this agent is directed against the epidermal growth factor receptor, and you just had to sequence the epidermal growth factor receptor and ended up finding mutations in it. I'm only going to show one Western blot and one growth curve. The one on the left shows this is not a subtle difference. This shows a cell viability assay where the further to the left that it goes down, the more sensitive it is. And these are on log scales. And the one on the far left is 3255, which has an L850R mutation, one of the sensitizing mutations. And it's not 5-fold or 10-fold, it's 100-fold more sensitive to the drug, which explains why in that particular lady we saw that response that went on for 2 years. And I'm going to show the one Western blot, and one of the reasons why we thought this was actually causal, we had the association by seeing those that responded were mutated, but when you went into the cell line, and the one on your far right, 3255, shows it at 100 nanomolar, which is about 5-fold lower than what you could achieve in the plasma. You see dramatic downregulation not only in the activated phosphorylated portion of EGFR, which is the top band to your right, but you also see the downstream targets, phospho-ERK and phospho-AKT. So yes, there was an association, and plus in a cell line that was mutated, you began seeing this dramatic sensitization to the therapeutic agent that we use. And there were three different groups. Our group was the one in Science in 2004. The group from MGH is at the bottom, and then the group from Memorial Sloan Kettering all came out within the first few months. And 23 of the 31 who responded to gefitinib had the mutation, whereas those that had wild types, almost none of them responded. And they all were around the ATP binding pocket of the epidermal growth factor receptor. And this really has changed our field. These manuscripts have been cited 24,000 times in the past 14 years. They're commonly cited. Please put them in your publications when you have EGFR. And then when this is tested prospectively, it took about a year and a half for them to set up testing across Japan, where the frequency of the mutation is 3-fold higher than what it is in the US. And they randomized them to gefitinib chemotherapy, and the CBDCA is carboplatin, and paclitaxel are standard chemo agents. And in contrast to what we'd commonly seen in other trials, you began showing a doubling of the time that the drug worked, going from 5.4 months for the chemo to 10.8 months for the EGFR TKI. So this was a dramatic difference. It was a doubling of the length of time it worked. And it was quickly adapted here, but it took a long time because most of these trials were done outside the US, and the FDA is very interested in seeing the information generated, and so it took 2015. It was in 2009 for approval in EMA. Now, one of the things that happens once you have a drug that's effective, and it so happened that particular drug was developed against the wild-type receptor. If you develop a drug that's specific for the mutant form or is more potent and more sensitive, you end up going through a paradigm where you try to improve the drug. Once you have the proof of concept, as I showed you before, we were working with a progression-free survival of about 10.8 months. One of the things that happened, and it began to be routine, where you biopsied these patients to find out if they developed, to find out the mechanism of resistance. And the gatekeeper mutation, the T790M, which is equivalent to the 315I in CML, was the most common form of resistance when you biopsied these patients. This is more than 100 patients. And so they began the work to develop an agent directed against it. And it came up with a drug that instead of a conazolone-based structure, it was a pyrimidine-based structure. It was a very novel construct of the drug. This is one of my patients who was treated very early on in the trials of this development. She'd been previously treated with one of the standard EGFR TKIs. And you can see here on this radiograph, she had a lot of CT scan. You can see she had a lot of pleural effusion on the left and the infiltrates on the right. And she responded for about a year and a half. So she had the T7. She was tested, she had the T790M, she went on the trial, and had the response for about a year and a half. And when this was tested in patients, they tested a few that were T790M positive, and those that were T790M negative, and this was, at the time, this was all done on the biopsy specimens. You had to biopsy the patients in order to be able to put them on this study. The T790M positives, after they'd had another EGFR TKI, had a progression-free survival of about 9.5 months, where it was about 3 months for those that were negative. And it was a proof of principle. And in 2015, it approved osimertinib for this T790M population. That was the initial approval. So it took about, from the time, it took 11 years between when the first drug came, define the resistance mechanisms, and develop a drug and get one that's more effective. Now, one of the things that happens, we have the principle of giving the best drug you have first. And so this drug, which is called osimertinib, was compared to the standards. As I showed you before, the initial standards were gefitinib and erlotinib, drugs made by two different companies, both developed against the wild-type receptor and not the mutant form. And they were randomized. And this is the results of the study. This is a progression-free survival where the osimertinib nearly doubled the length of time it worked. So it went from 10 months to 18.9 months. Now, the reason why this is important for those of us who practice thoracic oncology is that It used to be these drugs worked for 4 to 6 months, number one, and number two is that the survival of these patients was 8 to 10 months. So in this subpopulation, this becomes critically important for their management. We need to know this as quickly as possible after we make a diagnosis of advanced disease. And for this group of patients, certainly all of us want to know this 10 to 15% so that we give them osimertinib as the initial treatment, where we know that this is likely going to work for at least 2 years, and we're waiting. The good news is we're waiting for a while to find out what their expected survival is. But if this follows the others, it's typically somewhere between 4 and 5 years, or it's a five-fold increase in what you expect for this subgroup. I want to go on to ALK. This was discovered in a laboratory in Japan in 2007. This is one of my patients as well. She had that large mass on the right side there. And she had the crizotinib work for about 6 years. She was initially diagnosed in 2009, and at the time they were still making judgments, making treatment decisions based on clinical characteristics. So she was a never-smoking woman with adenocarcinoma, and they gave her erlotinib on the basis of her clinical characteristics. She didn't respond, and then she came here to the United States, and we did the testing, and she had the ALK rearrangement and has had this dramatic response. And when they've compared crizotinib to chemotherapy in the patients, you'll see something very similar, this hazard ratio of progression-free survival of 0.45. The other thing that's very interesting, when you go in, you see that flattening of the curve. And as I showed you, there are a few patients where this goes on for years. And the lady I showed you there, it responded for 6 years. So it's critical to know this at the time we go into this. Now, in the crizotinib study, they compared people initially given crizotinib, and the one on the right is survival. It slightly favors the crizotinib arm, but the patients were allowed to cross over. Now, the interesting thing that happened, and the thing that happened to my patient, is that this stuff works long enough that she got kicked off the trial. They originally wrote it to follow the patients for 2 years after they started. They had to amend the study to follow them for at least 3 years from when the last patient went on. And she ended up living long enough that they ended up closing out the study. I reviewed the paper for this, and I was sort of curious about why they were sending it in so late. And I went back to the original protocol that stated they were going to follow them for 2 years from the last one, and they ended up having to amend it. And I'm going to show you one other example where we've gotten some tails on the curve. Now, as I mentioned before, the paradigm is that you find the target, you do a proof of concept, and crizotinib is not that specific of a drug. I'm going to show you it also has an approval for ROS1. You go through the paradigm again of finding a more potent, more specific drug that's specific for the target once it's established. And alectinib is between 10 to 100-fold more potent and more specific for the ALK gene than crizotinib, which also works on MET, and it works on ROS1, which I'll show you in a minute. And they did this randomized study of alectinib versus crizotinib. And once again, you see this dramatic difference in the progression-free survival. Once again, a hazard ratio of 0.45, or it works twice as well. And you can also see that the hazard ratio for overall survival favors alectinib, and these patients are allowed to cross over, but it doesn't reach statistical significance. The other thing I would point out is the majority of these patients are alive beyond 2 years, which is a good bit different than what we've typically seen for lung cancer. And this is the other good thing, is that, as I showed you before, this was reported out when it was relatively immature. This was updated at this year's ASCO, and the progression-free survival of this is out to 3 years. I want to remind you the progression-free survival used to be 4 to 6 months with chemotherapy about 14 years ago. So this is dramatically different for the 5% that have the ALK rearrangement. So we're filling in the pie of having more and more of the patients who can get targeted therapies, and we need to know this information at the time we initially treat it, because the patients who get the best treatment first are the ones that their ultimate outcomes are improved compared to those where you have to give it after chemo. I'm going to move on to a few more. ROS1, it makes up about 1% of lung cancers. When this was published initially in 2014 in the New England Journal on 50 patients, as you can see, 72% of the patients respond. The other thing that's interesting is three of those patients ended up having complete responses, which is not something you commonly see in lung cancer. This has been reproduced in Asia, where the frequency of the mutation is similar. Once again, you see the exact 72%. For those of you who aren't used to looking, these are called waterfall plots. Everything below the line at 0 is responding or shrinking, and the few that are above the line are those that are growing while on therapy. As you can see, almost all the patients have stable or responding disease, and you can also see some very dramatic responses. Now, this translates into a long progression-free survivals. Once again, on the chemo, it's 4 to 6 months. Here in the New England Journal, this was approximately 19 months on the progression-free survival and about 16 months when the same study was done in a larger cohort. The other thing from these cohorts, and I'll show you one more, we've also got some idea of getting this approved, what it's going to take to get these drugs approved on single-arm trials. We don't have to necessarily, in these rare subsets, have to go through randomized trials to prove its utility over existing treatment. So the pie gets a little bit bigger. The other thing that happens that all of you know from doing the testing is that these groups of trying to get the targets, unless we can get KRAS, are going to be very small increments each time. I want to go on to BRAF. One of the interesting things is that I was involved in the discussions with, at that time, GlaxoSmithKline to try to, and with Genentech to try to get the combination of drugs for this. And Genentech was a little bit further ahead, but GSK was a little bit further behind, and they actually agreed to go after the 1% of lung cancers. Now, at the time, they were doing single-arm BRAF-directed drugs as well as combinations for melanoma, but in lung cancer, the V600Es for which this is developed only make up about 1%. Now, 1% of the lungs is pretty close to the number of patients with melanoma with V600Es. So although it's uncommon, the total number of people who can be treated is comparable to what we were seeing for melanoma, where it's standard practice. And once again, this is one of the patients that's treated at Dana-Farber. As you can see, the CT scan on your left shows the pleural effusion on the left as well as extended infiltrates on the left. And he's had a response now for about 3 years. These are the waterfall plots for second line, which is patients who have been previously treated. And the first line, once we had showed that there was activity in previously treated patients, we could put previously untreated patients on it. So once again, it's critical to know those who have V600E BRAF at the time of diagnosis. 64% had these responses. And including some complete responses. For those of you who don't commonly look at lung cancer, it's very unusual to see everything below the line. So this is a very impressive responses for these, and these were published in the last 2 years. On the basis of these single-arm trials of a progression-free survival of 10 months, a duration of response of 10 months, it received FDA approval last year. And we've done a presentation at the European Society of Medical Oncology jointly with the American Society of Clinical Oncology, and both the EMA, which is the regulatory body of Europe, and the Food and Drug Administration, the FDA here in the US, agree that somewhere of a progression-free survival of 6 to 10 months and a response rate in excess of 50% and a duration of response of about 10 months will get you single-arm approval. So the companies have a pretty good idea now about what the hurdle is to get across in these single-arm trials. The second thing is the progression-free survival of the BRAF with the combination directed against the V600E BRAF and its downstream target MEK, trametinib, which is the combination that's approved in melanoma for V600 BRAFs, and a similar one when it was independent. So it's about 11 months, pretty similar to what you saw with the initial permutations in the other targets. And the survival is about 2 years. Once again, we've started with 8 to 10 months. Now, one of the other things that happened is that it was our plan to publish the survival of this, of the whole cohort that were treated on the combination study about 1.5 years ago. And we've had to hold off because we were waiting until about approximately 75% of the patients had died. And the tail on the curve is such that we've had to postpone both presenting as well as publishing the material for about 1.5 years. one of the best problems I've had in practicing medical oncology in my life. So once again, the pie gets sliced a little bit larger. And I'm going to go to the two that are currently, that we think will likely come. NTRK, which is pretty tumor agnostic. It's present in a few lungs, but it looks like it's pretty consistently able to be targeted no matter what the histology. So this is the best response. Larotrectinib is a drug that's specifically developed for NTRK rearrangements. There's 3 of them. It looks like it responds equally well to all of the tracks that are rearranged, number 1. And number 2 is that as opposed to BRAF V600E, where you see different responses in lung and melanoma than you see in colon, this looks like it responds in nearly all the tumors that you find. As you can see, they've got up here 12 different histologies. It includes both pediatric tumors as well as adult tumors, and it includes a large number, including soft tissue sarcomas. Now, there's only 4 lung cancers in here, but it still makes up between about 0.5% to 1% of lung cancers. The lung cancers, the important ones, are that kind of light blue, and you'll see there's 2 that have a near complete response, and then there's one that is clearly in the waterfall plot, and then one that doesn't make it. So it's 3 of 4 in lung, and if you do your math, that's 75%. And the progression-free survival for those patients is in excess of 12 months. So this is the NTRK, as I showed you before, has gotten breakthrough status with the FDA, and it's currently being reviewed. And once again, the pie gets a little bit bigger. The last one I'm going to cover is RET. RET is present in about 2% of lung cancers. And there's a drug, LOXO-292. This was presented at our annual meeting at ASCO in this year. The rearrangements occur most commonly in lung. The blue is are the non-small cell lung cancers. There's a few with thyroid cancer. Then there's also mutations in RET. I'm not going to show you the data on the mutants. It's a bit less active than the rearrangements. And then there's a few in pancreatic cancer. So it's 3 different tumors that take place. And these are the duration of responses for those that have RET fusion partners. As you can see, the non-small cell lung cancers, those arrows on the end are those that are still on treatment. I guess I cut off the time frame on this. But anyway, 12 months is about in the middle of this. And as you can see, the thyroid look relatively well, and the pancreatics work as well. So once again, it looks like the RET is tumor agnostic, and it looks like the ones where you find it, thyroid, pancreatic, and non-small cell lung carcinoma, they have responses. And the duration of these responses look like they are going to be in excess of 10 to 12 months. So once again, we think this is likely going to be approved sometime in the next year. So the pie gets quite a bit bigger. It's about 25% or a quarter of lung cancers. The thing I haven't covered today is the tumor mutation burden as a potential predictive marker and PD-L1 testing for immunotherapy. That makes up about another 20 to 25% of lung cancers that have a high enough PD-L1 that you can give them checkpoint therapy initially. And the one thing I must say, in 14 years of having gone to having everybody treated the same, to being on the brink now of having 7 different treatments for the initial therapy, and it's all based on the markers that all of you are generating for us, so that we have the idea to be able to translate the information gathered from the biomarkers to then end up treating our patients with the expectation that it's working somewhere between twice as long to 5 times as long as what we used to be experiencing, what I consider relatively short 14 years ago. So what I've showed you here is that for EGFR, with the gefitinib, from the time of discovery until its first approval, somewhere around the world was about 5 years. It took us 11 years here in the U.S. We were a little slow. For the ALK, for the crizotinib, we were amongst the first in the world to approve it by 2011. And it was only 4 years from when there was discovery of the marker until the drug was approved. One of which was relatively short, in drug approval process. For ROS1 crizotinib, in 2016 it was approved. As you can see, we're going about 5-year increments during those first 3. BRAF in 2017, and these other 2 in 2018. The thing I haven't put on here is the more potent and specific drugs are getting introduced and being approved. And one of the good things in life is that it's becoming increasingly challenging to keep up with the FDA approvals, number one. And number 2 is that it makes your job more challenging, making certain that all of our patients have the appropriate testing, not only in the academic centers, but also this needs to be made available to more and more of our patients. And I'm glad to see on this agenda of having not only issues about the technical aspects of doing the test, but also avoid going broke. Our institution, in order to be able to do this, because we were involved in this, spends somewhere between $3 and $5 million a year supporting the genomic testing that's subsidized by our institution. We think it's important enough that it needs to be done. As the Chief Clinical Research Officer, we make certain that we make this available not only to the patients where we think it's going to get paid, but also all the patients where we think it's going to be worthwhile. And we think this is making a dramatic difference. And we look forward to the rest of this year with larotrectinib to add NTRK. And one of the things we think is really very likely is the RET rearrangement that's achieved breakthrough status actually this month. So with that, I hope going through the rest of the testing, you'll be able to see where we are, number one. And number 2 is how important it is for those of us who manage patients with lung cancer. Thank you. Thanks.
Dr. Johnson, are you able to wait for our
Yes.
questions at that time for Dr. Johnson? And there is one question. I guess about 30 of you texted me regarding a comment that I made, and so I will answer that question. At sunset today, Mr. James Marshall Hendricks will play the national anthem on his guitar for us. So I know who went to Woodstock. Okay, our next speaker is the Director of Molecular Cytopathology at MD Anderson Cancer Center, Dr. Sanchita Roy Chaudhuri.
Good morning. Thank you for having me here. It's a great honor to be here. And as you can see, I will be presenting on cytology specimens and the biomarker testing in cytology. And it was interesting when I was looking at the agenda that Phil has me presenting in between these 2 giant speakers from Boston. So I guess all I would like to say is, go Astros. I don't have any disclosures, and you can see I did include my Twitter handle and the hashtag for the conference. So for those of you who are on Twitter, do use the hashtag so people who aren't here can follow along and participate in this conference. All right, so I'd like to start off with the golden circle of cancer biomarker testing. And the 3 important questions are the why, the how, and the what. The why, of course, we just heard an excellent lecture on why we do biomarker testing in cancer patients. Of course, it's for better patient care. The how is what I will try and go over a little bit today. And for the what, you have the rest of the conference, and you have excellent talks from really great speakers on a multitude of biomarker testing in different organ systems. So this is sort of the summary of what I will be talking about today. So the bottom line is that cytology specimens provide excellent substrates for biomarker testing. And it is possible to do biomarker testing on cytology as long as it's appropriately validated. The important thing is that there are multiple factors that impact testing, and so recognizing these factors are important. And as the pathologist who is looking at the specimen, triaging these, and handling the specimens, we are actually in charge of how well these specimens work for biomarker testing. So we actually play a role in improving the success rates. So again, not something that's new to this audience. The role of cytopathology has changed from being primarily a diagnostic modality to something where we're using it not just for diagnosis, but also for all the clinical molecular assays. And when we're talking about biomarker testing, we're primarily talking about DNA, RNA-based tests, either PCR-based assays or some form of in situ hybridization like FISH assays, or something to do with the protein where we're doing immunostains to recognize these biomarkers. So biomarker testing is common in cytology. And why cytology? It's mainly because some of these patients, a large fraction of these patients, are actually diagnosed at an advanced stage, and so they're not candidates for surgical resection. So your small sample, which is either your core biopsy or a cytology effusion or an FNA sample, is probably the only sample you'll have, not just for the diagnosis, but for all the ancillary testing that we will need to do. And so the 3 points that I mentioned earlier, I'm going to go over those 3. So one, as I mentioned, as long as they're appropriately validated, biomarker testing is possible on cytology. So in 2013, the American Society of Cytopathology and the Papa-Nicolau Society of Cytopathology issued this joint position statement on the use of molecular testing in cytology. And if you look at the list of things that they had in the white paper, things haven't really changed much. We're doing all of these things. They're all still relevant. We've just expanded the repertoire of the things that we're doing. And all of these things are things that are important in cytology specimens. So, for example, when you look at HPV testing for cervical cytology, we've moved from like conventional pap smears to a liquid-based assay. And here's a table that shows all the different FDA-approved HPV testing that we do on our cervical specimens. There's multiple different indications of when we use these assays, but all of these tests, and it shows you the timeline of how these tests were approved for these different tests. But again, HPV testing is something we do routinely on cytology specimens. As a follow-up of that, HPV testing has become really important in head and neck cancers. And this is actually from the guideline issued by the College of American Pathologists of HPV testing in head and neck carcinomas. And this is statement 7, where they talk about the use of HPV testing in cytology specimens. Now, again, all of these assays that we do in cervical cytology, all the different platforms that we have, again, can be translated very easily into head and neck cancers as long as you appropriately validate things. In addition, there was no specific recommendation for a testing methodology. And again, for P16 staining, you could either use IHC or an in situ hybridization. Cutoffs were not recommended. The recommendation is, again, appropriate validation. When you look at thyroid cytology, molecular testing has become really important, especially in the category of the indeterminate thyroid cytology. There are, again, a whole bunch of different testing platforms that we have available at this point. The interesting thing is that most of these thyroid molecular tests require you to do an additional pass, like a dedicated pass in a proprietary solution. These are mostly send-out tests that are done, except for one where you can use archival smears for testing. Now, interestingly, there are a bunch of studies that have come out, including one from this institution, where they are actually using the residual liquid-based cytology for doing testing, including next-gen sequencing, which is kind of interesting because if we're using the residual liquid-based solutions for HPV testing, why can't we use that for some of these other molecular tests? Fish testing in cytology has been around for a while. We've been doing the Eurovision assay for urinary tract cytology. There is a fish assay for pancreatic, biliary specimens. And again, fish has been used in lung cytology for several years now. In cytology, I mean, you can obviously do it on your formalin-fixed tissue, but you have the ability to do it on your smears or your liquid-based preps as long as you validate your assay. What about immunohistochemistry? So, of course, the same caveat. As long as you validate your assays, you can do all of these biomarkers on cytology. Now, it's becoming increasingly important to be able to do some of these actionable biomarkers. And it's also important that we know that when we're reporting a result as positive, that it's not a false positive. So you do have to keep in mind that we have to optimize the assay validated on the cytology specimen. And why is this important is because cytology actually has many different specimen preparations. And if I took a poll of this room of people who do cytology, there's probably going to be a whole multitude of different ways people process their specimens. And so anytime you have a change in the way you process your specimen, it's important to realize that that probably affects the biomarker testing. And as an example, there was a recent study, I mean, not that recent, but a few years back, that showed that when you alcohol fix your specimens, that can actually affect how your immunostains will work. So again, this is a guideline from the CAP that outlines how we validate our IHC assays, and whatever works for histologic specimens actually are also applicable to our cytology specimens. And just as illustrations, we have validated some of these actionable IHC markers on our cytology specimens. All right, so what about mutation assays? So again, not a secret, biomarker testing is standard of care in multiple solid tumors. And the advantage cytology has is the variety of specimen preparations that we have. So formalin fixation causes nuclear degradation. So having the option of a non-formalin fixed specimen preparation usually gives you the option of getting better quality DNA. In addition, cytology specimens usually are not decalcified. So again, you have the advantage of a better quality DNA. So when we used to do our mutational assays, when I was a fellow in training, we had a whole multitude of different platforms that around 2011, 2012 kind of converged into next-gen sequencing. The primary reason, it's a great assay, great analytic sensitivity. It also gives you the option of looking at multiple genes using the same platform. So in cytology around that time, there were a whole bunch of publications that came out showing the feasibility of doing next-gen sequencing, not just from cell block specimens, but from smears, and the fact that your non-formalin fixed tissue gave you better quality DNA. This was an excellent paper that was published from the Brigham that analyzed some of these quality matrix that showed that smears and liquid-based preparations gave you better quality DNA for next-gen sequencing. And then a study that we did at our institution that showed that cytology specimens were inherently enriched in tumor. They had higher tumor fraction that led to higher allelic frequencies. They had lower numbers of failed amplicons and better coverage. So let's move on to some of these factors that actually affect the tissue quality. So as I mentioned, there's multiple pre-analytics that might affect the success of testing. And shown here is kind of a timeline of from when we collect the specimen. We obviously have very little control over some of these pre-acquisition factors, but the the part about once we acquire the specimen, how we handle that specimen and process it plays a big role in how that specimen is going to behave when we do some of these tests. So again, there's multiple steps involved, and I'm going to go over some of these. And even though they're a sequential order of how we acquire the specimen, process it, and handle it for the testing, in reality, they're all kind of interconnected. And having that feedback loop where you provide feedback to the person who's acquiring the specimen, also to the person who's processing it and handling it, triaging the specimen, and how you interpret that specimen and how it affects the testing is critically important so that we have better success with these specimens. So let's look at the specimen acquisition, which is the first step. And the first step, of course, is getting an adequate sample. So again, if you have an adequate sample, chances your test is going to work are much higher. So start with an adequate sample. And what can we do to ensure that we have an adequate sample? Number one is the communication. So it's really important that there is communication between the oncologist who is ordering the test, the person who's performing the test, and the pathologist who's actually handling and processing this specimen. Number two is using image guidance. Again, if I know where the needle is going in, you are likely going to get a better sample, which is going to be adequate. And then optimizing the technique, because again, the skill and expertise of the operator plays a big role in terms of getting an adequate sample. What about on-site evaluation, which is something we can do on our FNA samples, which actually plays a really good, important role in getting an adequate sample. So we have a pathologist on site for all our FNA procedures, and what that enables us is, one, to ensure at the time of the procedure that we're getting an adequate sample. This has a bigger role in places where you're able to do testing from your smears, because the smears is probably the only thing that I can assess up front at the time of the procedure and tell the radiologist I have an adequate sample that's going to be enough for all the tests that I'm going to do. Yes, if you see tumor on your smears, you assume that what you're putting into the rinse is going to be adequate, has tumor, and you're going to get a good cell block, but that's not always the case. In a way, you have to modify your protocol depending on the institution that you're in and the lab practices. So if your molecular lab only tests from cell blocks, then once you know that you have tumor, try and do additional passes for the cell block so you are hoping to make a good cell block that's going to be adequate for the tests that are needed. However, if you're at a place where you have the advantage of using your smears for testing, which is kind of what we do at MD Anderson, we try and maximize everything on our smears because we know the smears are going to give us better quality DNA, and I can tell them at the time of the procedure that it's adequate. The other advantage we have with on-site assessment is the ability to triage the specimen. So depending on what I'm seeing, if I think it's a lymphoma, I can send it for flow, or I can send it for micro if I think that's what it is, and then triage it according to what I think is going to be requested. So looking at specimen processing, I mentioned before that cytology has the advantage of having a whole variety of different specimen preparations, and shown here are the most commonly used preparations for molecular testing. So you have your direct smears, your cell blocks, and your liquid base. And even though I'm showing 3 preparations, there is a whole bunch of different ways how we can process them. The multitude of collection media, the fixatives and the stains is mind-boggling. And again, when you have so much variety, there is a lot of variation in how these things perform downstream. So the important thing to realize is that there are quantitative and qualitative differences when you have a variety of processing techniques. And yes, that also includes cell blocks, because not everybody processes their formalin-fixed tissue in the same way. So here are some of the recommendations: that use 10% formalin, use a synthetic paraffin for the block, kind of optimize the time that you're going to fix your specimen. When you store your blocks, have optimize the humidity and temperature. And then when you're sending sections for testing, use fresh cut sections. Now, these are optimal conditions. Not every lab is processing things the same way. As far as the non-formalin fixed tissue, again, this was a great study that actually compared spray fixed samples versus air-dried, cytolite versus cyto-rich red and alcohol fixed. They even compared different mounting mediums. And the important thing is not what is better than the other, but really the fact that you have quantitative differences in DNA yield when you change some of these pre-analytic factors. At our institution, we also looked at different kinds of glass slides that give you different DNA yields. We looked at extraction methods, scraping versus a cell lifting technique. And again, there are differences in the DNA yield. And why is it important? Because the DNA yield is actually, it correlates with the success of molecular testing, which makes sense. You have a sample that has a better DNA yield, you're likely to get better success with your testing. So moving on to the specimen handling and selection of specimens for testing, the communication with the molecular lab is also important because you need to know, if you're sending a test to a lab, you need to know what their criteria for acceptance is. What is considered adequate? Are they going to use tumor enrichment? What kind of platform are they using? Because the sensitivity of the platform is directly linked to the specimen that you're sending. And when I talk about specimen adequacy assessment, there's two things that we're primarily interested in. One is the overall cellularity, which is the number of nucleated cells, because that translates to the DNA yield. And then the tumor cellularity, which is the fraction of tumor cells you have relative to all the other cells in the background. And this is really critical because this is what relates to the analytic sensitivity of your platform and whether you're going to run the risk of a false negative result. So when you look at all your specimen types, you can kind of categorize them into 4 different groups. So you have your high cellularity and high tumor fraction samples. These are usually never an issue. You can send them for testing. They will typically work. You have your low cellularity, low tumor fraction samples. Again, not an issue. These will probably not work, so most of these are canceled up front, never sent for testing. The low cellularity but high tumor fraction samples, so you pretty much everything you have is tumor, but there's either a lot of necrosis or it's just a paucicellular sample. These are an issue because these may fail the minimum DNA yield that you need for testing. So when you're sending a sample like this, you want to send adequate number of slides so you have the DNA that's needed to run the test. The tumor fraction is not really an issue here. But the most interesting ones are these, which are highly cellular, but they have a low tumor fraction. So there's tumor, but there's a lot of benign cells that might dilute the tumor content that you have. So the goal for this group is to try and push them into either one of these 2 groups here, where you try and enrich the sample for the tumor fraction. And so if you have a sample like this, where here's a cell block, and you have tumor, but it's scattered amongst a lot of benign cells. This is really difficult to enrich for tumor. But this is the same sample, this is the smear, and if you see this area here, and usually towards the edge of the smear, that's where you have a higher tumor fraction, you can circle that area and enrich that sample so you maximize the tumor fraction and you minimize the risk of a false negative result. So this is from a review paper that kind of summarizes all these pre-analytic factors that play a role in the molecular testing success. And then moving on to the last point that I wanted to make is, as the pathologists, we do have a really important role in ensuring that our specimens actually work for some of these biomarker tests. So as pathologists, we're trained to recognize the atypical cells. So when we look at a specimen, that's pretty much what we see. And it's very easy to ignore all the benign cells that are in the background. So here's a cell block section from an EBUS lymph node FNA. And as you can see, most of this specimen has a large number of lymphocytes. There is tumor. And so if you look in this area, a higher power, just look at how many lymphocytes you have in the background. The tumor fraction in this specific area is 30% at best. If you take the whole sample, it's super low. Now, this was an interesting case because this is just the H&E section from the cell block. It was sent for testing on 2 separate occasions because there were 2 different sets of genes that were requested. So the first pathologist circled this entire thing, which I already showed you has a very low tumor fraction, said 50% tumor, sent it for testing, and then it came back, and then they requested more markers, went to a separate pathologist who circled the whole thing again, said 20% tumor. So here's the results for the first test that was sent. They had requested for EGFR and I believe KRAS at that time. And so came back negative. What's interesting is this was actually done by Sanger sequencing because they had said tumor was 50%. The molecular lab had no way of knowing whether it was truly 50%. So the oncologist emailed the pathologist saying that that's really strange because this is a patient who has a known EGFR mutation. What happened here? And so it was resent, and fortunately this time they did NGS. It was sent as 20%, which I still think is probably not correct, but on the NGS they picked up the EGFR sensitizing mutation as well as a resistance mutation, which is what they were clinically suspicious of. So what I'm trying to say is that as the pathologist, we play an important role in ensuring that the tests that we're trying to perform are successful. So it's important to try and do a good job so we're not compromising patient care. And then I'd just like to finish up with a case example. Just to show you how we work up these cases on cytology. So this is, again, a lung adenocarcinoma. This was the core biopsy. And as you can see, I mean, there's really very little viable tumor in the core biopsy. So when the molecular test request came, it was deemed insufficient for testing. So at our institution, most of our tests are reflex to our surgical path specimens. If it's inadequate, we pull up the FNA specimen. Everything has a concurrent FNA. And so here's the cytology from the FNA. And so here are smears. We have a lot of tumor on the smears. This was a cell block, which also has a decent amount of tumor in it. And so this case is like a couple of years old. So this was the biomarker test request that we used to get at the time. We're doing some of these biomarkers by our fusion assay on NGS currently, but at the time we were doing everything by FISH or NGS and then immuno. So let's start with the immuno. So if we're doing an immuno-based test, we have a cell block that has a decent amount of tumors, so we can do our IHC on the cell block sections. PD-L1, you need about at least 100 tumor cells to be able to make an assessment. What about FISH? So same thing. We have tumor on the cell block, so we can do FISH on the cell block section. The advantage of cytology is if that cell block was inadequate, you could also do it on the smears. And the smears actually work really well. We use Diffquick stained air-dried smears, partly that's what we're validated for. And also the air-dried cells, the nuclei are really big. They're much bigger than the size of the nuclei you have on formalin-fixed tissue. So reading the signals is easier, and that's what our cytogenetics techs who actually screen these slides for us tell us, that they actually prefer the smears over the cell blocks. As far as the mutation analysis, you've got a multitude of options. You could do it off the smears, which again, any one of these areas on the smears, which are so three-dimensional, several thousand cells, you are probably going to be able to do whatever you need to do just based on one good smear. This looks crappy because the cover slip, it's been de-cover slipped, it's a pap stained slide, but what I just wanted to show you is that we had really good smears, and in this case, we actually send the smears for testing. You also could send sections from the formalin-fixed tissue. So there are multiple ways of working up a cytology case. It depends on the cellularity and the tumor fraction in the sample. And again, it also depends on the molecular lab and what they are validated for. Now, when I usually go around presenting, I mean, we're at an academic center where we have the advantage of doing our biomarkers on our non-formalin fixed tissue, which may not be the case everywhere. If you're sending it to a reference lab, they may be only validated for formalin fixed tissues. So it's important to communicate your needs to the molecular lab, emphasize the importance of, because when you restrict yourself just to the FFPE, you are probably going to be canceling a lot of tests that you could have done had you had the opportunity to use your smears. So the revised guidelines for the lung biomarkers has actually been a great help because there are more and more labs that are recognizing the need to validate on non-formalin fixed tissues. So the minute you open it up to the non-formalin fixed tissue, you realize that you're getting better DNA. You can actually get by with less amounts of DNA for your input, and you can increase the number of cases that you actually don't need to rebiopsy the patient because you don't have a core biopsy or a cell block. So just want to finish up with what I started, back to the golden circle, and the summary of what I just told you, the how we do it on cytology. So it's important to know that you can do most of these tests as long as you validate them, recognize the pre-analytic factors, and how, as the pathologist, we play a role in improving the success of our test. So thank you very much, and I don't know, are we doing questions?
You'll be here for the... Okay. Our next speaker comes to us from Brigham and Women's in Harvard, Dr. Neil Lindemann.
Thank you, Phil, and thank you, Bruce and Sanchita. I'm not used to being referred to as a giant. I'm not sure how to take that. I've been trying to lose weight. Actually, I have a young nephew who understandably has trouble pronouncing my name, and he just calls me Uncle Big Guy. So maybe I should be used to it. So this is me, and the other thing that I'd also like to mention is I have no conflicts of interest, and I want to thank Bruce for talking about the EGFR discovery. I was part of that team, actually, and but I want to thank you, Bruce, for protecting me from the patent claim and shielding me from the unwanted taint of royalty revenue streams that might cloud my judgment and make it impossible for me to give an impartial assessment of technology today. So thank you very much. I'm going to talk a little bit, my task today is to talk about next-gen sequencing in the context of precision oncology. And some of these talks are extremely technical, and I'm going to try not to do that. I have a few technical points, but I want to try and make this more of a practical sort of how-to kind of conversation. So we'll talk a little bit about where we are now and where the field is headed. And so the first thing I just would want to emphasize is that molecular pathology is kind of right in the middle of a big storm right now. And so we started this in academics by generating exciting new data and evidence that suggested that what the whole purpose of this meeting here today is sold out, right, which is that molecular biomarkers are important for patient care. And industry sort of seized on this as well and fanned the flame, if you will, and that includes both making the technology more accessible for more labs and also establishing commercial laboratories which offer excellent services. And yet at the same time, there are some forces that are kind of putting the brakes on this, and I know that there'll be some talks about regulation and reimbursement later, and that can't be understated. The insurance companies aren't quite sure they want to pay for this or should, and the government isn't quite sure if the way that it's been developing over the last few years is in fact the right way to do it. And we're just sort of right in the middle, right, with these forces telling us do more, do more, do more, and these other forces saying, well, we're not paying for it and you're not allowed to do it. And so it leaves us all, not just in pathology, but also in oncology and the patients, trying to figure out what we should do. And so, you know, the first question really to ask is there a clinical benefit to molecular diagnostics in cancer? Sure as heck hope so. But under what circumstances, right? Is it, and Bruce mentioned we sequence everyone at the Dana-Farber, but I'm not sure that that's standard practice around America. That's what the decision we've made for our cancer center. And then also, how big is that benefit, and should we pay for it? And this leads to what I've likened to sort of a fundamental conflict, not to get too philosophical here, between the principles of evidence-based medicine, right, which is you have to do a randomized control study of 1,000 patients in each arm to figure out what you're supposed to do, versus the precision medicine model, which in its philosophical underpinning says everyone is different. You are never going to find 1,000 people that are identical to put into your two arms. And so until we reconcile that, I think it's going to continue to spin around a little bit. All right, enough philosophy. So Bruce has already presented to you the story of EGFR mutation in lung cancer, and I think this, although precision oncology, it wasn't called that, and molecular biomarkers were on the map before that, particularly in the hematologic malignancies, I think EGFR and lung cancer really kind of changed the story because this was a really common lethal cancer. And on the right, I have a picture of one of our patients who responded in this dramatic way for 2.5 years, essentially, to erlotinib, and some data showing, essentially, if you look at this, this is from Tony Mock's IPASS study, very similar to the Maimondo study that Bruce showed, that in patients who have an EGFR mutation and they get an EGFR inhibitor, they do a heck of a lot better than those same patients who get chemo. Or, and this was the important thing, patients who don't have an EGFR mutation, right? And so that sort of laid the basis saying the testing needed to be done. You can't just give everyone an EGFR inhibitor and assume that they're going to respond. And this was corroborated by 4 more phase 3 trials over the next couple of years. But it doesn't stop with lung cancer, right? So here's a similar kind of data. It's a slightly smaller study, but essentially showing that in melanoma, if you give a patient who has a BRAF mutation in melanoma, a BRAF inhibitor, they do a heck of a lot better. And there's a very dramatic case example, again, from our center, sort of in the upper right, showing someone riddled with disease who clears. It's not a permanent cure, as Bruce explained, but it certainly is a temporizing, life-extending benefit. And it goes on, right? So you can look at similar studies looking at GI sarcoma, the GIST, and KIT mutations in response to therapy. Colon cancer and KRAS the other way around, right? So KRAS mutation indicates someone is not going to respond as well to a target inhibitor of EGFR in colon cancer. There's prognostic implications for IDH mutations in glioblastoma, and Bruce has already showed you the data about ALK and lung cancer. And there's more, right? So if you look at ovarian cancers, now we're looking at germline mutations, the BRCA, so not mutations that are acquired in the tumor. There's a significant difference in response to PARP inhibitors. In leukemias, there's multiple markers, right? FLT3, NPM, IDH, I've just showed you some of them, giving you a complex matrix of outcomes. Some have targeted therapies, some are simply prognostic. The decision whether or not to give someone a bone marrow transplant or to treat them with more conservative management, all based on molecular markers. And then, as was alluded, this concept of all cancers and the total mutational load, and just looking at how many mutations there are across a relatively large spectrum of genomic space can determine whether or not those patients are likely or not likely to benefit from immunomodulatory therapies. And we are getting to the point where this kind of testing actually maybe should be done for all cancer patients, at least in advanced stage. Okay, so that's sort of the why of this, and I think this is a term I've made up, so my apologies to my oncology friends, but it's sort of a real change in oncology over the last 2 decades. Rather than give a nonspecific cytotoxic therapy that targets all replicating cells, like a cytotoxic chemotherapy, and it has high toxicity, low efficacy, and you sort of hope that the tumor gets killed by the agent before the rest of the patient's cells do, to this sort of more new wave approach. We're looking at specific molecular alterations that are driving the cancer biology and targeting those, right, to get more effective therapy with less toxicity. And the key to all of this is the molecular classification. And so here, just sort of looking at this in one last slide, sort of showing, and this is a study that also Bruce was a part of, multi-center, multi-marker study. This wasn't next-gen sequencing, but the idea was the same, looking at 14 biomarkers and then driving patients who had an alteration in one of those biomarkers to a targeted therapy. And you see 3 survival curves. The folks who had a mutation that could be targeted and got the targeted therapy in the orange line did a heck of a lot better than the other groups, which are the 2 blues, whether they had a mutation or they had a mutation for which there was no therapy. And what we're trying to do as a sort of global goal is to move everyone to that orange line. And then, as Bruce was saying, make the drugs even better so that orange line gets farther and farther out. Okay, so that's why we're doing this. Now, next question is sort of what to test, and so Bruce has done a good job already of laying out all the mutations in lung cancer that I'm going to fly through since it's sort of redundant, but it's a very similar diagram here. So you see these pie wedges. Red is EGFR, the light blue is KRAS. We unfortunately still can't do anything about that. And then all of these other subtypes in increasingly smaller proportions. This slide is from 2012, right? So it's 6 years later, it's getting even more and more. So that orange group, the ones where we don't have a marker, is getting smaller and smaller. But one of the things that we do have is what I liken to sort of an evidence regression, right? So the EGFR was approved with multiple phase 3 randomized controlled trials. ALK2 was actually approved by phase 2 trial, and it was response rate rather than overall survival. And then as we get smaller and smaller, as we get into smaller subsets, it gets harder and harder to make a large study, and we're making decisions based on case reports and animal models and cell lines. And at what point, if we're offering a diagnostic service, do we draw the line and say, this is what we're going to test, and this is what we're not? And there's a continuum here. It's not a clear line. And the list goes on and on. Here's 7 more markers, whoops. And that's only adenocarcinoma. There's other markers in squamous carcinoma. Haven't really panned out so much in clinic, but certainly there's cell lines and a few case reports that have been provocative. And I'm still only talking about lung cancer, and I'm only talking about DNA, okay? So the point is, this is really getting big. And the distinction between clinical care and research, what is exploratory and what is ready for practice, is kind of, this is a wall that's kind of broken, right? And you can decide which of these you prefer to be. So that's enough philosophy. I guess I'm going to get into a little bit now, sort of just how to go about this. Okay, and so there's lots and lots of genes. And the first question is, do you look at them one at a time, okay, or do you kind of bring in a large-scale panel test? And since I already told you what I'm here to talk about, you know what my answer is, but we'll go through it logically. What are the benefits of single gene assays? And there are some, and they shouldn't be understated. First of all, we're good at them, right? They're kind of easy. They're fast. They're cheap. You get a pretty clear answer. There's a band or there isn't a band. There's not a lot of, you don't need a team of computational biologists to help you figure out if there's something there or not. It's a manageable volume of data, and they're easy to report. And I wouldn't just chuck single gene assays, and we actually still run 31 of them in our lab. But that's the whole point, right? We have to run 31 of them. And so doing this sequentially ends up taking a long time, and it uses up material. And so that's where the problem comes in. And so, for example, if you look on the right, and I don't expect you to read it, the point is our requisition in 2008, our requisition in 2013. I hesitate to even show you what it looks like in now because it doesn't even fit on a page anymore. But the number of single gene tests is just proliferating, right? That on the left is a very simple little diagram of how we handled a lung cancer biopsy a few years ago. And as you can see, there's a whole bunch of tests and yeses and nos, and trying to route things to what was the most efficient from a cost perspective way of doing it. But in the end, this took a lot of time, and just keeping it in your head is a problem, so that knowing how to route things through the system. So we did only the tests we needed to and not the ones we didn't. And then finally, as I mentioned, and has been mentioned before by Sanchita, the samples are getting small. Well, they're not getting smaller, but they're small. And so the failure rate is pretty high for us anyway, when you get below about 2 millimeters in greatest limited dimension. And a lot of those samples are in that size range. And so if you start trying to do 7 or 8 assays with a tiny little biopsy, you're going to end up sending the patient back, and no one really wants that. So these are the liabilities of single gene assays. And the reason that there's an alternative is the new technology, which is next generation sequencing. And that has really kind of changed the way we do things. And I have to say, I've been in molecular diagnostics for a long time now, and it is a field that is highly prone to fads. And I can remember walking down the aisles of USCAP in the 90s, and everybody had their red greenograms and their microarrays showing how that was going to transform medicine and everything was going to change. And it just didn't happen. And there have been waves of other ones. And so the question really is this a fad too? And I really don't think so. This actually, I think, really is a change. Not I think, I know it's a change. And probably the best way to liken it is, to me, it's the difference between digital data processing in sound and imaging versus analog. And the traditional way we did things was analog. You put all your DNA molecules together, and then what you see or hear is the harmonious blend of all the mutations that might be there. But if you want to hear the second oboe, good luck, right? You're just hearing the whole orchestra playing. And it sounds nice, okay, but with next-generation sequencing, it's digital, right? So you can hone in on every single instrument if you want to and figure them out. You can still recombine them and get that harmonious blend, but you have the capability to zoom in on every individual unit of data that's in the sample, and the power of that is tremendous when you deal with cancer, which is a very heterogeneous problem, if you will. And so I don't think it's going to go away for that reason. And I'll just leave it at that. Okay, so when you're actually trying to do this in reality and set it up, you have a couple of simple things, and I like to make things limited down to 3 choices because I can't even count all the fingers on my hand. So the first thing you got to decide is how much you're going to sequence. Second thing, you're going to have to decide how are you going to do it, which is this library preparation business. And then the third and the last is the technical platform. And so many people focus on the boxes first and then figure out what to do with them, and that's completely the wrong way to go about this. My strong advice for anyone who isn't doing this already and is thinking about it is to decide what it is you want to do first and then find the right way to do it rather than the other way around, despite our lovely vendors outside who are going to want to sell you their equipment. Okay, so the first thing you got to answer is why not just sequence everything? We have the capability to do it. We could do a whole genome in a reasonable amount of time for a reasonable amount of money. It's kind of staggering to say this, right? Because it's inconceivable when I got into the field that you could do this, but you can, okay? So what's wrong with sequencing everything? So the first thing to understand is you get what's called lower coverage, which is the amount of sequences that you get at each position of the genome. And so when that happens, your ability to recognize true signal from noise goes away. This is less of an issue for germline, where you're looking at inherited mutations in DNA, where the DNA is kind of the same everywhere, but for heterogeneous samples like cancer, it's a catastrophic problem. Okay? And so what would happen is you'd be unable to really assess subpopulations to distinguish the malignant cells from the benign cells unless you have a ton of malignant cells. And then within that malignant cell population, you'd have trouble finding subpopulations, which is really important in the context of resistance and changes of the cancer over time. This will improve. So I don't want anyone to think that whole genome sequencing is dead. It's just not practical today. I have no doubt, especially with some of the single cell technology that's being pushed and developed, that this will take over in the future. But right now, Number 2, too much information. So yeah, there's 3 billion nucleotides. How much time are you going to spend on each one? There's not enough time in your life, right? Even if you spend a second on each of them. So it takes a really long time to do this, and storing the data actually becomes, just having the file becomes a legitimate expense. Again, that will change over time, but right now. And you just can't put as many samples through. So if you're trying to take care of a whole cancer center, you're just physically not capable of interpreting all of this data. It's just going to end up stored somewhere when someone someday will get around to it, and believe me, no one's going to get around to it. Okay. So how much to sequence? Short of it is you have to make this decision of what's right for your cancer center. How much of what's actionable versus the cost and throughput. So if you want to just focus on the things you know today you need for standard of care, you can do that with a relatively small targeted panel of somewhere between 50 and 100 genes, and you can take care of most of the applications. If you're in a research institute like we are, that's not good enough, right? And so you're going to look for several hundred genes about the things that are definitely actionable as well as the things that are plausibly actionable, the things we think we're going to need, and we change our menu every year to try and stay ahead of where the new developments are. And if you're just sort of infinite in resources and capability and have all the time in the world, you could sequence everything. Just a little note on the right is sort of looking at this concept of tumor mutational burden, which has really changed this a little bit, and the notion that if you need that as well, there's a certain amount of genetic material you need to sequence to be accurate. And so you see 3 lines and looking at how close the whole exome is to your targeted panel as a function of how many genes are on that panel. And the sweet spot seems to be a sort of the low 100 number of genes. And as you get below that, as you move from red to green to blue, you lose the ability to actually assess the tumor mutational burden if your panel gets too small. So that may change a few things. Okay. Number 2, this is the technical part. I threatened it, and it's true. All right, so what kind of library are you going to do? These are gross simplifications, so no one please come throw a stick at me for saying, you can't do this with that kind of technology. But in general, you have basically one choice, right, which is, are you going to do a hybrid capture approach where you capture a sequence with hybridization probes that recognize the targets you're interested in, and you need lots and lots of them? But then you can do a simple PCR, one PCR, okay, to amplify them all. The other approach is what's called amplicon sequencing, where you actually make PCR primers for every target you're doing. Okay, so now you're doing multiple PCR reactions all together. Basic rule. It's easier to combine a single molecule reaction like hybridization than to combine lots of PCR reactions. PCR is more squirrely than hybridization. Blah, 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 blah. What does that mean? That means if you add a whole bunch of PCR reactions together in the same conditions, they're not going to be as efficient, and their numbers of what you get from each of them are going to be more distorted. And so the consequence of that is that with an amplicon sequencing approach, your ability to really rely on copy number assessments changes a little bit. Now, I know there's sort of ways you can do it, so I don't mean to be completely generalizing, but that's the generalization. What is good about amplicon sequencing? It's a lot quicker, right? Much fewer steps, you get much higher coverage, but you're limited to smaller targets. So now you have your model, right? I know I need to do a relatively small number of targets, and I want it quick. That's an amplicon sequencing assay. We do that for our leukemia patients. And so we have a smaller panel. We call it the rapid heme panel. Terrible name, but that's what we call it. But that's so we can get our AML patients, we can get them results within 3 to 4 days. Big panel, you have lots of questions. It's a combination of doing some investigative work as well as some clinical work. Yeah, you want it quick, but you don't need it in 4 days. You could get it in 2 weeks, say. All right, so now you're looking at a hybrid capture panel, and that's what we do for most of our solid tumors. And we turn that around in about 10 to 12 days. Is okay? All right. And then the last thing is the box, and I'm not even going to get into that because this is I have no conflicts of interest, I'll remind you, but different ones have strengths and weaknesses for different approaches, and I'll just leave it at that. Last thing, which is sort of a new thing for us, is the question of whether to pair or not to pair, and how to correct for germline alterations. So the thing you need to understand, of course, is yeah, you've got mutations in your cancer, and then all your, it's hopefully understood, but all your normal cells have DNA in there too. And Sanchita talked about how all the normal DNA can make it hard to find tumor alterations. That's totally true. Sorry, I sounded like a Valley girl there, but yeah, it's very true, right? My wife is a Valley girl. But, and so are all her friends. But the other thing is, there can be mutations in the germline, and when you're mixing them all together, you don't know necessarily what you're looking at, right? So is the mutation that you think is important, is it in the cancer cells only, or is it in every cell? Sometimes when it's in every cell, it matters. Sometimes when it isn't, it doesn't. And so there's ways to do that. In a tumor-only model, right, which is what we do and what several other reference labs do and other academic labs, you use a population-based assessment of the germline. And so you use databases that have been compiled of hundreds of thousands of normal people who have given their DNA over the years, and you just pull out everything that's seen in those people above a certain percent. Okay? And then you can modify this a little bit by, there are some cancer mutations that kick around, so you pull those back out. And then you reconcile that, at least is what we do, with the tumor percentage that we see by microscope and the allele fraction to try and figure this out. And you can do that at high throughput, and it doesn't cost much, but it's not perfect, and some error cuts through. Okay? As opposed to, I'm going to sample the tumor and a normal sample from the same patient at the same time, and I'm going to subtract one from the other. And that's a patient-specific control, and that will be accurate, okay? But it costs twice as much. And then you have to always watch out if your normal sample is from blood, that there might be some circulating tumor DNA, which I know people will talk about later, and so then you don't want to subtract out the pathogenic mutation that's in the blood. And then there's some other, you have to watch out for transplant recipients and things like that. And it can be operationally difficult. It's a decision to make. I'll say again, choosing the platform is the easy part to all of this, right? Dealing with all of these other issues, which I know are going to be discussed over the course of the weekend, and I won't get into all of it, but every one of these is a real concern. I'll save just a minute or two for math. I'm not a good mathematician. I'm sorry. The computational needs are more than what you think they're going to be. So if you think they're going to be infinite, it's like infinity plus 3. The OncoPanel, which is the name of our test, generates about 30 million sequences per sample. Although I am a molecular pathologist, I'm also a trained surgical pathologist, and I'm used to this being the operational detection system. And this cannot look at 30 million sequences of DNA, right? Physically incapable of reviewing them with my own eyes. So we have to have scalable, automated informatics processes that take the raw output from these instruments and resolves them into something that I can use these two eyes on, okay? And the thing to understand, first of all, is that there's different kinds of informatics folks in the world. And just like you don't want an endocrinologist doing a C-section, you don't want a web developer developing your computational algorithm to process your pipeline, right? Or pipeline. So there are all these different skill sets, and you can't do this with one person. I run into people sometimes who say, I got a guy. I got a computer guy, I can do my precision oncology. And I'm like, no, that's like saying you've got a doctor and you can now have a hospital. It doesn't work that way. The other thing to watch out for is there's a lot of people who've taught themselves to do some really slick tricks with computers. And I don't think they're actually dishonest. I think they actually don't know what they don't know. And if you don't really know what they're doing, you can really go down the wrong path. So just be careful. Okay, so how can things go wrong? And I promise I'm almost done. So you can always have pre-analytical problems, right? You can mix up your samples, you can label things wrong. That can always happen. It's important to have processes in place to check that, just like anything else that happens anywhere in a clinical laboratory. It's not unique to molecular. And then we've heard a little bit of chat about problems with fixation. Metallic fixatives happen to be a problem, so avoid zinc and mercury and things like that. Acid, right, the unbuffered formalin, what happens is it oxidizes to formic acid over time. So if you don't change it quickly, your tissue is sitting in acid, just like the decal. And the Boolean solution, acid breaks DNA, and now you're screwed. Okay. And then actually formalin introduces an artifact, which is kind of interesting. The analytics are actually surprisingly robust. It's pretty amazing for anyone who sort of lived through the transition from, Sanger to NextGen to it works. It's kind of incredible, actually. The devices work, the equipment works, the data comes off, it's clean. There are a couple of phenomena that occur. There's a couple of specific kinds of artifacts that you see, but you can kind of get around those once you recognize them. This is not the big problem. This is the big problem. It's informatics. The post-analytic analysis is the major source of error. And I won't get into all the details, but essentially you have either a commercial package that you're buying, okay, or you have a guy, or you have a team. And what that guy or team or package is doing is taking all that data, aligning it to the reference genome, okay, figuring out what is normal, what is not, throwing out noise, okay, and there's the problem, throwing out the noise, and then giving you the mutations to view. And if it's a robot, right, so it doesn't know signal from noise. So you have to configure it to say how much of the sequence has to match the reference for it to keep. This is the aligner setting. And if the package or the guy or the team doesn't understand what you're trying to do, right, they're going to throw out mutations that you want to see, or they'll retain things that you don't want to see, or both, right? And so it's really important if you're directing the lab or the program to have a dialogue with the guy or the team or the people who make the software to figure out how you can optimize it for what you're trying to accomplish, because you can go horribly wrong. Well, I'm sorry, being melodramatic. You can go wrong. Then there's other things that we all have to deal with, annotation and nomenclature and a couple of funny little things. But I think the big thing is sort of making sure your aligner works the way you want it to. And then, as I mentioned before, that interpretation piece, knowing when you're looking at something that's in the tumor versus something that's in every cell in the sample, and how are you going to know the answers to those questions? Okay, very quickly, just a word about money. I know there'll be talk about that. There is none. It is possible to burn a tremendous amount of money on this. Bruce told you how much through the largesse of the Dana-Farber they spend every year to keep this going. We have been trying for 7 years to gain some measure of financial self-sustenance, and I think we have achieved a very, very little in that time. A little, not nothing, not my initials, NIL, but not much. Okay. there's lots of ways to build this. I think there's going to be a talk for later, so I won't go into the details of it. Just to give you a rough idea, right? The test costs us somewhere around $2,000 a sample between directs and indirects. The reimbursement is about $600 when we get paid. So we're losing a fair amount of money every time, but as they say, we make it up in volume. A word about regulation. The government's against us. So I've never been called a traitor before. This goes with giant. So recently, the FDA approved one commercial lab. I guess, in the interest of maintaining my innocence, I won't say who they are or anything or whether they're good or bad. But one lab has been approved as a companion diagnostic, and one academic lab has been cleared not as a companion diagnostic. And that sounds like wordsmithing, but the short of it is the clearance as a non-companion diagnostic means they won't get paid based on a CMS decision, and the only group that will be paid is what's approved by FDA. And that's been proposed for a number of years, and there's been a lot of hue and cry about it, and in the end, that's the case. And so people say, well, who cares? Well, we can't keep doing this if we don't get paid, right? And anyway, okay. So I guess I'll just leave you with this question, whether or not this is, in fact, all a fad or not. I really don't think so. There's a lot of data that shows that there are significant clinical decisions that have real ramifications for patients based on the application of this technology, and it continues to grow with new things, and I guess fads grow too, but I don't think it's phony. A lot of people to acknowledge, and I can't name them all, but these are the groups of folks here not here, for us back home in Boston that have helped develop our program or move it forward, and I guess we're not having questions, so that's it. Whoops. And here are slides I'm not going to get to, which about like what we do.
Dr. Lindemann is not only a giant in this field, he's a very humble giant. He is, by unanimous vote, our leader on the lung cancer guidelines. So he is one of my many bosses. I think for 1 second, if Chris Ventura and the College of American Pathologists guideline people are here, if they can wave their hands or stand up or something just for 1 second. I know you're here. There. Yeah. Yeah, so there are a lot of us who work with them here today. Dr. Dara Eisner comes to us from the University of Colorado. She is going to speak on an extremely important topic that covers all of everything that we're discussing today. This is about the golden rule. Who has the gold rules? Dr. Eisner.
Thank you very much. Sanchita and I are about the same height, and she stood back here. I really can't stand standing behind a podium because I feel like I'm so short that just my eyes peek out over the top. So I'm going to come out here to talk to everybody. I'm going to talk to you today about regulatory and reimbursement issues, and I think I could probably just sit down because Neil just summed it up, right? There is no money, and the government wants to end our show. So, okay, I'm done, thanks. All right, no, really. Okay, I do have disclosures. I am tainted by corporate money. Here are the corporate monies that I am associated with, so recognize that this is the case, and we'll move on from there. Briefly, before I get to my disclaimers, I will mention that Neil did say something about tumor mutation burden. If you're more interested in tumor mutation burden, I'm going to put a little plug out for tonight's symposium, the CME Dinner Symposium, in which we will be talking more about TMB. So I am speaking on behalf of myself. I've got slides here from professional societies with which I work. I borrowed them. These are still my opinions. I like giving talks with pictures. I really do. I'm a pathologist. These eyeballs are really, they're the center of my world. But this talk just doesn't happen to have a lot of pictures. I apologize. And hold on to your seats, because what I'm going to talk about here is really just the tip of the iceberg. And if you want to know more, I can point you to all kinds of resources. But this is really, truly just the tip of the iceberg. So I'm going to start off by showing you my final slide from 2016, when I gave a talk about this very topic a couple years ago. And I basically said, wah, wah, I'm a molecular pathologist in 2016. So we're going to see today if we feel any differently about this. Okay, so I'm going to start off with a brief history just to catch you up to where we are now. In 1976, the Medical Device Amendments to the Food, Drug, and Cosmetics Act gave the FDA the authority to regulate medical devices. Now, FDA has maintained from the outset that diagnostic assays are medical devices, like a pacemaker and an artificial hip. And this, therefore, it stays. They say, well, a diagnostic assay is a device. We have the authority to regulate them. And what they have done historically is exercised what they call enforcement discretion. That means, hey, we've just decided we're not going to tackle this, electively so. We maintain the right to at any time, but today, no. But in 2010, they announced that they would be ending enforcement discretion for laboratory testing, and they would start actively looking to regulate it. So I made this fun little timeline. So that was in June of 2010. They announced their intention to regulate. You have to fast forward. It took them 4 years to put together their draft. That was in October of 2014. They issued their draft to say, this is what it's going to look like. A few months later, they had a workshop where many of us came and gave fiery opinions. And then shortly after that, a group called the Diagnostic Test Working Group released their proposal for regulation of what they call in vitro clinical tests. This is going to be important. We'll come back to this. Okay. Later on in the same year, AMP, the Association for Molecular Pathology, with, an organization with which I work closely, issued their counter-proposal, which was essentially, hey, why don't we just update CLIA? There were a series of hearings on the Hill. And then what was the big thing in November 2016? I'm pretty sure it was the AMP meeting in Charlotte, November. I can't think of anything else that happened in November 16. Oh, wait, yes, there was something else. Okay, so approximately 1.5 weeks after our election in 2016, the FDA said, you know what, we're going to put a hold on this. So following this, the FDA issued a discussion paper on LDTs. That was in January of last year. And then in March of that year, there was a release of a discussion draft of a bill called DIA, and that's what we're going to talk about in a couple minutes. And then just a few weeks ago, the FDA released their technical assessment of DIA. Okay, so DIA, the Diagnostic Accuracy and Innovation Act. This is proposed by across the aisle between Representatives DeGette and Bouchon. It proposes a whole new center at FDA. It takes all of clinical laboratory testing and it puts them together into a single category called IVCTs, in vitro clinical tests. It would treat all IVCTs the same, whether it's a boxed and shipped kit, whether it's a single laboratory doing something at a single site, whether it's something that somebody like I or Neil assemble, generate, validate, and quality control in our laboratory. It also removes the authority from CMS and CLIA related to test development and validation and puts it squarely in the realm of FDA. So CLIA would be configured to really be about laboratory operations only. So from the 30,000-foot perspective, what this means is that the first stage of putting together a test is at the FDA stage. And then for the day-to-day operational issues, do you check your thermometers every day? That's what CLIA would be about. Okay, now, one of the issues that I have with this, that I share with AMP, is that this treats LDPs and IVDs the same, even though they are fundamentally different. So there are huge differences in the risks associated with how you think about these two different approaches to testing, but it says there's going to be a single regulatory pathway for all of it. I'm not going to go through this whole thing because I think for anybody who's paid any attention to this, it's kind of woo, wrong way. There we go. Do I have a laser pointer? Aha, I do have a laser pointer. Okay, so the major issues here that I want to point out, though, is that IVDs, a box I can buy, is a medical product, right? An LDP that I design to make in my lab, I consider to be a medical service, right? And then there's a lot of things in here, and I believe you guys will get the slides. I apologize they weren't up last night. But there are lots of differences between an IVD and an LDP. And it makes sense to me that something that a manufacturer is going to make and ship out for another lab to use should have some lockdown on it. That makes some sense, right? But As a laboratorian who designs and develops tests, I don't know that the risk that I bring to the table for that situation is the same as a kit that comes to me. Okay, so this is schematically what the proposal ultimately does, is it takes the existing regulations for IVDs, the things that are currently FDA-approved boxed and shipped kits, like the FDA-approved COBAS assays or the TheraScreen assays or the SurePaths of the world or the HPV tests of the world, and it reduces the regulatory barriers for those, simultaneously increasing the regulatory barriers for LDPs. This, in the speak of Washington, is the leveling of the playing field, right? I'm not sure I agree with that. I think this is in large part driven by the manufacturers of these things, right? Because, hey, this got easier, this got harder. Where do we think adoption is going to drive? Okay, I want to take a brief tangent to just go over some FDA terms. They're going to come up a couple times. They came up a little bit in the last lecture. FDA approval is called a pre-market authorization, or a PMA, and it is a review process for a high-risk, FDA speak is class 3 device. FDA clearance, for reasons I have not been able to figure out, are called a 510K. I don't know where 510K came from, but that's just what it is, and that's what we all know it to be. And this is based on equivalency to a predicate device. So in order to think about a 510K pathway, there has to be something that's already on the market that has a PMA that you can show that you are functionally equivalent to, right? So you can't get to the level of clearance without having something that you're comparing to. Okay, so let's go back to DIA, the potential impact on laboratories. Biggest thing is that it would treat laboratories as product developers, not as healthcare professionals, but as product developers. So we would have additional liabilities and constraints. The other really big issue, this is a lot of words, blah, 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 blah. That's what it means, right? The obstacles and burdens to comply with what the FDA wants us to do will put the vast majority of us out of business, right? And we will consolidate the entire laboratory operations of this country into 3 to 5 laboratories. Now, the other piece here, that's the other part of the money piece, right? The other part of this is that the FDA views this very differently. So they would be subject, laboratory developed tests would be subject to several development and production quality requirements. This is part of the idea that we would be product developers and manufacturers, right? So I'm just going to give you one example of how the FDA views this. The FDA has this thing they call QS elements, which is for quality systems. So I put the big question marks there because the first time I heard of this, I was like, what? What are you talking about? I don't know what this is. This is not how, as a physician, I was trained to think. This is not how, as a laboratorian, I was trained to think. This is manufacturing speak, right? So the example here is design controls. This is what design controls mean. Now, again, I did not learn to think this way. And if you look at this chart, and I'm not going to go through it in detail, it would make sense to you that if you want to make an artificial hip, that maybe you want to start off with defining your user needs and then getting design input and then establishing a design process and and then iterating the process and then iterating it again and then iterating it again. And you can't really get started until you've gone through your design validation and all of these things, right? Is that how I think about putting together a clinical test? No. I go, what genes do I need to target? What probes do I need to buy to target those genes? Do the probes have the appropriate amount of homology, right? There's some discrete steps that I do in terms of thinking about design, but it's not this. This is not really how we think about it. Okay. Now, I did mention that the FDA just came back with their technical assessment. So what does that mean? Deguette and Bouchon said, this is going to impact the FDA pretty significantly. We should get their opinion. So the bill sponsors sent the bill to the FDA with a request for a technical assessment. And this is designed for the FDA to comment on feasibility, timelines, costs. What do we think about what this does for us as the FDA? The FDA responded literally just a few weeks ago. It was the beginning of August. And their language, their response, in a completely unprecedented way, was not to comment on the existing bill, but it was to write new legislative language. Now, I don't know about you, but that's kind of unusual. And to put it into context, what makes it unusual is that the FDA, Commissioner Gottlieb, has previously said in public forums that he did not want to approach this unless there was a mandate in the form of legislation. Well, they just wrote the legislation that they want to create a mandate behind. Okay, so the stakeholders had a whole 2 weeks to respond to this entirely new proposal, and it was done entirely within the offices of DeGette and Bouchon. And so just a couple weeks ago was a meeting with key stakeholders at a congressional office to get a further explanation. So there's still a lot of unknown about this, but let's talk a little bit about FDA's legislative proposal. It proposes a single pathway for IVDs and LDPs, as I just mentioned before. So that part's not a departure from DIA. It does create a pathway for laboratories to become what they call pre-certified. If you can prove to the FDA that your lab is awesome, they don't have to ask you to submit something about every single test. They're talking about grandfathering existing tests. They're talking about a 2-risk pathway, high risk, low risk, and they will require post-market review to look for adverse events related to testing. This sounds great, right? They just came up with some great ideas. Pre-certification. This will not apply to anything that is classified as high risk. Now, we are here at the Cancer Biomarkers Conference. Let's take a guess as to whether or not any cancer biomarker will be classified as low risk. No. There is almost certainly going to be overlap with CLIA. It's going to be aligned with CLIA and CAP in that they're going to set it up on a 2-year rotating cycle. So again, very significant overlap. And if you are a laboratory that performs any high-risk testing, or LDPs, you will not be eligible for a third party to be the pre-certification agency for you. LDP implementing laboratories will be considered manufacturers, and this is truly frightening. First of all, they're going to say that these laboratories are now considered to be engaged in interstate commerce. I don't even know how to wrap my head around that. But the most frightening thing to me is that you can't discuss any off-label use. Now, think about when a drug rep goes to visit a doc, and they're allowed to talk about this drug is approved for this, right? And they are expressly prohibited from talking about any off-label use as part of promotional speech regulation, right? We would be subject to the same consideration. So if I somehow, through the great grace of mathematics, physics, and money, get an assay FDA approved, which that's a pretty big leap right there, and let's say I get a BRAF assay approved for melanoma and colon cancer, I would be expressly forbidden from having a discussion about the utility of that assay outside of anything I had it approved for. Whew! I find that to be incredibly, incredibly concerning, because my job as a molecular pathologist is not to rubber stamp a BRAF report. Right? My job as a molecular pathologist is to say, what do I think this BRAF means in the context of what I see on the slide and what I know about the patient? Now, Erdheim-Chester is a good example because we know BRAF mutations happen in Erdheim-Chester. But in this situation, I wouldn't even be able to be allowed to have a conversation with a clinician that says, oh, yes, we can try our test on your patient with Erdheim-Chester disease. Or, oh, yes, I think this test might give you some useful information. They do have a process for exempting what they're calling manual tests. They put IHC in this category. I think this is to appease all the anatomic pathologists, right? Ooh, don't worry. You don't have to worry about this for every IHC you do. Whew, big sigh of relief, right? But recognize that there are FDA-approved IHC assays, so the door has been opened for this paradigm to follow suit. Okay, next steps. I'm not going to go through this. The bottom line is that it's bouncing around the halls of Congress. There is no equivalent Senate version right now. In this current political climate, I don't think this bill is going to get approved. But this has truly set the stage for where I think we could be going. And it would be one thing if I thought this was just bouncing around in an echo chamber, but I'd like to show you comments from Commissioner Gottlieb from just a few days ago. So at a Friends of Cancer Research workshop in Washington, D.C. just a couple days ago, he said, first, we should have a consistent approach for all in vitro clinical tests. He's using language directly out of the legislation there. Our approach needs to be the same, whether the test developer is a traditional manufacturer or a clinical laboratory. The FDA is gearing up to do this. Okay, so that's it for DIA. Just a quick side. last time I was here, and you may have heard that the FDA was working on guidances related specifically to the regulation of next-generation sequencing. They did publish 2 guidances that they consider to be final. This was in April of last year. They're easy to look up. One is about standards for design, development, and analytical validation of next-generation sequencing-based tests. The other is about the use of public databases to create clinical validity assertions. These are all easily accessible. The way these were written were entirely about germline testing. So, but it's likely they would apply. Okay. Now, Neil said he wasn't going to mention the name of the company. I'm not going to have any way around it. So we're just going to get right out in the open here. I think pretty much everyone in this room knows that Foundation Medicine received an FDA approval combined with a CMS coverage determination. And this is where I say regulatory fund meets reimbursement fund. Come on. Okay. So I want to remind you that this is an approval, right? So coming back to this language I was talking about approval versus clearance. And I don't know if anyone from Foundation is in the room. I'm not trying to pick on a company. I think this is illustrative of how the process is working, and that's how I'm using this. And also, if anyone from Foundation's in the room and I say something wrong, please tell me. Okay, so from what I can tell from reading all the public documentation, the companion diagnostic claims for the FDA approval were based on comparability studies to existing FDA-approved assays. The non-companion diagnostic claims were based on comparability to an unidentified methodology. And there's language in both the FDA approval and the parallel CMS review about an FDA-approved report. That gets my hackles up because I feel like that's specifically the FDA getting into the practice of medicine, which they're not supposed to do. Okay, so we're back to FDA cleared versus approved. I've already talked about this. I'm not going to read all this to you, but approved, again, is high risk, and cleared is predicate device. And Neil already hinted at this. FDA cleared devices generally are not eligible for a companion diagnostic indication. We'll let that sink in a second. So think about the fact that Memorial Sloan Kettering had their lovely impact assay FDA cleared through the New York State pathway, which is new. The fact that they are cleared means that they cannot get a companion diagnostic indication, right? You have to be FDA approved to get a companion diagnostic indication. The FDA will come back to me, and CMS will come back to me and say, oh, but there's a new assay that's class 2 that got a companion diagnostic indication. It's a real-time PCR assay for BCR-ABL. It's not next-generation sequencing. There was no predicate device. I'm not really sure what happened. But generally speaking, and I've spoken with the FDA, all solid tumor biomarkers are considered high risk. Once they're considered high risk, you cannot get the CDX indication without full approval. Okay, so that's where we are. You having fun yet? All right. Let's move on to reimbursement. Okay, so how many people here know that reimbursement works in this patchwork of Medicare claims across the country? Yeah, this tends to be relatively underappreciated knowledge. So Medicare is administered through this patchwork of contractors called MACs. And each jurisdiction has the authority to oversee the practice in their region specifically, right? The exception is when there's a national level determination that overrides. So when you read papers about regional disparities in healthcare, some of it is because truly there are regional disparities in healthcare, right? Some of it is because we have set up a system where we're making decisions at this level. Okay, so I'm really going to focus on Medicare coverage. I'm not really going to focus on private payer coverage, but coverage for is basically the determination of whether and what stipulations are placed on whether or not service is paid for. Medicare's bar is reasonable and necessary, and there are 2 ways that Medicare considers how to pay for something. One is called national coverage determinations, NCDs. One is called local coverage determinations, LCDs. Okay, so this is the very easy way that LCDs are generated and responded to, right? Makes a lot of sense. I will not belabor this except to say that Medicare starts with a question, should we cover X? And they write a draft, and then there's all of these people who get to weigh in, and it's kind of a back and forth process. That's clear as mud, right? So the CAP recently proposed legislation that's moving through Congress. It's called the Local Coverage Determination Clarification Act of 2017. It's designed to improve transparency in the LCD process. And one example of how this might be achieved is clearer references to the evidence used to make determinations. So often in the LCD process, we get an LCD, and they say, this is what we learned from the evidence, but they don't tell us what evidence they cited. Unfortunately, the two things that I think are the most relevant for molecular diagnostics already got carved out of the bill. One is MolDX, which is one of the national administrators for molecular testing, was carved out from these rules. So these rules will not apply to MolDX. And the requirement that LCDs could not be carbon copied across jurisdiction was squashed. Now, what that means is that when one jurisdiction puts some effort in, or doesn't, other MACs sometimes just copy-paste them and deploy them, right? But by statute, each jurisdiction is supposed to do its own analysis. Okay, now, I'm not going to talk about a lot of the mechanics of how billing and reimbursement works, because I think that for people who aren't working in a molecular lab, the mechanics of what code do I bill and everything is less relevant than this. So for NGS, which is really the mainstay of what most of us do most of the time now, there is really no uniform way to bill for this. So unlike EGFR, where we now know there's a specific CPT code, if you do an EGFR test, you bill the EGFR code. For panels, there's huge diversity in how that gets billed. So some of the Medicare administrator contractors require the use of panel codes. So these are the codes that were generated specifically to be able to bill for NGS panels. So they require that you use them, but they probably won't pay them, right? Anybody who is in a MolDX region, and if you go back to that map, certain MACs are affiliated with a program called MolDX. They require the use of the NOS code 81479, which is kind of the garbage bag of all things molecular. But in order to do that, you have to go through MolDX. You have to submit your assay to MolDX, have them review your assay, submit your validation data, and if they're okay with it, they'll give you a Z code. And some MACs require that panel codes not be used and that you should stack the individual analyte. So if I run NGS for colon cancer, then I should bill for KRAS, BRAF, and NRAS. Okay, so then there's national coverage determinations. Again, clear as mud. And importantly, there's this newish entity called the NCDs and parallel review process. So it started as a pilot program in 2010. It's since become permanent. And it's a collaborative effort between Medicare and FDA that's designed to streamline between submitting for FDA review and getting a payment determination. The criteria on the FDA side and the CMS side are not altered. So it's not like they drop the bar, but it's designed to streamline and create connectivity. And an FDA marketing approval does not guarantee a favorable coverage decision. So now we're going to come back to Foundation Medicine. Again, not picking on a company. They did what they were supposed to do. They submitted their test. They got reviewed, right? So they submitted their Foundation 1 CDX assay as part of the parallel review process. And what came out of that with the FDA approval was the proposed national coverage determination. And it essentially had three major pieces to it. One is that it proposed full coverage for all FDA-approved companion diagnostic NGS tests. Number two is it said, oh, well, if you don't have an FDA-approved test, then you can get payment through this mechanism called CED, coverage with evidence development, but it has all of these other stipulations on them. And then they said statutorily, every other NGS assay out there will be denied. Okay, so as you can imagine, that didn't go over super well in the molecular community. There were about 315 comments submitted to the Federal Register. The majority of the comments expressed concern. So let's just do a quick quiz. Here, Medicare payment revision to policies under the PFS, the physician fee schedule. Guess how many comments came in on that one? What do you want to guess? About 15,000, right? This goes up there on like the lots of comments range. Cranes and derricks in construction, and OSHA. More or less? 721 comments. I don't even know what a derrick is, but 721 people commented on cranes and derricks. And then we got some flounder, scup, and black sea bass fisheries. That was 37, right? So to my view, this is the pecking order. We're somewhere between cranes and derricks and flounder. Okay, so the main issues with the draft, I'm not going to go through all of this. Again, you guys are going to get my slides. But the couple of things that really stand out. One is that the NCD was written around NGS, right? NGS is a technology, not a test. And it's very much unprecedented that a national coverage determination would be issued that covers an entire technology, right? So it's a very strange way of looking at things. And then, as you could gather from what I just showed you, the scope went well beyond the coverage of Foundation 1. Deciding to cover Foundation 1 and deciding not to cover everything else, those are kind of unrelated, right? There's a lot else in here. And if you're really bored, you can go and find the Federal Register and read the 315 comments. Okay, so the NCD was finalized in March, and they did make some significant changes. In general, I would say that things got a little bit better, but I also think that there's a phenomena here that if you tell everybody how bad it's going to be, and then it's only kind of bad, everybody's relieved, right? So the devil really, really is in the details. The most important thing that came out of the amount of pushback, though, is that the NCD remains in place, but they have left a mechanism for the local Medicare contractors to continue to identify their own coverage policies for non-FDA-approved NGS assays. Okay, so this is the final NCD. Again, easily accessible online. You'll get these slides. A couple of little bits about it. One is that in the final NCD, they said that the patient cannot have been previously tested using the same NGS test for the same primary diagnosis of cancer or repeat testing using the same NGS test, right? Well, we just heard from Bruce Johnson that there's lots of good indications for asking questions after people have regressed on a therapy. So this is not very forward-looking in terms of where we think the field is going to go. Now, here's the part that gets tricky, and this is what I was coming back to before. The final NCD says that the diagnostic laboratory has to have FDA approval or clearance as a companion CDX, right? Now, I'm not sure what happened here, but there is no companion diagnostic as clearance, right? So really, you have to have full FDA approval to get that CDX, which is part of this NCD. The test has to have an FDA-approved or cleared indication for use in that patient's cancer, and the results have to be provided to the patient using a report template to specify treatment options. And that's another thing that we could spend some time talking about, because I'm not sure that that's something that should be regulated. Okay, so what does this mean for labs? Oh, okay, submitting a 510K isn't that bad. It's $10,000, not $250,000. It's a lower bar. I'll just do that, right? But as I just explained, I have heard from the FDA, and this is pretty well known in the molecular community, that for all of the things we're going to talk about today, the EGFRs, the BRAFs, the MSIs, all of those things, all of those will be considered high risk. And that means by definition, you cannot get a CDX indication without getting a full approval, which means that you will never be eligible for payment under that national coverage determination. So MSK did a huge amount of work to get FDA cleared, and it does not move them 1 inch closer to coverage under this national coverage determination. There is no effective route to payment based on this, except to use a prepackaged FDA-approved test. And there is one, and that takes you back to all of those IVD versus LDP issues, right? If I bring in that one FDA-approved test and I want to make changes, well, now I'm back to the drawing board. There are many more things I didn't touch on here. PAMA, oh my God, PAMA. MolDX, a whole program. PLA codes. New York State Department of Health is a third-party reviewer. This is really, I'm still at tip of the iceberg here, I promise. Okay, so here's my poll. Are we still in Debbie Downer mode? Am I Mona neutral? Oh, well, I guess we'll wait and see. I was trying to think of somebody who's perennially happy, so I picked Dolly Parton. Hey, y'all, it's going to work out great. All right, how many for, we're going to start from the bottom. How many for C? Yeah. How many for B? That's where I was when I started making this, but by the end, I'm at A. How many at A? All right. Thank you very, very much for the opportunity to speak. I owe particular debts to Tara Burke, who's the Director of Public Policy and Advocacy at AMP, and Eric Connick for helping me with these slides.
So over 80% of pathologists are in community practice and have to face issues with biomarker testing every day. We have today the head of the largest pathology system in Houston, Dr. Richard Brown, the Memorial Hermann System. Dr. Brown?
Thank you, and good morning. I'm incredibly honored to be asked to speak to this very august group, and as they said with Monty Python, now for something entirely different. So what we're going to talk about really are the practical issues, the challenges that happen in the community when we look at biomarker testing for individual patients. And although I have all those titles over there on the right, I am, in fact, a practicing community pathologist, have been at one of the larger Memorial Hermann hospitals for over 20 years. And so deal with these issues on a day-to-day basis. So I wanted to start with kind of a worst-case scenario, kind of what we want to avoid happening, but unfortunately happens all too commonly. So patient X undergoes a needle biopsy for a presumed lung cancer. Pathologist orders some IHC, maybe some levels to support a diagnosis, finally arrives at a diagnosis of primary adenocarcinoma of the lung. Patient then undergoes staging procedures and seeks opinions from surgical, radiation, and medical oncologists. That can take weeks to happen. And then 4 to 6 weeks after diagnosis, pathology receives a request from the oncologist for EGFR mutation, ALK, and ROS1 testing. And so that's performed. Well, the patient subsequently goes and seeks a second opinion from another oncologist. This oncologist feels that that workup wasn't complete, so feels a need to, quote, complete the workup. He decides that complete workup from him includes MET studies and PD-L1. All of the studies are negative, and that's not uncommon in our system. And so then the patient begins standard agent chemotherapy. 6 months later, they've showed minimal response. And so now that patient's referred to a comprehensive cancer center. They request the tissue block so that they can do NGS studies, look for a possible target for clinical trial eligibility. And at that point, insufficient tissue remains in the block. So we have basically squandered this patient's tissue and hindered them from ultimately getting the treatment they need long down the road. And so I just wanted to frame the discussion kind of with that, and we'll look at some of the issues that we deal with and hopefully some ways that we can ameliorate those issues and challenges. So just to talk about where I am, I don't think that we are unique in community practice. We're just bigger. So Memorial Hermann is a large multi-hospital system here in Houston. We have 9 acute care community hospitals, 7 of which are accredited by the Commission on Cancer as cancer centers. And of course, we also have a very large accredited academic medical center that includes both the TMC campus for adults and the Children's Hospital. We saw last year a little over 7,000 new cancers diagnosed, and over 12,000 patients were seen. It's estimated that we have over 800 physicians who in some way impact the cancer program at Memorial Hermann. So you can just imagine in that scenario how many opportunities there are for non-standardized care, for multiple requests for tissue from the same patient, and so forth. And so these are our challenges. They're not ours alone, but of most community practices. We're lucky in that as Memorial Hermann, we have a governance through a system-level oncology service line who makes some decisions in terms of what happens and what doesn't in the oncology program, and also an integrated network cancer committee, and I serve as the pathology representative on that committee. So we do have some opportunity at the system level for standardization. So what do we do for biomarker testing? Well, even though we're big, our in-house biomarker testing is relatively rudimentary. So in-house at our large core laboratory, we do ERPR and HER2 immunohistochemistry on all newly diagnosed breast cancers. And we do MMR IHC for all newly diagnosed colorectal and endometrial cancers, not as a predictive marker, but rather for Lynch screening. All other biomarker testing is performed only when requested by the treating physician. So we don't have any other panels, standard approaches, whatever. That's all we do as a standing order for every patient. And the other thing that is not unique to us, but is certainly different from the academic medical centers, is that we have, 90+% of all of our biomarker testing is referred out to a reference laboratory. And so basically our approach is that, the oncologist then gives us the order for the testing, specifically what they want. We send the tissue block or the hematopathology specimen to the system contracted reference laboratory, and we do have one primary laboratory. And we insist on having a pathologist review before that happens. And the pathologist review is for two things. One is to review the appropriateness of testing, have a communication with the oncologist if there's something that is clearly not appropriate. And then secondly, to review the available specimen for adequacy. And those result in sometimes difficult conversations. We always honor requests for patient material from other reference laboratories. So, standard scenario where the request comes not from the patient, not from the oncologist, but from the laboratory who has a relationship with the oncologist. We honor those requests provided that the laboratory has patient billing specified, because we don't have a relationship with those laboratories. But we don't say, no, you can't have it, it has to go to our lab. So with that framework, let's talk about some of the challenges with biomarker testing in community practice. So first, lack of consensus. As you can imagine, when you have, as we do, 3 large community practice oncology groups, all with multiple providers, and those are just the big ones. There are lots of 1 and 2 doc operations as well. They all had different training. They all read different papers. And so without some governing body to say, let's get together and talk about what is standard for our patients, you can imagine that there is a great lack of consensus. And that's a real challenge, leads to that scenario I gave you at the beginning. The second one, I think, is something we don't pay enough attention to. Every hospital laboratory director, every CEO has their favorite reference laboratory they deal with, but that is not necessarily the optimal reference laboratory for biomarker testing. And so that's something that we as pathologists really need to take probably a harder look at than we actually do. Specimen stewardship is a huge issue. In our practice, the vast majority of our oncology patients known to be clinically advanced are going to have a needle biopsy from interventional radiology. They're very good. They provide multiple, very generous cores, but there's only so much of them to go around. So we have to be really careful about how that tissue is used. And then the other thing in a huge multi-facility, multiple physician practice like ours is avoiding delays in care. So many handoffs can happen, so many things that fall through the cracks potentially. We really have to be very diligent about looking for ways to expedite care. So we're going to talk about each of these in turn and some approaches that have been in the literature, other hospital systems have used, and we've used to some extent in our system. And then at the end, I want to kind of share with you the Holy Grail as I see it for how we might make this work in community practice. So first, achieving consensus and standardization. So first of all, our most successful strategy has been using clinical guidelines, because it's hard to get in a room and an oncologist argue against an NCCN guideline. I want to do this. Well, no, they say you shouldn't. So we've been very successful with the guidelines for lung cancer, the NCCN guidelines by tumor site, and that has probably done more for us in terms of standardizing testing, getting consensus than anything else. To the extent that you can, developing a test formulary is very useful. And we do have a hematology-oncology steering group within our physician organization. Not that widely represented, doesn't obviously represent all of the practices, but it is a place to start. And so one thing that group did with me early on is we agreed that multiple gene NGS testing the big panels are not going to be part of our routine formulary. Not that they lack worth, but it's just that most of our patients who get treated with a very limited number of drugs don't need them unless they're going to go on clinical trials. So we agreed early on that testing would not be done up front unless there was a potential for that patient to go on clinical trial. And equally important, if you're going to develop a formulary and standardized test panels, you need to have some mechanism for gatekeeper function, if you will. Someone who says, you didn't abide by what we agreed upon, why not? And there may be a good reason for it, or there may not. Unfortunately, in our system, that very frequently falls to the pathologist, and I don't think we're necessarily unique in that. Ideally, there would be a utilization management review on the back end that would deal with that in a perhaps more effective and comprehensive manner, and certainly keep us out of the hot seat. So reference laboratories, I think that, again, the pathologist is really key here because, we're the only ones who can bring to the conversation in a laboratory setting what is and is not likely to be acceptable and useful for biomarker testing. They might be great for doing chemistry, they might be great for doing immunology, but not necessarily so for what we're sending. Obviously, accreditation is a given. In a hospital laboratory setting like we're in, any laboratory you send to has to be accredited. Comprehensive test menu is essential. And as we'll talk about with stewardship of tissue, we really, most of the time, get one shot. And so we really need to send our tissue to a place that's going to be able to do everything we need to have done all at once. And so, there are wonderful laboratories in this city that do Sanger sequencing on genes A, B, and C, but if that's all they do, that's not going to be a good solution for me. Appropriately validated tests. It's amazing how certainly laboratory administrators treat these laboratories as a black box, and certainly with regard to biomarker testing. So what is the clinical validation? What is the technical validation for each of the assays that we're going to be sending to that laboratory? Really important, not only to assure ourselves that our patients are getting the best answer, but also important because we really need to have the conversation with the oncologist about the likelihood of false negatives, the likelihood of success in whatever specimen we're going to send. Adequate turnaround times is a given. As you all know, we have now guidelines that say, by and large, 10 days is the upper limit of what you would want to have as a turnaround time for certainly a molecular test. And so we need to be cognizant of that when we send to a reference laboratory. And one of the things I think that we as community pathologists, unless you've really had some specialized training, been at a cancer center and training and so forth, probably don't have very much knowledge of is having a conversation about the accuracy of the results. How do we optimize that? And Dr. Chowdhury talked earlier about the tumor to noise ratio, if you will, and that becomes really important in a lot of our specimens. And so, it's often a very difficult conversation to have with the oncologist about, well, why won't you send this? Well, I won't send this because I don't think you're going to get the right answer. But to do that, to have that conversation, we need to know from the laboratory, number one, what do they do for enhancement? What a microdissection on every case? What is their threshold for a QNS and why? These kinds of things don't come up unless you specifically ask. And finally, one of the things that has been a big challenge for us is interfacing with the LAS and the EMR. I mean, these are biomarker testing results are typically complex, and trying to replicate those in an addendum report or something that a transcriptionist is typing is not going to work. Yes, we can scan, yes, we can fax, we can do all of those things, but a direct interface from the laboratory into the EMR is the optimal approach. So these are all things that enter into or should enter into decisions about selection and evaluation of reference laboratories. I don't think they always do, and that's part of the challenge. Okay, stewardship. Probably for me as a pathologist, the single most important thing, to make sure that that one needle biopsy from that patient can get everything that it needs. And so, first of all, intraprocedural assessment is very important. We need to be on the front end of the case saying, this is what we need, and anything less is not going to serve the patient. And again, that's sometimes a difficult conversation. So normally our interventional radiology colleagues are very good about this. They understand the need. They understand about how much tumor can be in a needle biopsy or not and how much is needed. They get all of that. So our colleagues are wonderful. We don't have to have that conversation with them. We do sometimes have to have the conversation intraoperatively with a surgeon who's going in to pluck some nodules from a carcinomatosis of the abdomen, and we need enough tissue not only to make a diagnosis, but to perform all the biomarker testing. And they don't sometimes, it looks really big to them through the laparoscope, but it's not. So we have to be very diligent about insisting that we have that. And again, as Dr. Todd alluded to earlier, we do have the opportunity for cytology specimens to be part of the process, and that's particularly important there because we really have to give them guidance as to whether the specimen's adequately cellular. When I started practice, you got multiple levels on needle biopsies because you wanted to make sure you could make a diagnosis, and that was up front on every case. Well, we think differently now. So in the realm of biomarker testing, the right thing to do is to get one fully surfaced cut and look at that and then decide what you need to do. And we need to be judicious about everything: recuts, special stains, immunohistochemistry. Try to minimize to the lowest level we can to make a diagnosis so that adequate tissue remains. We have been successful with judicious use of unstained sections in needle biopsy specimens. And one thing we would never want to do, of course, is ask for 20 unstained sections on every single needle biopsy that comes through the lab. That would be a disaster. But if, for example, a needle biopsy is seen by the pathologist, they know it's cancer, and now it's going back for an IHC diagnosis to kind of hone that in. Is it squamous? Is it adeno? Is it primary? Is it metastatic? At that point, one could certainly obtain the additional unstained slides so that if, in the process, that tumor is largely gone at the other end, you have something now that is already in the box. You don't have to go back to the block and retrim it. And then for us, as I alluded to earlier with the choice of a laboratory, really we have one shot most of the time if we're going to do the right thing. And so really initial application of immunostain, FISH, and particularly NGS all at once has been our most successful approach. So for lung cancer, we now do everything that is recommended in the guideline up front, including a limited site-specific NGS panel according to the guideline. And so, yes, that may be useful information. No, it may not. But, we have one shot at it. And so we don't want to be doing just EGFR and, a bunch of FISH and immunohistochemistry tests, and then we go back and there's nothing left. So this has been very successful for us, particularly with the high sensitivity of NGS in these very limited specimens. And again, the goal is for us to get to a point where we have achieved 100% knowledge of any result that can be immediately actionable for that patient. Maybe not something that may be actionable in 6 months or a year, but what's actionable now. That's our goal. Avoiding delays in care. And boy, this is a big one. It's amazing how long these patients can bounce about before they finally get to the point that they are ready to have definitive therapy, particularly if it's targeted therapy. And so expedited diagnosis by the pathologist, obviously, is a given, but it is not so easy in some community practices. We're lucky to have a very large core laboratory with 150 immunohistochemical stains. We can get to a diagnosis in most cases pretty rapidly. Somebody who has to send out their immunostains, not so much. So we have to be very diligent about that because that really starts the clock ticking, and it's very easy to have that first step really slow the pace. There needs to be some way for that patient to get through all of those stages we talked about, through seeing all the appropriate oncologists, radiation oncologists, surgeon, whoever they need to see, and decide what stage they are and what they need in a very expedited manner. And that's where we, I think, really, in our system at least, fall down. It's very, very difficult to do that unless you have somebody guiding the case. And for us, there are two mechanisms that work very well: presenting patients at multidisciplinary tumor boards, even if they don't have an oncologist assigned, right after diagnosis, so we can get to what stage are they, what do they need, who do they need to see. And then involvement of nurse navigators for us has been a great success, because they're like bird dogs. I mean, they make sure that patient gets what they need, sees who they need, make sure the pathologist sends what they need to send. Standing orders. So for biomarker testing, that's a two-edged sword, because you really don't want to have a standing order for biomarker testing in every patient with one diagnosis, as if it were one size fits all, because then you lose potentially the opportunity to do another study that may be more important down the road. So for us, a standing order would only potentially happen for someone who is determined to be ready for targeted therapy. They are a candidate based on stage, clinical, how well they're doing. Short of that, we do not have standing orders. So, I've been under a lot of pressure for years for lung cancers to do a standard, EGFR ALK for every case. No, I've really resisted that, because there's a good chance that you're going to waste the tissue and not get to the answer you need. Because for us, in 2017, our ALK and ROS rate was 0. So, you really have to think about where the answer is. Protocols for expedited referral of specimens to reference labs, something we don't think about very often, but again, the pathologist is key to that. We need to have in place protocols so that when the order hits the door, we have a block going out that same day. And that's the process we use. Immediately upon an oncologist's order, the slides get pulled, we review the slides, select the specimen, the block goes out by courier that day. So very easy to let these sit around and take care of your slides that you need to sign out that day. But this is always a priority. And I've said it over and over, but it is the central theme. Engagement of the pathologist is the key to success in all of this. And really, on the front end and on the back end. So we really need to be there. We need to be the champion saying, boy, you really need to get this doc to do this kind of biopsy, because that's where the money is. You need to biopsy that organ versus that one, because we think that's where we'll get the best answer. We need to look at the specimen adequacy and then decide what we can or can't have success in doing in terms of biomarker testing. And again, as I said earlier, that's sometimes a difficult conversation with the oncologist, who just thinks, well, you've got a biopsy, why can't you send it? Why isn't that going to work? So, all of that said, here's my nirvana. Here's what I hope will happen at our institution, and I have actually proposed this to our Network Cancer Committee as a clinical goal for 2019, this very process. And it incorporates much of what we just talked about. So on the front end, we convene a multidisciplinary work group that will determine, if you will, standard panels of biomarker tests. What do we think we can do that would give us the most actionable results all in one shot? And we can agree that that's what we would do up front, and we don't have to have a lot of debate about it. Once we've decided that, and I think that's possible for some organ systems and not so much for others, lung it's certainly possible, colon, then we do standing orders for those, but only in the context of demonstrated eligibility for target therapy. So typically, high-stage disease. Not everybody who has an adenocarcinoma who turns out to be operable. No, only those who are eligible for targeted therapy. And that we, as pathologists, are then authorized through the Network Cancer Committee and Medical Executive Committee approval to send that designated panel upon diagnosis to the reference laboratory. Now, the challenge here, as I said, is to identifying those eligible patients, right? And you really need a mechanism to expedite that. And we talked about how tumor boards and nurse navigators can be a great way to do that. And then at that point, we send the tissue out, or the heme path specimen, whatever it is, in an expedited manner. And again, if we have unstaged tissues already cut, that expedites the whole process. We can send those. It makes it quicker and easier for the laboratory doing the staining or molecular assay. And then most importantly, we really need somebody who is going to look after this whole process. Not only when cases that are not approved get done, but rather as new tests and guidelines come out, that we revise our recommendations. And then finally, to look at all cases in which biomarker testing was unsuccessful. What did we do wrong? Why was it that patient didn't have adequate tissue to get everything done they needed to have done? So this is what I hope will happen. I would be interested in hearing at the break and during lunch from some of you who are further down this road how it goes, and look forward to speaking with you. And again, thank you very much for the opportunity to share this with you.
So Dr. Brown actually a few decades ago worked at Houston Methodist Hospital, where he was chief of our immunohistochemistry, and also was my partner in lung pathology. Dr. Brown is quite an excellent lung pathologist. And speaking of people who are excellent in lung pathology who left Houston Methodist to go work with the Memorial Hermann system, and Dr. Ross Miller also has a somewhat shorter history and more recent history. Dr. Miller will introduce our next couple of speakers. Dr. Lindemann is a giant in the field. Dr. Miller is a giant.
My brother's taller than me. He is my younger brother, but not my little brother by any means. Pleasure for me to introduce our next speaker. Dr. Terry Longacre is a professor of pathology at Stanford, and she is going to talk to us about biomarker testing in endometrial cancer. Dr. Longacre.
Thank you. This is the second time I've been asked to speak at this conference. The first time, I think it was largely because I had just come off writing the CAP recommendations for endometrial cancer biomarker testing, and so I will go over that again. As for this time, I'm not really sure. There was a mention about Woodstock, and somebody told me once I looked like Joni Mitchell, so maybe that's why I'm here, for the Woodstock theme. I do have a couple of disclosures. One is that there's not a huge amount of updated information on endometrial cancer biomarker testing. There's a few new things that I'm going to hit on towards the end of my talk. And the second one's probably the more important one. I do work as a advisor for Merck. That is on the paperwork. It's not on my slide. So anyway, as I mentioned, I was sort of headed up the CAP biomarker reporting committee, and these were all the other partners in crime that are responsible for our suggestions on reporting on endometrial cancer. What we did is we sat around and discussed for well over a year which markers we thought were relevant, not necessarily mandated, but relevant and in a utility in a large number of labs, not just academic labs. And we ultimately settled on these particular markers. I'm going to go through all of them. There was a reasonable amount of discussion of HER2, which at the time was thought not to be ready for prime time. I'll circle back towards that at the end. So I'm basically just going to go through these rather quickly. Hormone receptor status is, although there's no outcome-driven consensus opinions about the utility of this in endometrial cancer, unlike breast carcinoma, many of the treating clinicians continue to request these markers in order to predict response to endocrine therapy in endometrial carcinoma. In absence of any other robust data, we settled on recommending using the similar format of reporting for breast cancer. And as I mentioned, this is not a mandatory test or necessarily an NCCN indicated guideline. The assay validation should be done with positive and negative controls, with internal and external both controls, and of course formalin fixed paraffin embedded sections. Already, the utility of doing this in endometrial cancer is not as, or it's not as well, I guess, organized as in breast cancer. Certainly if you do these tests on endometrial biopsies or curettages, you've got a very good chance of having well-fixed tissue. More often than not, we're performing these studies on hysterectomy specimens, and as anybody in the room who does much pathology, general pathology or GYN pathology, those uteri sit around in the refrigerator. They're not opened right away, and they're not necessarily fixed as well or as optimally as you would like them to be in breast cancer. These were our reporting sort of results for ER and progesterone testing, and I'm not going to spend a whole lot of time going over them, other than to say we settled on the fact that a negative would be less than 1%, as was suggested or is used in the breast cancer reporting. Again, this is out of uniformity. There's not a lot of data supporting that. We recommended a number of positive cells and intensity, just as in breast tissue, and this is basically our reporting format. This is the way we would do it at Stanford, and I think that most centers do something very similar to that with breast cancer. Mismatch repair testing, I'm going to spend a little bit more time on. It's obviously been initially developed to evaluate for Lynch syndrome, but it's become a lot more sort of mainstream because it can be utilized for identifying patients who may respond for PD-L1 inhibitor. PD-L1 therapy. Again, this is not a mandated test, but it is used fairly routinely in many laboratories. We just heard the last speaker saying that they use this as a routine test in their laboratory. It certainly is in ours and all endometrial cancers. And in fact, we do it on all GI cancers, not even just colorectal carcinomas anymore. Again, this requires assay validation, formalin fixed paraffin embedded sections. In general, any positive reaction in nuclei of the tumor cells is considered intact or normal expression. I've heard some speakers say they require 5%. I'm not sure what that's based on, other than a comfort level that they really are interpreting a positive nucleus as being positive. I don't know of good data saying you have to have a 5%. Intact staining can be patchy, though, and so if you have a small specimen, which we do often test on our cytology specimens at Stanford, you just have to keep in mind loss of expression on a scanty sample may be an erroneous result. If you have intact nuclear expression on a scanty sample and you know you're looking at tumor cells, you're probably okay. The options, again, intact, staining, loss of nuclear expression, and cannot be determined, and then you explain why. And again, we sort of, piggybacked on the colorectal cancer CAP reporting templates, and that's basically how we report out our mismatch repair in endometrial cancer. Before I go on, I want to go back. How do you go back on this? I don't know how to go. Somebody else was going back before. I think I got it, though, didn't I? Yeah. This is really what I wanted to talk about, is really quickly, is the interpretation results. I don't have a lot of pictures, but this is a very straightforward test. It's nice, strong nuclear staining when it works and when it's strong and crisp, but there can be issues. MSH6 can be very heterogeneous. You need to evaluate large areas of the tumor to be certain that you have or do not have expression. It can be lost during chemotherapy or at least muted. So again, it can be even more difficult if the patient's had neoadjuvant therapy. This is a bigger problem in colon cancer than it is in GYN, but every once in a while, when we're evaluating our ovarian tumors, we see a problem with that. Some of these tumors can have massive numbers of tumor-infiltrating lymphocytes, and you can erroneously interpret these as positive. Even experienced people doing this have on occasion slipped and said, well, done a preliminary read as intact, when in fact, really, it's just the lymphocytes that are positive. You can have a nuclear sort of speckled pattern. I wish I'd brought a picture of that. That is an artifact. That's not a representative of intact expression. You can get zonal loss. And this tends to occur more frequently in endometrial cancers than most of the other cancers that I've evaluated. And it's usually due to some focal epigenetic methylation, usually of MLH1. And again, so if you're using your mismatch repair apparatus to identify patients who might respond to PD-1 inhibitor therapy, and you encounter a case with zonal loss, that patient may not respond as well as those patients who really do have defective mismatch repair apparatus. I think I've just gone over that. I think everybody in the room knows now there's 4 key patterns of loss. I'm just going to go over a few of them. This is an example of a clear cell carcinoma, and this is the MLH1, and as you can see, it's very nicely strong nuclear staining. PMS2, very clear. See, when they work, it's easy. Anybody can read them. It's when they're not so straightforward that you can run into problems. Here's one where this particular example has loss of MSH2. These arrows are pointing to the normal internal control. You absolutely have to have normal internal control to interpret these stains. You cannot interpret them if all you have is tumor nuclei. And every once in a while we'll get into tumor, not usually endometrial cancer. We've had a couple of adrenal cortical carcinomas they've asked us to stain. And if you don't have normal tissue, loss of expression cannot be interpreted. You really have to have that control, because it could just be a fixation or preservation. And here again is MSH6, and again the arrows are pointing out to the normal stromal nuclei are positive. So this is an example of loss of expression of mismatch repair proteins MSH2 and 6. And then see comment. We have a very long comment about what this may or may not mean in terms of Lynch, and as well as in terms of possible response to checkpoint inhibitor therapy. Here's an example of MSH6 loss, which is much more common in endometrial carcinoma than colorectal carcinoma. And again, you could argue there's no internal control, but if you look very, very carefully, some of those nuclei in the stroma are positive. But we see this really quite frequently in endometrial cancer and not so common in GI. Here's yet another example of an endometrioid cancer where it's got isolated loss of PMS2, and this is the way it would be reported. Here's a nice example of an undifferentiated endometrial carcinoma that's lost expression of MLH1 and PMS2, and it's very clearly lost, and you've got nice internal nuclear control. The reason I put this in is to emphasize that loss of MLH1 and PMS2 in the GYN tract is followed up completely differently than in the colon. Colon, you can do BRAF mutation. That's a sort of surrogate or stand-in for promoter methylation. That is not the case in endometrial carcinoma. You really have to do promoter methylation analysis. And it's reported out as positive, negative, or cannot be determined. Unlike colon cancer, the vast majority of endometrial cancers that have lost expression of MLH1 are usually due to methylation. That's a very small subset that actually have an underlying germline abnormality. MSI testing can be used alternatively, and it can be also used to triage patients for checkpoint inhibitor therapy. Again, it's not mandatory. There are two major methods. There's the NIH recommended panel, and then there's the ProMega. We use the ProMega, and that's simply because it utilizes more mononucleotide markers and decreases the likelihood that you're going to get a low microsatellite unstable result. And I think everybody knows this. The problems, of course, if you don't, and we've already heard about this, is insufficient tumor cell nuclei, and we did do our own little study of pathologists' ability to estimate tumor cellularity, and we found exactly the same results. For some reason, we overestimate tumor. It can be a problem in the colon, not so much in endometrial cancers, but every once in a while we get a mucinous endometrioid cancer, and if you have a lot of mucin, you can have insufficient tumor cell nuclei. And early on, when we were setting up these studies at Stanford, I got several calls back from the molecular lab saying, your report's wrong, because we'd read out a loss of protein expression because it's microsatellite stable. And then I would go back and I'd pull the case and I would see there's like tons and tons of mucin. I'd say, well, you probably didn't get enough nuclei. It also may not identify the MSH6 protein deficient cases. And remember, I just said earlier that MSH6 is a big player in endometrial carcinoma. And so we jettisoned our MSI tests fairly early on in the course of doing our mismatch repair MS/MSI workup, because we found that the only cases that the PCR were picking up were cases that were fixation problems. So we'd get cases from the outside labs that, for whatever reason, our immunostains didn't work very well, and then we would have to triage them to molecular lab. But they were not identifying any cases that we could not identify on immunohistochemistry. Enough of that. P53 immunohistochemistry has used a lot in GYN pathology. We're using it almost routinely now. Very rarely, at least for me, for tumor typing. I think that there's some real issues with that. Not all, there's a variety of histologic types of endometrial cancer that can express P53, and I don't think there is a direct one-to-one correlation. It is being used more for prognostic and possibly treatment purposes, although again, this is not mandatory and not necessarily indicated. I'm going to come back to that in a minute when I talk about some of the TCGA data. We recommend, at least the CAP, that these be read out as normal, and there's a lot of discussion about, do you say wild type, normal? We settled on normal expression, abnormal, strong diffuse overexpression, and we settled at a pretty high bar, greater than 90%. And then abnormal null expression, which is complete loss of expression, because you can see both patterns in tumors that have underlying P53 mutations, or, of course, cannot be determined. Now, this is all predicated on having really well-fixed tissue. So if you have a nice biopsy or a curettage, that 90% cutoff is a reasonable thing, I think. Some people say, well, 80. I think 80, every once in a while, if you start reading off in some of your moderately stained nuclei, you may overinterpret a specimen as abnormal when it's not. If, however, you're looking at a hysterectomy specimen, this greater than 90% may not be as useful because, again, as I mentioned, the fixation problem. So we were constantly, when we're doing endometrial pathology, trying to read these stains and in their percentages and their strength, factoring in where's that tissue been, what part of that tumor has got the best antigen preservation. As you know, P53 can be expressed it should be expressed at low levels in normal tissue, but sometimes you can see it very highly expressed under conditions of cellular damage or repair. Here's normal endometrium, just to show you. That's a reasonable amount. That's just normal. There you go again. And there's varying patterns of staining. You have some really dark and then some very faint. This is abnormal. This is a uterine serous cancer. It's very strong, dark staining in greater than 90% of the lesional nuclei, and that's an abnormal, strong, positive pattern. Here's a null pattern. This is another serous carcinoma, and you can see the background nuclei are kind of express some degree of staining, but the tumor cells are all completely negative. Again, you have to have internal control to read out a null background. Now, for the next little bit, I do want to talk about HER2 positive immunohistochemistry. This is new news. This is, as I mentioned when we did our CAP recommendations for tumor reporting, HER2 was not, there were some studies showing that there was some response to some cases of uterine serous carcinoma to Herceptin, but it wasn't clear how you identified them. In this past year, the Yale group did a fairly nice It's a small study, but it made a big splash, big enough that the NCCN is going to come out with recommendations that all endometrial cancers, at least endometrial uterine serous carcinomas that are either present at high stage or recurrent, will be tested or should be tested for HER2 for possibility of response to treatment. Now, what they found was greater than 50% improvement in progression-free survival on their controlled study. Again, as I mentioned, it's small, but it was big. But the results were impressive enough that I understand those guidelines are being written now. So it's going to be in the near future that that's probably something that even the private labs are going to be doing. The interpretation appears to be best, or at least based on discussions with the group at Yale that did the study, the scoring is using breast scoring guidelines. Again, this is going to be a huge problem because if you're doing it on a hysterectomy specimen and it's not well fixed, interpretation may not be as adequate as it is in the breast tissue. Perhaps we will start processing our uteri differently. I suspect that won't be the case because this will only apply to the high-stage tumors, and you're not going to really know it's high-stage or recurrent. Well, you might know it's recurrent, but you won't know it's high-stage until you've actually done the staging procedure. So what we've been doing HER2 for a while now because our clinicians felt that it was in fact useful, and they were treating their patients with Herceptin if that was positive. So what we do is we wait until we know they're high stage, and then we will try and do the study on the hysterectomy specimen. But if not, we'll make every effort to go back to the curettage because that would be a better fixed specimen. So I think that's going to be a sort of a routine, probably even more routine than mismatch repair. Now, this is a slide I showed 2 years ago when I was here about future biomarkers. It's tough to make predictions, especially about the future. That's a Yogi Berra quote. And I talked a little bit, just a touch about the TCGA data, but now I want to talk a lot about, spend the next 10 minutes talking about it, because it's become, I think this is the new exciting stuff that we're doing in endometrial cancer. So the TCGA identified 4 broad groups of endometrial carcinoma. One was POL-E ultramutated. The other one's the microsatellite instability hypermutated. We already knew about this because we were already looking at these tumors for Lynch syndrome. So I already knew those happened. Copy number low and then copy number high, which is our P53 mutated tumors. No, why doesn't this? What do I do when I don't understand why this doesn't. There you go. So what are the POL-E ultramutated cases? Well, they basically have mutations in the exonuclease domain of POL-E. They result in increased C to A transversion. And basically what you see is tons of mutations. And so you can get mutations in P10, the PIK3CA, all of these other sort of things that we've been seeing in endometrial carcinomas already. And you can also even see a subset of these tumors will be microsatellite unstable because they will actually have abnormalities in their mismatch repair genes. The exciting thing about this particular subset of endometrial carcinomas is they had never been identified before. This was a total molecular identification of a subset of endometrial carcinomas that had improved progression-free survival. So no histologic markers were useful in predicting this particular group of tumors in terms of being a good news sort of tumor. And again, I'm doing this. I don't understand. The second group is the MSI hypermutated, and again, we knew about these. Most of them, as I mentioned, are MLH1 promoter hypermethylation. They have tenfold increased mutation frequency as opposed to the super high frequency of mutations you see in the POL-E. These also have a variety of other mutations that I've listed, so they're not exactly pure tumors. The The low single copy number abnormalities were basically those tumors, subset of mostly endometrioid tumors, not the serous tumors that had either mutations in P10, the beta-catenin pathway, some of them in ARID1A, et cetera, et cetera. Most of these are mutually exclusive, and so it wasn't as if they were, but they all sort of were grouped into this low single copy number abnormality subgroup. And then finally is the high single copy number abnormality. 90% of these had mutations in P53, 30% in ERB2, and then about half in the PIK3CA. The interesting thing, and what many of us already sort of knew, is that these high single copy abnormality endometrial carcinomas were not all serous. And that gets back to my comment about using P53 as an adjudicator in trying to determine whether or not you have a serous or a high-grade endometrioid carcinoma. There's going to be a subset of endometrioid carcinomas or some tumors with mixed histology that will harbor P53 mutations. And so, again, this we knew, but this sort of, solidified what we'd already knew about P53. So that was the TCGA, and I was talking about how promising this was going to be, and kind of left it at that. But now I want to talk a little bit more about what's happened since then. Based on these sort of the preliminary data from the TCGA, this PROMISE was sort of algorithm was devised. It stands for Proactive Molecular Risk Classifier for Endometrial Cancer. And it was basically, the proposal was if you stratify endometrial cancers by whether or not they have one of these subtypes, you can actually stratify them into prognostic groups. I'm sorry I keep doing this. I don't understand why it's not. Now, then there were a series of what's been referred to as PORTEC trials, and this is the PORTEC is at the bottom of the slide. What it stands for is post-operative radiation therapy in endometrial carcinoma. This is a large-scale, a very large-scale series of studies. Started out, obviously, there was a PORTEC 1. They're up to PORTEC 4A. And the most exciting thing about this particular trial, at least to me, is this is the first endometrial carcinoma trial design that's been set up saying, okay, let's look at our molecular markers compared to our histologic markers. I mean, that's just, we've been doing histologic markers solely for forever. But for those of us who've been doing that, we've recognized for some years now that there's some very low-grade, very low-stage endometrioid carcinomas that go bad, and there's no explanation. And likewise, we've seen some really hideous-looking tumors under the microscope that seem to do really quite well. And again, really, there's no explanation. But the TCGA and these PORTEC trials have actually started teasing them out. And they've divided them up into I don't know why I'm hitting this wrong. Do you think it's... Oh, there we go. So they have a favorable, which is the pole E, which makes sense. And then they have another type, there's no specific mutation profile without a mutation in the beta-catenin pathway. This is an example of a very, very high-grade tumor that's got a POLE mutation. You would never guess that this would be stratified into the favorable sort of category of endometrial carcinomas, never in your wildest dreams. There are a reasonable number of tumor-infiltrating lymphocytes, and some of these tumors have massive numbers, but there's not enough there's nothing looking at this particular tumor that you would say, oh, this is going to be a good prognostic tumor. This is the kind of cytology this thing has. And yet this is a good prognosis. This falls in the favorable prognosis. This is purely molecular. Histology is not going to get you there in this particular case. Intermediate risk is the MMR deficient and no specific mutation profile, but do in fact have a mutation in beta-catenin. And a lot of this study, looking at the CTNNB mutational status in endometrial cancer, has really been done by a variety of groups, but I'm citing Russell Brodus's group here. And basically what they found was that, and again, I mentioned that we've seen these cases, that there's a subset of patients with low-grade, low-stage endometrioid cancer that, for whatever reason, have a worse clinical prognosis or develop progressive disease for no apparent reason. And it looks like this, at least some of these can be accounted for by identifying this particular mutation. In other words, it's a subset of patients that are not going to do well, or you can expect may not do well, that might benefit from local radiation, in which you would never do it on the basis of histologic features alone. Mutational status is the best way to identify these, but about 80 to 85% can be detected with just immunohistochemistry. Again, though, this can be very difficult to interpret. We've started doing this. Often these tumors only show 5 to 10% of positive nuclear staining. Sometimes it's just all over the place, and then it's easy. Here's an example of one of these, and this is not the best example. It shows you, it's the best example to show you strong nuclear staining. On the right, you see a gland-forming tumor. A lot of it's membranous staining, but if you look very carefully, there is some strong nuclear staining. I don't know that it's 5%. And then on the left, on the left side of the slide, you can see this very high-grade process. So this is probably a dedifferentiated endometrioid carcinoma that really picked up a bunch of nuclear beta-catenin as it went bad. The reason I say it's not the best example is because you would predict that this would be a bad tumor on histology. The tumors that you really like to see that this is particularly useful for would be the low-stage, low-grade, grade 1 or 2 endometrioid carcinomas. And those are, although we've been testing all of them, those are the ones you would want to target in order to inform your clinician that this patient actually may do worse than anticipated. And then finally, there's the unfavorable category, which is abnormal P53 we've known for forever. There's this thought that this L1 cell adhesion molecule or overexpression may be unfavorable. This is all part of this whole PORTEC trial. And then there is, in fact, one histologic factor that's featured in the unfavorable, and that's substantial LVSI. And that's a lot of LVSI, and you don't see that very often at all. It's L1 CAM is seen most frequently in P53 abnormal tumors. The only time it's going to be really useful is if you're looking at those that have normal P53 and no specific mutation. I wanted to go back, but I'm not. I'm going to say thank you. But I do want to say one thing, though, that I think in the near future we are going to be using molecular, I think at some level. We've already set up, we've talked about single panel assays. We've set up the POLI as a single assay for our endometrial cancers, and that's going live within the next couple of weeks. So I think this is going to be really important work and exciting work for GYN therapy. Thank you.
All right, our next speaker is Dr. Deborah Dillon. Dr. Dillon is the director of the Breast Tissue Bank at the Dana-Farber Cancer Institute. And Dr. Dillon will be talking about biomarker testing in breast cancer.
Hi. Thank you, and thanks very much to Phil Cagle for inviting me today. I'll see if I can figure out how to get the next slide here. I'm not talking about anything having to do with my work with this company. So, I'm actually not a very competitive person, but when I hear about what's going on in lung cancer, it just makes me want to remind you that the very first targeted therapy was actually in breast cancer. And here in 1896, Sir George Thomas Beatson published a report in Lancet of bilateral oophorectomy for treatment of advanced breast cancer, and that actually became the primary form of therapy for breast cancer in premenopausal women from that time. Now, of course, we still target the estrogen receptor pathway as standard of care for hormone receptor positive breast cancer, but we usually do this now with a variety of drugs. So what I want to talk about today are the standard of care markers that we use in breast cancer, the pretty much standard of care multi-gene predictors that we're using in certain types of breast cancer in certain scenarios, and novel markers, my best bets for the future. So ER/PR and HER2, estrogen receptor, progesterone receptor, and HER2. I think everybody here is well, most people are pathologists. We're using immunohistochemistry primarily to do this. We test all newly diagnosed invasive breast cancers, all post-treatment breast cancers, all recurrences, and all metastases using FISH to disambiguate some that are equivocal on immunohistochemistry. And we do this because ER and PR expression predict response to ER pathway targeting, and HER2 overexpression and amplification predict response to HER2 targeting. For those of you who don't work in the breast cancer area, about 70% of all breast cancers are ER positive, HER2 negative, then about 15% are triple negative, and about 15% HER2 positive. The HER2 positives are then divided between those that are ER positive and those that are ER negative. So I think we're doing pretty well in the ER/PR domain. We've had more than 20 years to practice, so we should be pretty good at this. But I think we still have some challenges, particularly around the cutoff point for a positive result, making sure we can avoid false negative results. And what about these other ways of looking at ER and PR? So we've all seen some cases that have very rare positive cells, and this begs the question of where the threshold for a positive result should be. When we first established the immunohistochemical assays in the 1990s, when these replaced the ligand binding assays, there were very few studies done at the time to establish optimal cutoff points. And in fact, a variety of cutoff points were used clinically and in the literature. And it's really the failure of pathologists to reach a consensus on this that led to discrepancies in interpretation in treatment recommendations. And in some cases, patients were harmed by not receiving the treatment that they should have received for their cancers. When we think about establishing optimal thresholds, we have to realize that almost any cutoff point is going to identify groups of patients who have better and worse survival. But to predict the response to therapy for an individual patient, you want to have that based on clinical validation against outcome. So some of the best information that we have about where the cut point should be is from this 1999 publication from Craig Allred's group that showed that patients who had an Allred score of 3 or above, I'm not even going to try to find but it's that red arrow. I'm not going to try to find the pointer. And you had better disease-free survival when they were treated with endocrine therapy. Now, you can get an Allred score of 3 a couple of different ways. You can have less than 1% of cells that have intermediate intensity, or 10% of cells, 1 to 10% with weak intensity. Patients with a score of 2, Allred score of 2, had survival similar to those ER-negative cancers. So for better or for worse, this is the best information we have that currently informs our choice of a cutoff for our ASCO-CAP guidelines for positivity. And I think at this time, with better antigen retrieval methods that we have now and these rabbit monoclonals, we really have to, at some point, address the validity of the findings of this in terms of establishing that cutoff point. And there is increasing evidence that low expressors, to some extent, are more like triple-negative breast cancer, and many clinical trials now for triple-negative breast cancer have set their thresholds at 5 or 10% in order to be able to enroll the low expressors. False positive and false negative results. False positive results, fortunately, are very rare, and when we see them, usually represent entrapped normal cells, as you see here. False negative results are much more common. These generally involve problems with the tissue, such as cautery, decalcification, prolonged ischemic time, like Dr. Longacre was talking about, poor fixation. And here you see an example where a cauterized edge of the tumor is completely negative for estrogen receptor, but there's clear estrogen receptor expression in the tumor that's not cauterized. So we teach our residents to always check the normal epithelium to make sure it's positive. If not, repeat on the same or a different specimen. Now also we teach our residents to always correlate with histology. Some cancers are virtually always ER positive, including mucinous, tubular, low-grade ductal cancers, and grade 1 and 2 lobular cancers. So the problems with the ER testing in Newfoundland were discovered when 2 patients with ER-negative lobular cancer were retested and found to be ER positive. This resulted in retesting of over 1,000 cases, and eventually almost 40% of these were found to have some degree of ER positivity. More than 100 of those patients had died without receiving hormonal therapy. So the moral of the story for us as pathologists is that earlier attention to an unusual finding could have alerted us to this problem earlier. And the red flag, of course, is ER-negative lobular cancer, because that happens, but it is exceedingly rare. So what about IHC? Well, IHC is cheap, fast, robust, and although there are some other assays that can detect ER and PR expression using aggregated scraped tissue, you have to keep in mind if you're using an assay that uses scraped tissue, although you're concordant in the large number of cases, the most common type of discrepancy is going to be a false negative. And we see this in cases with low cellularity cancers, particularly lobular, and in cancers, small cancers that have large biopsy sites. When there's a discordance between ER status from scraped tissue and an immunohistochemistry, the immunohistochemistry is generally the correct result. The same holds for image analysis. If you're using image analysis, you just have to keep in mind that there are other cells in the breast tissue that do express estrogen receptor, such as the normal cells and also lymphocytes that you see here. Also, this is a case that came to us called estrogen receptor positive, but if you look, you can clearly see that the invasive carcinoma cells are completely negative, but the stromal cells are positive. So stromal cells do express estrogen receptor, and if you're using some kind of image analysis, you just need to make sure that you've set your parameters to exclude things like this. So in summary then, for ER and PR, the lower cutoff is currently at 1%, but we shouldn't be too surprised if patients are being qualified for triple negative trials, even though they do have some degree of estrogen receptor expression up to 10%. False negative results we can avoid through attention to technical issues and some interpretive pitfalls. I think IHC is here to stay for this. Really, if you're using anything else, you do need to be aware of the pitfalls in assays that are scraped and aggregated. I've included the reference to the ASCO-CAP guidelines for ER-PR in case you need them. So HER2 was the first cancer biomarker to be targeted by a therapeutic antibody in 1998. It's now the target of a number of different HER2 therapies. HER2 is amplified and overexpressed in 15% of breast cancers, and we generally evaluate this using immunohistochemistry and or FISH. So I think the areas of kind of our struggles yet in HER2 involve avoiding false positive results on immunohistochemistry. Where should that cutoff point be for a positive result on the FISH? And struggling still a bit with heterogeneity in some of the more rare non-classical FISH results. There are many different antibodies to HER2. Fortunately, strong 3+ positive staining with virtually all of them is associated with amplification by FISH. There are differing sensitivities and specificities, especially in the intermediate ranges, and as we'll hear more about this afternoon, of course, this is, as all IHC, subject to pre-analytical and other analytical and interpretive variables. As a community, we try hard, I think, to reduce variability and to standardize our interpretive criteria. We don't get too concerned about discrepancies in the 0 to 1+ range, but we're terribly concerned about variability in the 2+ to 3+ range. False positive 3+ results have significant consequences. For individual patients, this leads to inappropriate treatment. For clinical trials, it can impact the results of the trial. And for society as a whole, these targeted therapies are quite costly, and you really have to weigh this against the really pretty good price of an IHC or an in situ hybridization in order to get the extra information if you're struggling with something that's on the fence. So the causes of false positive 3+ stain results include overstaining, edge artifact, cytoplasmic positivity, and of course all of these do as well contribute to overinterpretation. Grimm and colleagues looked at IHC, in situ hybridization, discordant cases a few years back and found that the vast majority of discordant cases were due to overinterpretation of the immunohistochemistry as 3+, when actually due to the granular staining, crush artifact, or weaker intensity, they really should have pulled back and called these cases a 2+. So we teach that in order to avoid that false positive 3+, you should have a very high threshold for interpreting a cancer as 3+. You should have strong, crisp, complete membrane positivity. This has sometimes been called the chicken wire pattern, and have a low threshold for confirming by in situ hybridization if you're not sure. Most institutions are using a hybrid testing scheme, which works because of the high concordance between a 3+ positive result and amplification by FISH, and also high concordance between 0 and 1+ on IHC and the lack of amplification by FISH. Most institutions then will test with FISH the cases that fall in that 2+ equivocal range. And depending on the antibody that's being used to initially screen the tissue, somewhere between 20 and 50% of those cases will be amplified by FISH. The dual probe assays use 2 probes. The HER2 probe covers the HER2 gene plus a couple extra genes on both sides, and also contains a chromosome 17 probe that hybridizes to the pericentromere alpha repeat sequences. And a nice example here of an amplified case, you can see that you have 2 copies of the 1 or 2 copies in all cells of the centromere probe, and probably 6 to 8 or maybe even 10 copies of HER2 for each one of those CEP17 probes. It's important to remember that the FISH for HER2 is done on 5 micron sections, so for any of you who are working with NGS, the estimated number of copies in a whole cell obviously is going to be different from what you see in a 5 micron section. Scoring for FISH is standardized. We count only cells that have both signals. We avoid counting overlapping cells that would falsely elevate our copy number. Probe signals are counted in a minimum of 20 tumor cells. DCS is excluded because it doesn't always show the same genotype as the invasive cancer. We then calculate average HER2 signals per cell, the average CEP17 signals per cell, and from that you derive a ratio of HER2 to chromosome 17. So for classical FISH results, the non-amplified pattern on the left, virtually none of patients who have this pattern on their FISH respond to HER2-targeted therapy. A large number of patients with the pattern on the right, the typical amplified pattern, will respond to HER2-directed therapy. This is a paper from Kimberly Allison last year, where they looked at all of their HER2 cases and found that overall the vast majority of cases can be pretty easily classified into either one of these 2 classic patterns. So in their study, 78% showed that classic non-amplified pattern, 12% showed the classic amplified pattern, and then of course there's the 5% of equivocals and the 5% of the non-classical amplifieds, which of course take 90% of our time, or used to take 90% of our time. Since the 2018 update to the ASCO-CAP HER2 guidelines came out, I think in May, this update addresses that 10% of difficult cases, those with equivocal and non-classical results, and I have the reference here for you also. And just to briefly summarize the changes, these cases that were previously classified as positive because they were positive by ratio, but not by copy number, by virtue of loss of the CEP17 signal, that's the green signal here, rather than true amplification of HER2. These cases used to be classified as positive. They're now, for the most part, going to be negative. I've never seen, unless they have a 3+ IHC, and I've never seen in 25 years of doing FISH, I've never seen a 3+ IHC in a case with monosomy. So another type of case that's been reclassified are those that were positive by HER2 copy number but not by ratio by virtue of the co-amplification of the CEP17 signal. So in this case, you have more than 6 copies per cell of HER2, but you have a ratio of less than 2. Most of these cases will now, we're now incorporating the, there isn't a pointer, is this? Yes, okay. So now we are incorporating, incorporating the results of the immunohistochemistry to guide the interpretation of this particular FISH category. These will continue to be classified as positive as long as they have at least 2+ immunohistochemistry. And again, these usually do not show 3+, usually these are 2+ positive. So the entire equivocal category from previously, prior to the guidelines update, these are ratio less than 2 with HER2 copy number between 4 and 6, is going away, as far as I'm concerned. And that's because the only ones that will be continued to be classified as positive are the ones that are 3+, and I've never seen a 3+ on an equivocal case. So if you have one, send it to me. Okay, so I think it's not too surprising that we've struggled a little bit with this cutoff for HER2-positive FISH. I think the biology is a continuum. There are some breast cancers that are simply at the threshold between positive and negative, and I do think that the 2018 update to the guidelines is helping to close that gap. It would be difficult for me to overstate the importance of HER2 testing in clinical decision-making. For HER2 3+ positive or amplified cases, targeted therapy reduces the risk of recurrence by 1/2 and reduces mortality by 1/3. And when we submit our pathology reports telling, all of these details about the histology, absolutely nothing happens to the patient until that addendum goes out with the ER/PR and HER2 status. So the last issue with FISH, I think, is about heterogeneity. We want to make sure we can identify cases that have a distinct clustered subpopulation with a different HER2 gene status. These are classified as HER2 positive if you have more than 10% of the cancer being positive, but very importantly, it has to be in a homogeneous and contiguous population. So you can't go just, cherry picking around the most abnormal cells in order to drive that ratio up. Here's a case of heterogeneity that I had a couple of years ago. Clearly, you can see that the breast, even at 1x here, is clearly HER2 negative. In the axillary lymph node, you have this flaming 3+ positive MET, including also a HER2 0 MET as well. We went back and stained 4 blocks of the primary cancer and found that about 20% of the primary cancer, in fact, was HER2 3+. So this is an example of real true heterogeneity. I think cancers with a discrete identifiable subpopulation of HER2 positive cells are rare. But they're interesting because this might be a source of resistant disease. And sometimes the oncologists do like to tailor their therapy to both components, such as the case that I showed you, who was also covered for the triple-negative disease that constituted the other 80% of her cancer. So for HER2, majority of breast cancers can be clearly classified into positive and negative according to the probability of treatment response. False positive results on IHC are a big problem. The only type of heterogeneity we're really concerned about is a discrete, contiguous population. 2018 update reclassifies these unusual types of FISH results according pretty much to the IHC and totally gets rid of the FISH equivocal category. So next, I want to just mention multi-gene predictors. This is about who gets chemotherapy. And I apologize for showing this picture because I think everybody's seen it a million times. But I just want to remind you that of the subtypes of breast cancer, we recognize more than one type of ER-positive, HER2-negative breast cancer. These are luminal A and luminal B. This probably do not represent discrete subtypes, but rather a continuum. These intrinsic subtypes are associated with clinical behavior, and you can see that your HER2 positive and your basal-like subtypes have very bad behavior, and your luminal subtypes are associated with a much better outcome. But this is the luminal A line up here, and this is the luminal B line down here. And although virtually all patients with HER2 positive and triple negative tumors get treated with chemotherapy as long as the tumors are more than about 0.5 centimeter, if I had an ER positive tumor, I would want to know whether I'm up here or whether I'm down here when I'm trying to make the decision about whether or not to take chemotherapy. So how are these clinical decisions made? And my apologies to any oncologists in the group, but from my simple-minded pathologist standpoint here, small, low-grade ER-positive, HER2-negative cancers that look like they probably are luminal cancers get hormonal therapy alone, whereas the larger, higher-grade ER-positive, HER2-negative cancers, anything that's got kind of some adverse prognostic markers where you're worried about the possibility it could be luminal B, will get a multi-gene predictor in order to determine the benefit from chemotherapy. The most common of these assays that's used in this country is Oncotype DX. It's a real-time PCR assay for 21 genes in order to predict recurrence and chemotherapy benefit in ER-positive, HER2-negative breast cancer. It's marketed by Genomic Health after a retrospective look at the tumors in two of these NSABP trials that showed benefit of tamoxifen and chemotherapy in women with ER-positive lymph node negative breast cancer. And the really interesting thing that came out in that study was that with surgery and tamoxifen alone, only 15% of women had recurrences at 10 years. And that suggested that we were treating 85% of the cases with too much chemotherapy. So the Oncotype DX consists of estrogen pathway genes, HER2 pathway genes, and proliferation genes. These then are put together in a statistical algorithm to determine a recurrence score indicating the level of risk for recurrence into low risk, intermediate, and high risk groups. The risk score is then reported along with a predicted benefit from chemotherapy. So how is this working prospectively for us? I think that everyone feels better about not using chemo when the result comes back low risk. Everyone feels better about using chemo when it comes back high risk, but most of them come back in the middle. So there we are. So this assay has been undergoing prospective validation over the course of the last 6 or 7 years in the Taylor RX trial. And this is a trial that enrolled more than 10,000 patients who had low-risk scores got endocrine therapy only, patients that had high-risk scores got chemotherapy, and the ones with intermediate scores got randomized to chemotherapy and no chemotherapy. We now have the results, the 5-year results from this trial just for the low-risk group. Not surprisingly, 99% of those who were treated with hormonal therapy alone without chemotherapy were cancer-free after 5 years. Big caveat being it's only follow-ups, only 5 years, and we know that hormone receptor positive cancer, when it comes back, tends to come back later. So, but that's, it's still encouraging, and the results are very similar to a similar trial that was done in Israel. The difference in Israel is that they didn't randomize patients to in the intermediate group. The results from the Israeli study also support the use of endocrine therapy alone when the risk score is low. And in the intermediate group, importantly, although there's some selection bias here, it really shows quite similar survival in patients who were treated with chemotherapy and hormonal therapy. So we're really looking forward to the rest of the results from the Taylor RX trial, so we know what to do with those intermediate folks. So there are other multi-gene predictors on the market, including MammaPrint, Prosigna, EndoPredict, and Breast Cancer Index. They differ from each other and from Oncotype DX in the platforms that are used, in the specific genes that are included, and also in the populations that were used in their development and validation. Most of these oncology guidelines now support the use of a multi-gene expression assay in order to predict chemotherapy benefit in ER-positive, HER2-negative breast cancer. Which assay is used may not matter too much as long as differentiation and proliferation genes are included. I do expect that we will see the classification of individual patients to vary, and some early data does suggest that some of these multi-gene predictors, particularly Prosigna and Breast Cancer Index, may actually have better power for the detection of late recurrence. I expect that in the next few years we're going to see lots of papers comparing these different platforms. Importantly, these multi-gene predictors are covered by most major U.S. insurance carriers for patients who have early-stage invasive breast cancer. So my best bets for the future in the last few minutes here. Most triple-negative cancers, as you know then, are high-grade and are treated with chemotherapy, but there are a couple of rare low-grade histologic subtypes that have characteristic translocations. The first is adenoid cystic carcinoma, where more than half of these have a translocation between 6 and 9 that involves either MIB or NF1B or both. And also secretory carcinomas are another low-grade histologic subtype that have 12-15 translocation involving ETV6 and NTRK3. This is the same translocation that's seen in the mesenchymal PD tumors. So it's important to detect these. They can be detected either by FISH or NGS if you have a diagnostically challenging case. And it's important to make this distinction because typically the clinicians, when they see a triple-negative breast cancer, will give the patient chemotherapy, but these are low-grade subtypes that don't need chemotherapy. And so making that diagnosis is important. So my favorite bets for the future are estrogen receptor mutations, HER2 mutations, androgen receptor, and I'm not going to talk about PD-1 and PD-L1 because we had a whole talk about that in breast cancer tomorrow. So estrogen receptor mutations are very rare in primary tumors, but they're present in a significant portion of patients with metastatic disease who've received endocrine therapy, particularly those who received endocrine therapy with an aromatase inhibitor. These mutations are clustered in the ligand binding domain, and they lead to constitutive estrogen receptor activity, and they're associated with acquired endocrine resistance. This is the perfect setting for liquid biopsy, and we're also going to get a liquid biopsy talk, I think, tomorrow, because you don't have the primary, it doesn't matter to test the primary tumor, and you really do want to collect information from all different metastatic sites. So I think we're seeing now the use of these liquid biopsies in the context of clinical trials in breast cancer. In the Bolero trial, almost 30% of patients with advanced ER-positive disease had estrogen receptor mutations in their circulation. And I think the potential for real-time monitoring is great here. Aditya Bhardia presented a poster at ASCO last year in a study of his where there were 50% of patients with circulating estrogen receptor mutations, and he was able to monitor decreases in the estrogen receptor mutation fraction during estrogen receptor blockade treatment. So great potential there. HER2 mutations are clustered in the kinase domain. They are gain-of-function missense mutations that are capable of activating signaling even in tumors that have normal HER2 copy number. HER2 mutations are present in 2.5% of breast cancers and are enriched in certain subtypes, particularly the high-grade lobular cancers. And most of the tumors that have HER2 mutations do not have amplification. In preclinical models, these mutations are activating, they increase tumor growth, and thereby represent an alternate mechanism of HER2 activation in these tumors. Importantly, many of these in vitro show less sensitivity to trastuzumab and lapatinib, but all are sensitive to neratinib. And now we're seeing neratinib targeting of patients with HER2 mutations, and the preliminary data look like there's a response somewhere in the range of 20 to 25%. Finally, androgen receptor is expressed in a large percentage of breast cancers. The greatest clinical interest in androgen receptor as a marker in breast cancer is in apocrine carcinomas. Although this is not a histologic subtype that is recognized separately by the WHO, there is a characteristic biologic profile of these apocrine carcinomas. They are often triple negative and androgen receptor positive. They do quite badly in general, and so androgen receptor targeting is of great clinical interest, and this is a recent report by Tiffany Traina that just came out a couple months ago, a phase 2 trial of the AR blockade for AR-positive triple-negative breast cancer, and again, there was a benefit in about a third of patients in that trial. How do we best look at androgen receptor? It's probably going to be immunohistochemistry, quite robust, nuclear stains similar to ER and PR. One would think that androgen receptor amplification will also probably predict response. Androgen receptor mutations, I think, depending on where they are, might actually abrogate the nuclear activity of the binding of androgen receptor to those androgen receptor response elements, so they may predict people who should not be treated with androgen receptor blockade. So in summary then, there are two very rare low-grade triple-negative subtypes of breast cancer that have specific translocations. ESR1 mutations are present in patients with metastatic ER-positive metastatic breast cancer and are associated with resistance to hormonal therapy. HER2 mutations are common in HER2 non-amplified cases and may respond best to a different type of HER2-targeted therapy. And finally, I think immunohistochemistry for androgen receptor is probably where we're going to go in terms of predicting response for androgen-targeted therapies. Thank you.
So this is the somewhat more complicated part of the program here. We're going to ask our speakers to come up here and take a chair at the podium. We're about to ask you questions. If you will please do so, those of you who've spoken this morning. And those of you who, this will be Dr. Eric Bernecker, Dr. Randy Olson, Dr. Ross Miller, and Dr. Jay Rowe, to please come forward as our moderators. In the past, we did this program with actually the moderators having the seats, but we're going to change it up a little bit this time. And if the moderators are certainly welcome to make comments and ask questions themselves, but it's been suggested that maybe you can also be the one to go around with the microphone to people if it's needed. Yeah, okay. Dr. Bernecker, I'll let you take over this part. We do need to end.
Yeah, we'll be on time. I'll start with a question for Neil or for Dara. How much of a problem do you really think lack of concordance between NGS among different platforms or different companies is, and how should oncologists who order these tests figure out how to work the way through that debate?
Sure, thank you. So I think it's an interesting question, and it's a real problem to be sure. Part of it has to do with where the discordance is in terms of which mutation, and how it's presented. So very often, looking at sort of all mutations, there seems to be pretty high discordance on occasion, but usually where you look at the most actionable, targetable oncogenes, in point of fact, the discordance is quite a bit less. And I'm not saying that that's necessarily justification, but there is a need, I think, for some more standardization in the field, and we'll get there. But I would feel that oncologists should be confident in the results that they get from a validated, CLIA-certified, capable lab for a targetable, actionable alteration. And when there's something that's a little more novel or more investigatory, that might be an instance where some kind of alternative approach might be useful. For us, we interpret all our results by hand, individually, actually. And so when something is equivocal or not sure, we make sure we express that in the report. And so I think, I was involved with some guidelines about how to report these things too. And I think that's an important thing that we perhaps not as a profession do as good a job as we could, is expressing our uncertainty when there is uncertainty in the result.
I agree completely, and I would point you to a recent publication by Kim et al. It was not focused on next-generation sequencing, but it was focused on publication of the proficiency testing data across targeted testing for a number of years, and the concordance was exceptionally high. And the reality is that if you're looking at the markers that matter, the concordance is going to be quite high. That said, it doesn't mean that there isn't always room for improvement. There isn't always room to identify more standards, better standards, etc. But, if you're talking about a BRAF mutation or an EGFR deletion, the chances that you're going to get systematic, widespread discordance at that level, I think, is pretty low at this point.
Other questions from the audience at all? I can bring the mic to you and everything. Okay. Here, I wrote down a few things so I can come up with something here. Let's see. Dr. Chowdhury, great talk on your molecular testing and cytology specimens. Do you have any experience with molecular testing on the supernative samples?
She just published on it.
Is that a question, or are you just giving me a chance to...
No, I'd love to hear your take on it, though.
Okay, so again, this is something that I've been kind of interested in recently. There has been a lot of discussion about different ways we can utilize our specimens, and given our best efforts, there's often the scenario where you just don't have enough to do all the tests that you're required to do. So there have been several studies in the past where they've looked at the supernatant from the FNA rinse and have been able to successfully extract DNA from there, which makes sense given the number of tests that we do using residual liquid-based cytology. It makes sense that you would have DNA in these needle rinses. The fact that when we spin down the cells, you think you're spinning down everything and the supernatant has nothing in it, and we toss it away into the trash. We decided to look at that, and we were actually surprised at the amount of DNA we were extracting from there. Sometimes more DNA than we actually extracted from the smears itself. And initially, our thought was this is cell-free DNA that's probably in the rinse, but in reality, it's high molecular weight DNA, and our hypothesis is that we're just releasing DNA from either the FNA procedure or when we're centrifuging the cells, it's just DNA being released. And there's so much DNA that we're able to do next-gen sequencing and a multitude of other assays if needed. So it just highlights the fact that there are multiple ways of utilizing the specimens, even when you have limited amounts of tissue.
Thanks. I think Dr. Trong has a question.
I would like to have a question for Dr. Browse. Sometimes we have biopsy of the tumors, like biopsy from the GI tract or biopsy of the lung, and sometimes the tumor tissue is somewhat small, and we don't know whether or not the positive biopsy will be followed by definitive resection of the specimen. So what's your thought about molecular testing on that situations?
Well, I think that's the scenario where it becomes very important to have the conversation up front about where you're going to get the most bang for the buck, because you're probably only going to get one shot.
And so the real question is, okay, what for the oncologist would be actionable for that patient, and go for those assays selectively. That actually is a fairly common scenario for us.
Question for Dr. Dillon regarding ER IHC. If you do the IHC on core biopsies, do you repeat on lumpectomy specimens if it's a negative result, or only if histology would argue possibly it's a false negative?
So if the markers are negative on the original, we would always repeat on the excision for anything where the markers were negative on the original. I think if if the markers are positive and you're looking at like a small tubular cancer and you've got 0.8 cm of it in the core and you've got like 0.1 cm of it left in the excision, then I don't think anybody cares in that case. And the same goes for, a low-grade classic lobular. If you've got a good sample on the core and there's not very much left on the excision and it was ER/PR positive on the core, we wouldn't bother to repeat. But in general, the advice is to repeat anything that was negative on the first time around.
I have 2 questions. And first one for Dr. Dillon. And for the breast marker study here, you mentioned right here. Sorry. And you mentioned the heterogeneity of the ER stains from the big resection specimens. I'm just wondering whether this ER heterogeneity correlates with the histology heterogeneity.
ER heterogeneity correlating with, that's a really interesting question, and I think we've one of the interesting things that we've seen with marker expression like this is in the setting of neoadjuvant chemotherapy, which I didn't talk about at all. But in neoadjuvant chemotherapy, you're taking a core that's pretty small of a pretty big tumor, and then you're basing your treatment upon that. And we've actually seen cases now where the core was ER/PR negative, HER2 positive. The patient was treated with HER2 targeted therapy, had massive response, absolutely nothing HER2 positive left, and yet this big, massive ER positive kind of low grade nodule next to the HER2 positive cancer. So you're always like working in the back of the closet, I think, on those neoadjuvant cases. I think you just have to use your judgment. In bilobed lesions, I'll usually make sure that we assay both of the lobes of the bilobed lesion. If you have multiple biopsies of the same lesion, we used to be pretty happy to say, these are histologically similar and only do the marker on the largest one, which I'd still be comfortable doing, say, in the setting of invasive lobular cancer where you've got multiple biopsies. But, I would have a pretty low bar. Immunohistochemistry is not an expensive test. I have a pretty low bar for repeating. If you've got multiple blocks and a massive, really different histology, repeat.
Thank you so much. The next question is for Dr. Roy. And I know for the molecular test for the patient with metastatic disease, many times, especially in MD Anderson Cancer Center, many patients have multiple metastatic sites, including malignant fluid. I'm wondering, do we test all the sites, tumor sites for the molecular test, or do we have, just one single formula?
So you're talking about like multiple metastatic sites at the same time, not at different time points.
Different.
Typically, we assume that if you test one site, that it's representative, and unless there is some histologic basis that they look different and you're testing. So sometimes you'll have like 2 nodules in the lung and we'll test them both. But usually we don't test 4 different, you get like EBUS lymph nodes done, 3 of them being positive. We're not going to test all 3 of them. We'll pick the best sample.
So question, in the modern era, what is the role of testing for tumor unknown origin, which is not an insignificant group of tumors even after immunohistochemical panels? Since many times these tumors are treated, if you can pinpoint what organ it's likely from, the frontline chemotherapy would be different depending on the different organs, as opposed to just going directly to next-generation sequencing and looking at what genes may be actionable from that standpoint. Is there any role these days?
It's an interesting question, and we test everything, so we test tumors of unknown origin as well. I have to say it's subjectively a little disappointing. We're not usually able to figure it out. We may be able to narrow things down a little bit. I know there's a number of expression classifiers that are available from a variety of laboratories to try and figure that out, and that ultimately might be a better way to go, but I don't have as much experience with those personally. But that said, a lot of these mutations are what they say promiscuous, and they cut across different cancer types, particularly the targetable ones. And while it may be tempting to figure if you've got a BRAF V600E, it almost doesn't matter what diagnosis you have. There are actually quite a few studies showing that the outcome is different in the different cancer types with those mutations. But I think in a carcinoma of unknown potential, finding a targetable alteration like that would prompt an oncologist to use a targeted therapy. As far as doing actual classification, there aren't a lot of mutations that are extremely specific. And so unless you find sort of a classic EGFR mutation, which you usually don't see outside a lung, it's going to be hard to make a definitive diagnosis that way. Maybe a little different for the sarcomas with the fusions, but not so much for carcinomas.
Hi. I have a question about the ER and PR receptors. Have you ever encountered situations where your ER and PR is low? Let's say ER is low. With Alred score 3. And then the clinicians order Oncotype DX. Oncotype DX comes back as ER negative. And then you get a phone call, of course. What am I supposed to do? I usually tell them you go by IHC. What is your take on it?
Yeah, no, absolutely. I didn't talk about that, but no, I mean, we've had that experience too, of course, and I think that it's the same issue as any assay where you scrape and you analyze. You know, it's the same thing for Oncotype DX, and particularly this happens in low cellularity lobular cancers, and we've also seen it happen in cancers with large biopsy site. And so we always tell our clinicians, we actually, when we first started to see this, because the clinicians would bring us their Oncotype report and say, you called this positive, and in fact, it's negative, you know. And of course, they have decimal points and everything, so, you know, it looks like it's really accurate. So... no, we say, no, we look at the immunohistochemistry. If the immunohistochemistry is positive, the immunohistochemistry should prevail. I think this is just an issue of dilution of the signal.
Hi. This is a question, I guess, for Dr. Lindemann and maybe also partly Dr. Brown and the other panelists. But, you know, there are multiple, of course, NGS assays on the market, and this also echoes a little bit of the sentiment from the first question. What, in your opinion, is the optimal sweet spot, essentially, for gene content? Is for, you know, at this point, the COSMIC database is pretty well populated, and we've had TCGA data sets generated. So in the non-discovery environment where we're focused on actionability and routine clinical care, is there really a role for very extensive gene panels for SNVs and small indels? Or perhaps, I think you had mentioned in your laboratory you have a 31 gene panel. Where do you feel is the most value if you're really, the mission is clinical actionability to guide therapy and prognosis and practice according to clinical practice guidelines well established? There is like this sort of, in my mind, gray zone where even the clinical practice guidelines, whether it be NCCN or WHO or other, can lag behind cutting-edge clinical care as well. So it's, to me, a little hazy. What's the optimal approach? And, you know, not having a very well-established consensus on this is, I think, what's led to a lot of the issues with the reimbursement, et cetera, is because, you know, we have extensive data generated, but it becomes a question, what's the value of it for the, you know, clinical care now? So multi-gene panels that are tens to less than 50 to 100, or several hundred genes, where do you feel are where's the most value for routine clinical care at this time?
Sure, thank you. And I'm not hedging to dodge the question. It's because there isn't a clear answer, unfortunately. So we have two tests, just for the record. One is a 95 gene panel that we do for the hematologic malignancies, and the other is 450 that we do for solid cancers, and that's part of our mission. So COSMIC is good, but COSMIC has mistakes in it, and so do the general population databases. And so we use our test as a hybrid, right, where we're trying to do FDA-approved therapies, which you can kind of count on two hands. There aren't that many of them, really, right now. So if you want to sort of limit what you're doing to what you can prescribe on label, you're going to be looking at a dozen or so markers, or maybe a few more. If you want to look at what's available now for clinical trials, and you want to route your patient not only to what's available off the shelf today, but what can refer them for a study, now you're going to increase quite a bit the number of targets that you're looking at, and that's a moving target, and it keeps changing. And so now you're getting into scores of genes. And then the last thing that I'd mention is this tumor mutational burden, which changes everything to some extent. And I'm sure you'll hear about some trials that have occurred recently that have suggested that the tumor mutational burden is actually a pretty good way to predict response to some of the immunomodulatory therapies. The challenge there is that if you don't look at enough genes, you don't get enough information to accurately predict what the mutational load is. And the sweet spot for that appears to be in the low hundreds somewhere. And that's very different from some of the shorter, quicker, more targeted panels that are made for the very, what we call in our language in the lab tier 1, those things that no one would argue about. So I'm not really dodging your question. I think it does get at what your mission is. And if your mission is just what's available now, you can get that with a relatively small panel of 30 to 50 genes. But if you want that larger picture, you're going to have to get into the low hundreds. I don't think that whole exome sequencing is needed at this time. I don't think whole genome sequencing is needed at this time. And some people will argue that. But.
We're going to take one last question, and then, is there one? Yes.
It won't take long, I promise. This is for Dr. Roy Chowdhury. So in your assessments of the FNA rinses, what do you do to control for tumor cellularity?
That's a great question, because that's always the issue, because in the rinse, I have no idea what the tumor fraction is. And we have actually gone back and looked at, because so the rinse is coming from all the different passes, and when we spin it down, we're either making a cell block or we're making a cytospin out of the cellular material. And we've gone and looked at that, and we've had cases where there's barely anything on the cytospin. It would definitely not qualify for anything, a molecular-based test, but we still extracted enough DNA and have picked up mutations from that. So people have used, like for liquid-based cytology, they've used the thin prep slide as a measure of the amount of tumor you have, and then they test directly from the leftover rinse. So that works for the most part. We've looked at the overall cellularity and the tumor fraction in all our smears and have used that. And it works for the most part, but we've had rare cases where there's barely anything in the rinse from the cellular point of view, but there is a ton of DNA in the rinse. So, yeah.
I can also provide a couple of perspectives on this, because I promise my whole life is not about regulation and reimbursement. So a couple of points on this. First is that I think in that sort of approach, you have to take it as a only positive result or informative perspective, right? And, if someone were to validate that to the extent that they were using it clinically, you just have to have extremely strong wording about negative findings. I just don't think you can infer much. But I will mention that some laboratories that do this type of testing that don't have a morphologic correlate will embed into their assays, particularly if there's any RNA component, expression metrics for epithelial components. Now, it doesn't distinguish benign from malignant epithelium, but for example, if you build into your assay a marker that allows you to know that you've got expression of keratins, et cetera, then you at least know that you have some epithelial elements in your test. So there are some molecular kind of tricks of the hat you can use to kind of backdoor create assurances.
So I'd like to breach panelist etiquette and ask one of my colleagues a question, and this is for Dr. Brown. I noticed that your workflow and your policy did not include consideration of deploying biomarker testing in your facility, and I'm wondering, what are the barriers that make it such that that's just not going to happen for you?
It's purely financial, frankly. Basically, we always analyze break-even points, and for us, the volume is just not there. Another challenge that's really kind of, I guess, a little bit unique to the Houston market is finding technologists, right? I mean, there's so much competition in Houston for molecular technologists. We have a huge infectious disease molecular laboratory, and we're doing good just to staff that. So on the molecular side, that's been the major challenge. On the immuno side and the fish side, then that becomes more of a financial consideration. As far as PD-L1's going, we're still waiting to sort of get some consensus. We're not going to change our platform just to do that. So, if at some point we get an overarching, you can do one assay with one score and agree with everybody, then we'll look at that.
Great. All right. Thank you to our panelists. Thanks for the questions.
Thank you, Phil, and thank you for inviting me to speak today. Thank you to the organizers. I'm really excited to talk to you about pre-analytics, biospecimens, which have been my life now for a couple of decades. In my background, have been at Mass General for 15 years, heading GI pathology, high-volume service, heading to discovery labs, doing clinical research, clinical trials in CALGB, and then went to the NCI for a decade. So I've kind of seen biomarker development from all sides, and I'm here to share some of that experience, good and bad, with you. To talk about especially how biomarkers fit into our new vision of medical practice in general, that precision medicine, it's our vision of 21st century medicine, and we're thinking about early detection and disease risk based on molecular profiles of patients, and how do we get those? Those come from molecular biomarkers from biospecimens. We're also thinking about making diagnosis based on molecular characterization of disease, not just morphology. And that will be based on biomarkers or signatures from specimens, from patients. Molecular and genomically based treatment using targeted agents again requires companion diagnostic biomarkers from biospecimens. And the true vision of the connection of what we do in the clinic to what we learn in research, in a seamless feedback loop, taking advantage of every patient and the data that we derive from each patient, requires that we link these data from biospecimens from clinical care to the research world. Actually, we already do that, and I'll start by actually saying that it's not special specimens I'm talking about. I'm talking about the specimens that we handle every day in the pathology department. Those are the ones that are used in clinical trials. So you are connected to clinical research, whether or not you think you are, through the biospecimens that you handle and analyze. So at the end of the day, precision medicine depends on the availability of high-quality biomarkers. This is a biomarker-driven era. So what is a biomarker? I'll just use this simple definition, but I want to emphasize that it's a measurable characteristic used as an indicator of a biologic state or condition. And it's usually a biomolecule or a set of biomolecules from a biospecimen, but not exclusively, because we use radiologic imaging techniques to create biomarkers as well. And it doesn't actually sound so hard, because haven't we been doing this forever in pathology? Yes and no. We are actually in a new era now, created solely by technology development. We are in an era where we don't need to just look at one molecule, do one test. We can look at them all. So we are in an era where we can examine from a single biospecimen a genome, transcriptome, proteome, epigenome, metabolome, microbiome, and not just of the patient, but of the other genomes that we carry around. And this is all put in the context of spatial relationships and microenvironments, so we have to think about how all these things connect, and it makes your head pop off your body trying to think about this. It's so complex, and it's constantly evolving. We now know that cancer is never the same, and especially if we touch it with treatment, it's a strong evolutionary factor that completely changes the nature of the beast with which you are dealing. So we're looking at increasing layers of complexity all the time, but this creates for us increasing limitations due to the sheer amount of analytic data we can produce. And we're always fighting with data quality, the sheer size of the data, the rate of production. Analytics, which has now become a constriction in the analysis process. How do you connect different flavors of data? What's an MRI scan have to do with a whole genome sequence? You have to create algorithms for these things. Clinical trials and regulatory pathways have to be brought into the picture, so you have to deal with the regulators, otherwise no new knowledge will get to the bedside of the patient. So we are living in an unprecedented era where technology development is unleashing this power in the hands of pathologists that is exponential, not linear, in its growth pattern. So I'm sure most of you have heard of Moore's Law, which is it came from Gordon Moore. He was an Intel scientist who in 1965 noticed that about every 18 months they were producing microchips that had twice as many or integrated circuits, and that the power of computing was doubling every 18 months, and it looked like there was no end in sight, and so he prophesied that this would continue indefinitely. And in fact, it became the mantra for technology development in general. Moore's Law, faster, better, cheaper, and it created an explosive technology development with a tsunami of data close behind it. Unprecedented, multidimensional data explosion. So this is the environment in which we are trying to develop biomarkers. And we are producing unprecedented amounts of data, and it's still early in the game. We are producing unprecedented varieties of data, genomic, phenomic, clinical data, imaging. Complexity is increasing. And the velocity with which we do this is rising exponentially as well. Our problem is we got a lot of data. There's no question about that. But we don't know how it relates to biologic truth. So the veracity of this data is still in question. And the value, even if we know that it's true, how do we apply it to patients and patient care? What good is it to us? I'm going to just pause a minute to emphasize the word exponential. You can pass over that very quickly without realizing what it means in real life. We're in fact in what Thomas Friedman has called the age of acceleration, where we are enjoying this exponential growth. This is linear growth in comparison. And in fact, we're only here at the moment. There's a lot more to come. And the power of an exponential, so this is just one example. If you doubled 1 just 63 times, you would get a number of 18 quintillion. That's 18 with 18 zeros behind it. That's big. So when we talk about big data, that's what we're talking about. And since 1965, the power of technology has been doubling every 18 months. So we're already in the midst of this. And when you think about biomedical technologies versus other technologies that aren't quite in an exponential growth phase, you can get some idea of what this means in terms of tool development for our use. And some Intel engineers were just playing with this idea and calculated that if the 1971 Volkswagen had followed the same trajectory as the microprocessor, according to Moore's law, today it would go 300,000 miles per hour, it would get 2 million miles per gallon of gas, and it would cost 4 cents. So that's the kind of exponential growth we're talking about. And so I'm just going to put this in context of one of the most powerful tools that we now have in the laboratory, and put it in context of my professional lifetime. So 1990, I call it yesteryear here, but in fact, it's not that long ago. And it was, in fact, possible to sequence the human genome back then. It would have taken 8 years and $3 billion with the technology at the time, but it was possible. And then in the year 2000, the technology had developed to the point where you could sequence a genome in about a year, and it would cost $100 million. Today, you can get a whole genome sequence we've reached the $1,000 holy grail. So for $1,000 in 24 hours, you can get a whole genome sequence. And with the increasing rate of technology development, we expect that very soon we can do whole genome sequencing on every patient that comes into the hospital, just like a CBC, because it'll only take 8 hours and cost $100. And you get a lot of data for your money. And the technologies are getting smaller and more portable, so you can do this multiple times at the bedside, at the home of the patient. These portable sequencers can be plugged into your laptop. So with these powerful tools, this is really what I'm here to talk about, come powerful risks for us. The technological capacity now exists to produce bad data with unprecedented efficiency. And we now have the ability to get the wrong answers with unprecedented speed. So we need to be careful because it's complex and it's getting more so. With the patient's genome, a cancer's panoply of genomes. So I'm sure all of you have seen the publications, for instance, the one in the New England Journal that showed if you just biopsy the primary tumor in different spots, you get different genomes. And if you biopsy a metastasis, a different genome from any of the ones in the primary. And then another metastasis again has another genome, and they differ from one another, and they don't match the primary. This makes your head hurt. So we have to deal with this kind of complexity. And cancer's evolving genome all the time. In response to time and therapy, and the genome's relationship to tumor behaviors and outcomes, which is really what we care about, needs to be linked to these other flavors of data that we produce. And the biological, pathological, and computational complexity of cancer are now all increasing exponentially. And across multiple scales. So we have to move from molecular scales. We need AI and complex signal deconvolution algorithms to figure out what's going on in these molecular systems and pathways and how they talk to one another and how this influences the behavior of the cells and the outcome for the patient. We need large-scale informatics, and we need patient profiling and rational therapies and health monitoring, all in the context of the question, can we afford it? So the value of all of this comes into the question. But I'm here to say you got to embrace the complexity because it's not going away. So this creates a different era for biomarker development. And biomarkers are the thing that drives product development. How do you get a new product to the bedside of the patient? You have to convince the FDA that the product is safe and effective. And how do you do that? You measure biomarkers and you show them the data. So right now, from pre-discovery in the laboratory, if you come up with 5,000 to 10,000 potential compounds that might be therapeutic, it takes you about 12 years and about $1.6 billion to get one of these to the FDA. And actually, that has been now reanalyzed by my favorite science writer at Forbes, Matthew Herper, who's looked at the hidden costs of drug development, the truly staggering costs, he calls it, of drug development, and thinks that when you look at the hidden costs and the secondary costs, it can cost between $5 and $11 billion to get one new drug to market. So what's the problem here? Time and attrition are directly related to the lack of validated biomarkers of efficiency and toxicity. No question about it. We don't have the measurements that we need to push this process forward. And this is just a graph to show you the sad state of drug development. It is not operating according to Moore's law. It's operating according to the opposite of Moore's law, which people have called Aram's law, because the number of new drug approvals per $1 billion spent has halved every 9 years. That's not good news. And my colleague, George Post at Arizona State, so we're all in the National Biomarker Development Alliance together. That's why I went to Arizona. Not for the dirt and the cactus. Because the smartest people that I worked with at the NCI all came together to form the National Biodevelopment Alliance to look at the big picture of what the problems were in this developmental process and design solutions and convene think tanks to get people who were invested in stakeholders in that issue to fix it. And that is one of the things that I'm doing in CAP, and we'll talk to you about in a few minutes. But George, for this article that he wrote for Nature, he's now updating it, but nothing's really changed, noted that if you read the literature, it would suggest to you that we're producing 150,000 papers that say, this could be a biomarker for fill in the blank, with more development and validation. And of course, the number that actually make it to the clinic that are routinely used in clinical care is a tiny fraction of that. So what's the problem? Why can't we get from discovery to clinical care? The NBDA, the National Biomarker Development Alliance, in a series of think tanks, defined this list of paralyzing persistent problems in biomarker development. Discoveries often start with irrelevant clinical questions. The scientists are disconnected from what the clinicians need and want. Rigorous, end-to-end, properly powered statistical design is lacking. Technical standards are lacking or are just disregarded. Data and metadata quality and provenance are inadequate to poor. And analytics are often inappropriate or inadequate for the sophistication, the complexity that I referred to. That's in the study. But this one hit home with me. Discovery is often based on convenient samples of unknown quality. Knock, knock, knock on the pathology department door. Can I have 150 colon cancer blocks? And this is what discovery is all about. And those blocks, I would suggest to you, even when I was chief of GI pathology at Mass General Hospital, MGH, Man's Greatest Hospital, were of unknown provenance. Unknown provenance. So their quality is unknown. And the proof in the pudding is it does have an effect on the approvals from the FDA and the EMA, the European Medicines Agency, of biomarkers for efficacy or safety, approved biomarkers that can be used regularly in clinical trials for measurements. They have declined steadily over the last 15 years. And the biggest problem with this is non-reproducibility across labs and studies. So this is a rampant problem, and it's a crisis for us in biomedicine. It came to my attention when this study hit the front pages of multiple newspapers. This one is the Los Angeles Times, and it's about 5 years ago. And it was written by reporters who had talked to the investigators. Basically, this was a study in which Amgen decided to go back to the discovery research that suggested that a putative compound might be a good drug. And before going all the way to the end of the process and wasting billions of dollars in clinical development, decided to we'll just go back and see if we can reproduce the discovery data. And I'm talking about publications in our best journals, Cell, Nature, Science. And after this, you might wonder if, those aren't our best journals of irreproducible results. Because what they did was even go to the labs of the investigators to try and find the secret sauce. Oh, by the way, they also signed non-disclosure agreements, so we still don't know what publications we're talking about here. And of the 53 landmark studies in oncology and hematology, only 6 could be reproduced. 11%. Even with the investigator, they couldn't even reproduce their own data. So there are other high-profile examples. I went digging with my friends in the federal government because if you use federal money, you have to have the data be disclosed. So I was able to get data on these kinds of failures. It's not easy because people don't like to make it public, but when I was just going to the NCI, there was a very high-profile paper that came out of the NCI suggesting that a mass spec diagnostic profile could differentiate any kind of ovarian cancer from patients without. And when they looked at the data, it was all based on bias because the control and experimental groups had been run differently and separately. There was no veracity to it at all. And this was so high profile, it went all the way to Congress. The Congress was wanting to pass a bill that would suggest that every woman in the United States should get this test, all based on bias. 5 out of 7 of the largest epidemiologic cancer studies didn't classify patients better than chance. I love this one. Microarray drug sensitivity signatures from cell lines to predict patient response. It was named one of the top 100 breakthroughs in biomedical science in 2006. Couldn't be reproduced 3 years later in a large clinical study. Of 18 published microarray studies, only 2 were reproducible, published in Science. And Bayer Corporation had actually done something very similar to Amgen a few years earlier and got a slightly better reproducibility rate, 20 to 25%. But that's terrible. It would actually suggest that flipping a coin would be a better way to make business decisions about drug development than scientific data. And this also caused a crisis in the public view. This got to the popular press. And Science and Nature basically passed it off. They recognized it, but they thought that it was part of the culture. This was a cultural problem in biomedicine, that few scientists repeat their own studies. Publications are often based on the one time out of 5 that you ran the experiment and it worked. And external validation, give your SOPs to somebody else and see if they can come up with the same answer, is rarely, if ever, done. And everybody has an excuse. I don't have the money to do that, but I am not sympathetic. So we really need to change the culture of biomedicine. And now also it's become clear, because there's a watchdog now. So I don't know, how many of you have heard of Retraction Watch? Oh my God, it's my favorite sport now. You have to sign up to this website, because it will be shocking when these are people. This is a not-for-profit that actually tracks fraud, retractions, all kinds of things that are usually sub rosa in biomedicine, and now is making them public, and published this in Nature, that the percentage of retractions in biomedicine has gone up 400% in a year. This is 2010, despite the fact that publications had gone up 44% in 10 years. So you see this incredible increase in the numbers of retractions from our literature, but it's really hard to know what's good and what's bad because, well, first of all, this has become much more public, that we do have some bad behavior in our field. And just this week, 2 high-profile biomedical scientists, one from Memorial Sloan Kettering and one from Dartmouth, resigned because of plagiarism and because of lack of making their connections with industry public. And then there are those that are just honest error. But there's still a lot of irreproducible results that are just sloppy science. So the newest twist on this, this is why I love Retraction Watch, there's always something to learn about how people cheat. And the newest one is fake peer review. You make up your own reviewers, or you review your own papers with a new email address. This is also quite common. And in fact, even if you get your paper retracted, it doesn't keep people from citing it in high-profile situations. So many papers, including the #1 most cited paper, receive more citations after they were retracted than before. So this one, look at this. This is about a protein that mimics the effects of insulin, and it was published in Science. So the citations before retraction, 276. After retraction, 972. And then 5 years after the retractions, half of this guy, Scott Rubin's, articles are still being quoted. He was an anesthesiologist who just fabricated data and went to jail. And people are still citing his work. So this isn't good either. And this is a friend of mine, actually, who... This is Richard Harris, who is an NPR reporter who got interested in this whole issue, and I recommend this book. It's a good read, and it's short. It's called Rigor Mortis. It's a play on words about the death of rigor in biomedical science, sloppy science. And here's, his conclusion, really. And it doesn't... we're talking about investigators at every level of the spectrum. So it's important that you understand that people can get away with things for a very long time. And I referred to this earlier, but because we don't know what's been retracted and because much of what's in the literature is wrong, we have a problem about knowing what's really true, what we can really trust, and how can we, on the basis of this, develop reliable, useful biomarkers. It's not easy. So we're facing a difficult situation in which we have all of this data, all this powerful technology, and on the other side, we've got investigators who either don't know what they're doing or are cheating. And this is the environment in which we have to work. So John Ioannidis, one of my heroes, has now spends his professional life looking at why most published research findings are false. And he has named here the top 3 as lack of external validation, which I mentioned before, which needs to be a norm, not an extraordinary event, inadequate power of studies and flawed design, and bias. Now, bias is a word that covers a lot of territory, and I'll talk about it in a second in relationship to our world and specific. But I thought this was interesting because Ioannidis had these corollaries to his studies, saying that the smaller the study, this helps you go through the literature, by the way. The smaller the study, the smaller the effect size, the greater the number of tested relationships, the greater the flexibility in design definitions, outcomes, and analytical modes, the greater the financial interests and prejudices, and the last one I love, the hotter the scientific field, the less likely the findings are to be true. So this is a word of caution. And this is why I'm here as Chief Medical Officer of the National Biomarker Development Alliance. We were looking at all of these problems together, the landscape of biomarker development, trying to figure out where the constriction points, where the big problems were, figure out solutions, and convene people to fix them. So we're a think tank. We bring people together, and through a series of think tanks to understand biomarker development, we in fact started with, I was highly biased, so I pushed this to start with biospecimens, the garbage in, garbage out problem in biomedicine. And this is not a new idea. David Ransohoff and Margaret Gurley, fellow pathologists, wrote this paper in JCO a few years ago talking about bias in studies being related to specimen collection, specimen storage and handling, and specimen analysis. So these two are pre-analytical. This is analytical. This is where we put most of our focus. We don't put enough focus on the pre-analytics. Everything that happens to the specimen before it gets to the machine that spews out all the data. And the analytical tests that we're doing, as I said, are getting more and more complex. And this is actually raising the bar for molecular quality of biospecimens. So it's urgent that we pay attention to this, and yet we don't. When I looked at, now, this has been my problem since I went to the NCI. I was recruited there to start a national biobank for the United States, and also they said, well, you got to fix this problem of garbage in, garbage out in NCI-funded science. I couldn't do that because it starts at the point of care. It starts at the bedside of the patient, someplace where the federal government should not be penetrating. That's why I left back in the private sector, working with CAP to try and do this. But this is the vision, even that I had at the NCI, that biospecimen collection, handling and processing, before it gets to the analysis, really determine the quality of the molecular data and what you do with it, the quality of the outcome. So it's a seamless feedback loop here. The loop is going to patient management, pathology department results, to managing patients and those decisions. But the same thing will happen in clinical trials, exactly the same thing. So the quality of what happens down here directly determines the quality of what happens up top. And yet all the focus goes to that. Without precision pre-analytics, I firmly believe this, we won't have precision medicine. So pre-analytics include all of the factors up to the moment of analysis, and they can artifactually alter both the biospecimen molecular content, because it's still alive and still reacting to major biologic stress. So it's translating and transcribing and all kinds of different genes that it wasn't when it was part of the patient's anatomy, all artifactually. And the molecular quality of the specimen, because the molecules begin to break down. And the most important of these require rigorous, real-time, upfront management and documentation. I've got my bulletproof vest on underneath this because I realize that this is not what we're doing and it's not easy. But if you don't do it, you can't go back, and technology won't fix it. So when I had my first think tank on biospecimens, I actually had all the stakeholders there from the government and the funders and the payers and the patients and pathology. CAP was there in force. But I got the CMO of Illumina to actually stand up and say, yeah, even our technology can't fix a bad sample. Well, yes, you should be saying that in public because you're misleading people into thinking that your technology can spin straw into gold. It was making me crazy. So this is a realization that we have to embrace. And in pathology, and I know you all know this is true, we're very rigorous. We're very rigorous about the place where the test is done. We have CAP and CLIA laboratory accreditation to oversee that and enforce it. We enforce the quality of the people doing the test, their education, proficiency testing, licensure, all controls that. We along with the FDA, put a lot of emphasis on the platforms used for testing, the validity of the tests, and the validity of the data that they generate. And of course, the processes in your lab for testing, the standard operating procedures and the total quality management systems that you have in place. All of this we rigorously control. But for patient samples to be tested, we control pre-analytics for one type of sample for one type of patient. And that would be breast cancer samples from breast cancer patients, and all the rest of the patients and all the rest of their samples are not controlled. And I don't think that this is the right thing to do. We know more about the quality of beef in the supermarket than we do about patient specimens in our labs, because the USDA regulates the quality of biospecimen, or of beef, and we do nothing. And in fact, so I tell you a story about Mass General, great hospital, but I was both in CLGB doing research with with colon cancer patients and diagnosing colon cancer patients at Mass General, and was looking at the pathway from patient to laboratory in this great hospital. And of course, what happens is the colon cancer comes out, it gets thrown into a bucket, it sits there, desiccating until the circulating nurse comes over, puts it in a bag, stamps it. Then when the operation is over, puts the bag in the holding refrigerator. So now the temperature excursion is, up and down, body temperature, room temperature, refrigeration. And then at the end of the day, the same guy who delivered the mail at Mass General comes by with his cart, picks up all of the specimens in the whole room, takes them to the pathology department after he has his coffee in the cafeteria, and then it goes to the pathology department where they're all sitting in a big pile while the accessioner gives them a path number and moves them over to the other side of the computer. Then they go into a refrigerator, and if it's 4th of July weekend, the resident comes in Monday night and grosses a specimen, puts a piece in formalin. Now that living tissue, 4 days later, is being stabilized. And that is the piece of tissue that will be used for patient management and for clinical trials research, and will be forever the quality of that sample in the patient's block. So at the end of the day, it doesn't matter how good your test or how good your hospital, or how good your lab, or how good you are. Garbage in, garbage out is always going to be the problem. And when you look at the life cycle of a biospecimen, so even before the specimen comes out, it's subjected to a lot of atypical biological stresses of being exposed to antibiotics, drugs, anesthesia. It comes out, and then the surgeons and the pathologists and the PAs are involved in all of these pre-analytics with the specimen in their hands, and then you stop the biologic activity by fusing or fixing, and then it goes into analysis. But there are both pre-acquisition and post-acquisition pre-analytics. But the only one that we can really control is the one that has to do with the activities in the pathology department. But it's not the only activities that need to be controlled. So I just want you to know I'm aware of that, and we're going the next step to fix that too. But you're familiar with this data. This is David Hicks's data showing you that if you just let a HER2-positive breast cancer sit around, it will test HER2 negative after two hours. And if you're looking at other, biomarkers, depending on what it is, it may be downregulated or upregulated. In this case, it's an upregulation, but it's artificial. And Hartmut Juhl, who's the CEO of Indivimed, he's a surgeon who started his own company because he's a proteomicist and couldn't get specimens of high enough quality to do his own proteomic research. So he decided he was just going to start a company and do it himself. But he says without knowledge about tissue processing methods and assurance of rapid tissue fixation, protein expression data are unreliable, and understanding of pathway activity, which we must do, is impossible, and I completely agree. And here's some data that Hartmut produced with surgeons back in Germany, showing that it's changing even before the specimen comes out of the patient, but intra-op specimens, biopsies, and then biopsies of the same specimen post-op showed a greater than twofold change in the expression of more than 15% of genes and 60% of selected proteins. So the bottom line here, my message is, it matters. And if you're measuring something in the laboratory with such accuracy, it should reflect something real in the biology and pathobiology of the patient, and it's not just tissue. So this is the counterpart of the pathway for bloods, and we know that these things matter and affect the readout of molecular testing, the blood draws, the collection tubes, even stuff like inversions. Did you invert it 10 times? Did you mix it enough? Did you fill the tube enough? These are things that people just, first of all, we don't enforce these kinds of things, even though they're bread and butter and we know they're important. So at the end of the day, you end up with a tube. Again, that's an unknown in terms of quality. And just a couple of years ago, the IOM, the National Academy of Sciences, Engineering, and Medicine, spoke up about this. They had a committee devoted to biomarker tests for molecularly targeted therapies, the key to unlocking precision medicine. One of the 10 stated goals that this committee came up with specifically addressed biospecimen quality. Their suggestion was, in short, enhance specimen handling and documentation to ensure patient safety and accuracy of biomarker test results. Amen. They went on to say that the reliability of biomarker test results depends on the quality of the patient specimens, and professional organizations and healthcare institutions, professional organizations, that would be us, should develop and implement standards for obtaining adequate specimens. So, the NBDA convened a series of think tanks devoted to specimens. And this is not, this is not easy. It's not that biomarker development is actually a team sport. So here you have Laura Esserman. She's the PI of the iSpy trial, and here we're at the National Press Club, and this is Janet Woodcock from the FDA. I mean, so there are a lot of people who have to, stakeholders who have to weigh in on this process. Here was the actual think tank, and you may see some of your friends here. You can blame them. So this was, CAP was here in force. I had the immediate past president, the current president, the president-elect there. They were part of this process. We were going to define this process and a solution in 4 days of me locking them up in a ballroom in Scottsdale, Arizona. And guess what? They actually, along with the other stakeholders who all weighed in, because everybody has their own vision of what quality is, we had all of these flavors of people. So we had, now that I notice, this is Rich Shilsky. So he's the chief medical officer of ASCO. So some of these people pipe themselves in remotely. But this is the kind of broad spectrum stakeholder group that we had convened. And we got them all to agree, which was a miracle in and of itself. It's probably because they wanted to get out of the ballroom. But what they did was come up with a top 10 list. They all knew from their experience and their expertise that not all pre-analytics are created equal, that some of them really bugger up the specimens and lead to unreliable results and were their biggest problem. So they had to agree on what the most important of those were for blood and tissue. So this was to identify where the, oh, I'm sorry, I went into a hole there. Can I sue? No, I'm sorry. Yeah, I'll get myself away from this. So this was to identify where the biggest bang for the buck would be, the biggest value if we went forward and tried to change these things. It was based on this. I love this, Pareto principle. If you haven't heard it, it comes from the business world. And it's basically a principle of inputs and outputs. And it says basically that in any big organization, 80% of your problems come from only 20% of your issues. And if you can identify those 20%, you'll be a long way toward process improvement. It won't be perfection, but it will. This is what we need. We need to apply the Pareto principle to what we do. So I took the top 10 list from the think tank back to CAP. And CAP put me on the Precision Healthcare Committee and allowed me to put together what was called the PPMPT, the Pre-Analytics for Precision Medicine Project Team, which were a group of experts from across CAP. And we spent nearly 4 years validating from the literature the top 10 lists. We just finished. I've just written up the manuscript representing this work. It's been through the CSA. It's coming back to me now for revisions. But basically, we defined where the big problems are. And this is bread and butter. This is what your grandmother told you. You know, the time to stabilization, the method of processing, specimen thickness, volume of fixative, the method of stabilization, the time, total time in fixative turns out to be major, people. Total time in fixative, even maybe more important than cold ischemia time. Processor variables, paraffin type and storage conditions. This is, again, here for blood. Tube, draw order, method of stabilization, tube inversions, method of processing, centrifuge speed and time, and temperature and storage conditions, the number of freeze-thaw cycles. These are just basic, but we do not enforce them. In fact, we don't even know what's going on in most of our settings for any of these things. We need to change. And the actions are that we intend, the PPMPT, after publishing our findings, wanted to turn the top 5 lists, or the top 10 lists for both specimen types, into performance metrics. Oh, I keep doing this. Performance metrics for pathologists. So we benchmark them against other organizations' recommendations like CLIA, ISPR, ISO, NCI, none of which enforce their recommendations. And we wanted ours to be data-driven and practical and practicable, implementable in every practice setting. And here's the basic stuff. Specimen thickness, less than 5 millimeters. And here's some of the big ones. So we want everybody to be using 10% neutral phosphate buffered formalin. That sounds like an ancient, something that was, that the scribes back in Egypt were writing on hieroglyphs. But it's not carried out. And here's the big one, as I said, total time in fixative, at least 6 hours to get adequate cross-linking, but no more than 24. Push it to 36, but the studies show that molecular compromise, molecular breakdown, excessive cross-linking starts to occur at 24 hours. And the latest data from the NCI, which is contract research from my old office, is bringing that down even further, suggesting that maybe even 12 hours you start to get molecular damage. Paraffin type has to be low melt. You can't be frying all of your specimens. And of course, this is the time in processor has to be included and tracked. That we have to collect this data, or at least any deviations from the recommendations. And you know how it goes in the lab. Grossing the specimen, and a piece goes into a bucket. That's actually time 0, but nobody knows when that is. And then the bucket sits there all day, and then you put it on the processor, and then the processor starts. And the total time in formalin is rarely known. And it's certainly not part of the pathology report in the way it should. Now, if we did this, it would transform the reliability of data that we generate in the pathology department. And people in the research world are starting to take notice as well that, oh, okay, those pathologists are starting to step up. This was a reporter who came to one of my education sessions at CAP. But this is my vision. This is, in fact, I'm going to die doing this or die trying, but this is something that I think we cannot afford not to do. It's the right thing to do for patients. It's the right thing to do. We're all invested. Who pays for that research at the NCI? We do. $5.6 billion of our taxes go into that. So we're invested in this scientifically. And how is medicine going to evolve for patients unless we do this? Transformation of practice will be far-reaching. The variably variable and unknown quality of our specimens will be transformed into uniform known quality that is consistent with fitness for purpose. Not every test that we do, it won't be perfect, but it will, in fact, if we want to put balls on this tree, if we want to raise the bar even further, we need a bar to raise. And convenience samples will actually be good, will actually be fit for purpose. So I'm thinking, this is my last slide, but I know this isn't easy, and this is not a message that I enjoy delivering, except that we're all in this together, and the possibility of actually changing it truly exists. And it's just thrilling. And I want you to know that I'm cognizant of the fact that you rarely know when time zero is for cold ischemia time. When did it come out of the patient? You don't know because the surgeon doesn't tell you. So surgeons are involved, those circulating nurses, those transport people, the PAs, the phlebotomists are all part of this. So at the end of March, I'm holding another think tank with all of these people in the same room, teaching them where they sit in the trajectory, the biospecimen quality pipeline, making them own their part of it, and making them come up with their own SOPs, and then making their SOPs align. And like the CAP vision, having their professional organizations enforce the right thing to do. So thank you for listening, and onward and upward. Get in here.
Very eye-opening talk. Next, let's welcome Professor Kay Washington. Today she'll talk about the biomarkers of upper GI tract. Some would link to the colon.
Thank you, Dr. Cagle, and the other organizers for allowing me to speak here. I think I need the clicker. Carolyn? Oh, here it is.
Oh, did I? Yeah. Oh, wait a minute, I'm still on. Oh, geez. Do you need this, Kay?
I think I'm okay here. Well, sure. I have the sad fate of following Carolyn.
Just watch out for the hole.
Sad fate. So we're going to be talking about the mundane biomarker testing. Yeah, is this on? Okay, thank you. This is just a picture from the Vanderbilt Historical Archives, and my office is actually, in the old building. Where's the pointer? Right here. But the rest of it is unrecognizable. It must have been taken in the 20s if you look at the cars down at the bottom. But I hope we've moved a little bit further along. So what I want to talk to you about today is the rationale for testing upper GI cancers. What tumors, why should we be testing them, and which patients should we test? And how to test and how to report. I'll touch briefly on microsatellite instability or mismatch repair protein testing. touch briefly on PD-L1. You're going to have, 2 hours of PD-L1 specific talks, so I don't want to belabor that. But I'll spend most of the time on HER2 testing in gastric and esophageal adenocarcinoma. And as you know, these are very, very common cancers worldwide, 5th and 8th in the world. Esophageal has squamous cell carcinoma, not such a big problem in this country. We tend to forget that in some Asian countries, such as China, esophageal squamous cell carcinoma is still a huge public health problem. Gastric is one of the most common cancers worldwide. These are both often diagnosed at advanced stage, and obviously the therapies are limited. I'm not going to talk a lot about squamous cell carcinoma, but focus more on the adenocarcinomas of stomach and esophagus. And as you know, as pathologists, these have a protean microscopic appearance from the old intestinal type gastric cancers that we talk about to the diffuse signet ring cell, non-cohesive gastric cancers as well. But this has all been put in the framework of a molecular classification from the TCGA, which I find really fascinating for gastric cancer. The TCGA has divided gastric cancers into 4 molecular subtypes. The EBV-driven, about 10%, microsatellite instability high, we're coming to recognize as an important subtype of gastric cancer. It's about 1/5 to 1/4 of cases. The genomically stable cancers are our old diffuse linitis plastica cancers for the most part. And then the biggest group is the chromosomal instability subgroup, which are mostly the Lauren type intestinal cancers. And there are other molecular classification schemes. There's an Asian gastric cancer group that has also 4 different molecular subtypes. They overlap with the TCGA. They're not exactly analogous, but I'll stick with the TCGA. TCGA has also done analysis of esophageal cancers, and we're finding that esophageal squamous cell carcinomas have more in common with squamous cell carcinomas at other sites than they do with esophageal adenocarcinomas. As you move down the esophagus, of course, you start to pick up the esophageal adenocarcinomas and at the GE junction as well. And these cancers are more analogous to the chromosomal instability gastric type cancers for the most part. It's not until you move into the stomach proper that you start to pick up more of the microsatellite instability cancers and the genomically stable cancers. So there's a clear distribution along the anatomic axis of these molecular subtypes. The EBV positive gastric cancers are pretty rare. They're only about 10%, maybe 90,000 cases per year, 3% at the gastroesophageal junction. You essentially don't see them more proximally in the esophagus. They have the best prognosis of the 4 molecular subtypes. But I think relevant to marker testing is that this type is going to have very high levels of PD-L1 for the most part, and alterations in other genes as you see there. They rarely are p53 mutated. And this type has extreme CpG island methylation and phenotype. And they have a distinctive histologic appearance, but I will warn you that this appearance overlaps significantly with the medullary type of microsatellite instability high cancer. We did a little study in our institution looking at our solid gastric cancers with a lot of lymphoid stroma, and we couldn't tell the EBV from the microsatellite instability medullary type just looking at the H&E slides. So I would say to you, if you have this type of cancer, go ahead and do the markers, do the EBV and the microsatellite instability to tell them apart. And we found that the EBV ones tend to have more lymphoid aggregates within the tumor, and sometimes more eosinophils, which was a curious observation. They tend to have very high levels of PD-L1 here in the tumor cells, but they can also have it in the infiltrating lymphocytes as well. The microsatellite instability high gastric cancers, like right-sided colon cancers, older women, they're in the distal stomach, fewer positive lymph nodes, higher tumor mutation burden, mostly hypermethylation of the MLH1 promoter, although you will pick up some Lynch syndrome patients by doing this testing. Better survival than our genomically stable subtype, but worse than EBV. And they do also have strong expression of PD-L1, but may not show the same benefits from the targeted therapy. And these can have a variety of histologic appearances. I don't think you can really predict from looking at them, but it's like colon cancer. You may have a medullary type, and you may have a mucinous type with this rather lacy appearance to the tumor. But I would go ahead and do the testing. Here's an example of microsatellite or mismatch repair protein testing. In a case of gastric cancer, this is one of those solid subtypes. And you can see there's loss of MLH1 and PMS2 in this cancer, but preserved MSH2 and MSH6 nuclear positivity. And that's about what we expect in most of them. They're due to hypermethylation of the MLH1 promoter for the most part. The genomically stable gastric cancers tend to have a low mutation burden. They're resistant to adjuvant chemotherapy, and they do have the unique mutation patterns of alterations in the cell adhesion pathways. About 37% will have E-cadherin mutations, and we all know that these are these poorly cohesive subtypes. Signet ring cell carcinomas often don't form a grossly visible mass. The chromosomal instability gastric carcinomas are about half of gastric carcinomas. They'll are an intestinal type, and they can have amplification of HER2, FGFR2, and VEGF-A. And they have a variety of histologic appearances, mostly gland forming. Now, to get to the guidelines for biomarker testing, what are we doing right now? Well, the current NCCN guidelines are that you should do mismatch repair testing or microsatellite instability testing on all the locally advanced, recurrent, metastatic gastric or esophageal adenocarcinomas in patients who are candidates for treatment with PD-1 inhibitors. That's probably a little bit more restrictive than a lot of us are doing, especially in the academic centers, but if you take the NCCN guidelines as standard of care, you'll be testing on these patients who are candidates for this type of treatment. And that goes for the PD-L1 testing as well. PD-L1, you use the combined positive score, where you score the total number of positive cells divided by the number of viable tumor cells and multiplied by 100. And you only need a score of 1 for gastric and esophageal cancer to be considered PD-L1 positive. There is an FDA-approved companion diagnostic for patients being considered for treatment with pembrolizumab. And this is just a schematic showing you that the tumor cells express PD-L1 and PD-L2 as a mechanism to escape immune surveillance from the T cells. And pembrolizumab in particular has shown activity in gastric cancer. And this is just from the FDA website showing you that the approved one is the IHC 22C3 test. And this the clinical trials of pembrolizumab use this clone. Other trials of other PD-1 or PD-L1 inhibitors use a different test, and so that is not totally necessary to use the FDA-approved one, but that's the one that's on the website. Now, PD-L1 is positive in about half of gastric cancer, and the pembrolizumab trial showed an overall response rate of up to about 30%. That's been less with nivolumab and some of the other PD-1 inhibitors. There have been trials with esophageal squamous cell carcinoma and adenocarcinoma. A lot of these trials are ongoing, or they're in phase 3 at the moment. And notably, PD-L1 positivity enriches for response, but it's not that sensitive and it's not that specific. So the overall response rate in the Keynote trial was 15.5% in the PD-L1 positive patients versus 5.5% in the PD-L1 negative patients. Now, obviously more study of biomarkers is needed for this. It does enrich for a population that will respond, but it's not entirely specific. And if you pay attention to the literature coming out of Asia, these Asian versus non-Asian gastric cancer cases have different CD8, CD3 ratios of tumor-infiltrating inflammatory cells, and there may be a less favorable outcome for non-Asian adenocarcinoma. PD-L1 is expressed in tumor and stroma across all stages and histologies. It's slightly more common in HER2-negative cases. And the odds ratio for EBV cases is high, 15.5 compared to all comers, and it's pretty high for MSH high cancers. So these are the subtypes that are more likely to be PD-L1 positive. And I thought, just thinking about the pathogenesis of gastric cancer, it was interesting to see that there are data showing that H. pylori induces increased PD-L1 expression in gastric mucosa. So kind of an interesting way to think about the pathogenesis there. This is just an example of PD-L1 in a gastric adenocarcinoma. You can see that here we've got stromal infiltrating inflammatory cells plus tumor cells positive. Here it's mostly tumor cells, and those obviously are greater. The CPS would be greater than 1 in those cases, so they would be considered positive. There are also pretty good data. There are a couple of systematic reviews of PD-L1 as a prognostic factor in gastric cancer. And again, this may be tied to those molecular subtypes having a better prognosis that tend to be associated. But you can see that for the most part, the PD-L1 negative cases do have a slightly better prognosis in two recent systematic reviews. And let's see. And it may be even more important as a prognostic factor in squamous cell carcinoma. There are a limited number of studies here. This is a systematic review. And notably, it's difficult to compare studies sometimes because some studies used a 1% cutoff as positive, some studies used as high as 5%. So that is one explanation for this extreme variability from 14% in one study to 82% in another study. So we really do need to decide on the cutoff for these. PD-L1 expression does appear to be higher in squamous cell carcinoma than adenocarcinoma. And of course, that has relevance given that the approval for targeted therapies in all solid tumors. So the squamous cell carcinomas that you see may very well be eligible for treatment with PD-1 inhibitors. So you certainly should be open to testing them. So those are the kind of new things we're looking at. But what about HER2? This is one of our first personalized medicine factors for upper GI cancers. And it's a predictive marker for trastuzumab response in esophageal GE junction and gastric adenocarcinomas. And of course, our recommendations are based pretty much on the TOGA trial, even several years later. And this was a randomized phase 3 trial of trastuzumab in patients who were positive for HER2, an international study. And largely on the basis of this randomized trial and other data, we were able to put together from the CAP, the ASCP, and ASCO the guidelines for HER2 testing and clinical decision-making in tumors at these sites. And this was published in late 2016 in these 3 journals and led by Angela Bartley for CAP. The target audience for this guideline was oncologists to help them decide how to identify appropriate patients, which patients to test, and importantly for the pathologist, how to approve the appropriate specimens based on the information we had at the time, how to do the tests, and how to interpret and report. As you know, trastuzumab blocks binding of EGF to the HER2 protein and prevents a lot of downstream signaling pathways in the cell. I don't want to spend a lot of time on the molecular biology. The TOGA trial, the initial analysis showed that there was about a 2.7-month improvement in survival with trastuzumab in HER2-positive gastric cancer. That doesn't seem huge, but there were some patients with durable responses, just as with any targeted therapy, and it had been quite some time since we saw this measure of improvement in survival for gastric cancer. The subsequent analysis did show that this time is a little shortened, but still this remains a mainstay of treatment for metastatic, recurrent, or locally advanced gastric cancer and esophageal cancer. Our main testing modality for the biomarker is HER2 expression by immunohistochemistry. Now, who should be tested? Well, really, the indications now are these locally advanced, metastatic, or recurrent tumors. Would it be useful in the adjuvant setting? I think we're still trying to sort that out. And should it be done reflexively, or should you wait on your medical oncologist to ask you to do it? And I think that really depends on the local needs, the local context. Those of us in academic centers are doing the test up front in a lot of the cases, but depending on your practice environment, you may wait for a request from the oncologist, and either is appropriate. So what should we be testing? I think this is something that's still up in the air. We really did not have data to favor any one specimen over another, other than on the basis of specimen quality. So should you test the primary, the biopsy, or the resection, or the metastasis? Well, there was pretty good concordance between biopsy and resection specimens in the clinical trials, and the TOGA trial had similar rates of positivity for biopsy versus surgical specimens. And there have been other studies since that showed no difference in HER2 positivity between resections and biopsies of the primary or the metastatic disease. But I think this may be due to limited numbers of patients, and we need to keep looking at this. So our advice in the protocol, in the guideline, and my advice to you is choose the best block. You may not have great material, in a patient who's been treated and has a resection after a neoadjuvant therapy. You may have to go back to the biopsy. It's appropriate to test cytology specimens, and we've heard about good practices for that, but you do need to validate your assays on the cytology. How many biopsy fragments are needed? We actually had a gastroenterologist on the guideline, and he allowed us to say a minimum of 5. This was based on not great data, but it's a pretty good recommendation, I think. Optimally 6 to 8. So your gastroenterologist needs to do more than one biopsy of a tumor. It's very frustrating for us to get a single biopsy fragment. If there's concern for adequacy, be open to retesting the patient if you get more material. Tell a clinician if it's negative, I have doubts about the validity of it, and it's probably a good idea to document the number of tumor-containing fragments when you have just a few. There was a nice study recently that did document that maybe our choice of 5 was a pretty good choice. They looked at the positive rate increasing with the number of tumor-containing fragments. And when they got to 4 versus 5, this was actually not statistically significant, but it does make the point that 4 or 5 would be a good minimum number to shoot for. And this is just an example of a biopsy with adequate tumor. There would be about 6 to 7 fragments there. What about the histologic subtype? Gastroesophageal and esophageal are more likely to be positive than stomach because the distal gastric cancers are not as prone to be positive. The intestinal subtype, as we saw from the molecular characterization, is more likely to be positive than the genomically stable type, the diffuse subtype. And the rare subtypes, there are not a great amount of data on this. I did see a recent paper saying the hepatoid variant of gastric carcinoma is usually positive for HER2. But we don't have much data. But we do have some data on grade. In general, the lower the grade of the cancer is, the more likely it is to be HER2 positive. So pick your blocks with the best formed glandular areas. But there's a caveat. Most of the studies don't specify grading criteria. And maybe you should consider testing more than one block if the tumor is really heterogeneous, which is a problem in gastric cancer. And there is a study out there saying that testing 2 tumor blocks from resections was more likely, obviously, to give you a positive result. So what testing algorithm did the guideline come up with? Well, we recommended starting with immunohistochemistry. If it's 3+ positive, you're done. Patient's positive. If it's 1+ or negative, you're done. Patient's negative. The 2+ or equivocal should go on to have in situ hybridization testing. Now, what was the basis for that recommendation? And not everybody agrees with it. Some people advocate universal in situ testing plus IHC. The basis was the TOGA trial data. Patients who were amplified by FISH but did not overexpress HER2 did not benefit from trastuzumab in TOGA. And there have been some subsequent negative clinical trials of HER2 blockade, but they allowed in a lot of patients who were amplified but IHC negative. And if you really look at that data on a more granular level, those patients probably didn't benefit and brought the trial down. So the benefit of therapy in gastric and esophageal appears to correlate with protein overexpression. About half the IHC2+ cases will show amplification, and they are considered eligible for treatment. Because our goal here is to help determine eligibility for treatment, we don't want to get false negatives. So if you're uncertain whether a score is 1+ or 2+, I would go ahead and test. Our goal is to avoid false negatives here. And any of the in situ hybridization methods are appropriate. Just choose whichever one you prefer. Now, if we really look at the breakdown of the HER2 status in the TOGA participants, we see that there were actually only a few patients, 23 and 38, who were FISH positive IHC 0, and a few more who were IHC 1+ FISH positive. So we're basing these recommendations, we realize, on small numbers of patients. If you look at the exploratory post hoc analysis of those IHC negative FISH positive folks, they did not benefit, but the IHC 2 positive, FISH positive, or the IH3 positive folks are the ones who did. So it appears to be the protein overexpression, but more data would be useful. We did not make a recommendation as to which antibody to use in the guideline because we didn't have enough data for that. The TOGA used Hercept test, but other studies have used Ventana or Thermo Fisher antibody, and of course others are available. It depends on your laboratory. It just has to be validated for your test. There's generally moderate to good concordance among the antibodies, and we did not make a specific recommendation. The 4B5 antibody gives you more 3+ in a head-to-head comparison compared to Hercept test, but this may be laboratory dependent too. Importantly, in gastric and esophageal HER2 testing, you do not use the breast guidelines. You use a specific scoring system for this anatomic site, and it's based on the reactivity, the intensity of the expression, and the percentage of tumor cells. To be positive in a biopsy specimen, you need only a cluster of 5 tumor cells or more to be positive, and you do not need complete circumferential membrane expression. You need at least 10% in a surgical specimen positivity. So start with IHC, exclude nonspecific staining, and I'll show you some examples of that, and look for membranous staining. Doesn't have to be circumferential. Watch out for granular punctate staining. That is not counted. And then you assess the staining intensity, and the Hoffman-Ruschoff method specifies which microscopic objective you should see the intensity on, and that's an attempt to overcome inter-observer agreement variability when we're assessing intensity of staining, and that can help. Now, 3+ is easy. It looks brown when you pick it up. I mean, you don't really even need a microscope to see 3+ in gastric or esophageal HER2, and these are some examples here. And it correlates very well with extreme amplification on FISH. Now, here I would call this one 2+. We've got over 10% of the tumor cells, pretty good staining there, and nice linear staining pattern. 1+, how many would go 1+ on this one? 2+? I would call this one 2+ because I want to see the FISH on it. I would hate for this patient not to be considered for therapy that might help them. So I'm gonna err on the side of 2+. This I would call 1+. It's pretty faint. You would have to go to a high power to see it. If you want to test it with FISH, that's perfectly appropriate. Again, our goal is to avoid false negatives. And this I would call 0. I'm seeing a little bit of punctate staining on high power, but nothing that's really linear. And that's a diffuse type or non-cohesive, so you really don't expect it to be positive. What are the pitfalls in IHC expression? Watch out for gastric intestinal metaplasia. You should be scoring only invasive tumor. Don't score dysplasia. Watch out for edge effect and nonspecific staining and marginated cytoplasm of signet ring cell cancers. Here's expression in foveolar epithelium, some nuclear and cytoplasmic staining, a little bit of membranous staining, but that's not invasive tumor. That's the foveolar epithelium. Here it is cytoplasmic staining in intestinal metaplasia, all nonspecific. It's not the invasive cancer. You're not going to score it. Here we have some nuclear cytoplasmic staining, a little bit of staining along up in here that I would probably score as 2+, but these other areas are nonspecific. Now, gastric cancer can show an extreme degree of heterogeneity, and you need to watch out for that. We've got some 3+ on one biopsy fragment, 2+ on another, and other fragments are negative here. So how can we increase our inter-observer agreement? Well, use the magnification rule because that will help us with scoring based entirely on intensity. Should we be making a case for going for digital scoring on this? Maybe. But the TOGA trial wasn't done that way. TOGA is still, the clinical trials are what we need to go back to and look at those slides because they have the outcome data. Our doing retrospective studies on cases from our files without really knowing the outcome and the treatment status are not going to help us with this. So 3+, visible to naked eye, strong membrane positivity on low magnification, 2+, 10x objective, 1+, 40x objective. So I think if you remember that, we'll become more, our inter-observer agreement will improve. Fluorescence hybrid in situ hybridization, we use the HER2 CEP17 ratio. The greater than or equal to 2 is considered amplified or positive. And we do have the problem of polysomia and all the difficult to interpret in situs in gastric cancer. With the new breast guidelines coming out, the 2018 breast guidelines, they do not look at HER2 for gastric cancer. That's just for breast. So for gastric cancer, if you have a problematic in situ hybridization case, use the 2013. It's analogous to the ASCO-CAP 2013 breast recommendations. So we have not looked at the new guidelines for those difficult in situ hybridization cases yet in terms of gastric cancer. So the best thing to do is to localize your area of invasive tumor, look at intense HER2 expression areas from your IHC, and pick the morphology of the malignancy, look at the morphology of the malignancy to select the cells for in situ hybridization. I'm not going to go into reporting in detail. I would refer you to this CAP template for some guidelines on how to report the results for these specimens. And again, that was led by Angela Bartley. So I saw an interesting paper recently from pathologists in the United Kingdom, and they looked at recommendations specific to their National Health Service. And this was not an evidence-based guideline like the CAP guideline, but a lot of it was more expert opinion and local context. And they mostly affirmed our guidelines, but they went a little bit further than we did. They recommended that the testing be performed on tissue obtained after treatment because of selective pressure on tumors. And I think that is probably, if you have equal blocks, if your tissue quality is good, I think that's probably a good choice. They recommend resection over biopsy. I would rely on the tissue quality. We have a lot of gastric cancers that are treated with neoadjuvant therapy. Our resections may not be the best specimen to choose in terms of tumor cellularity. And they also said if there's equivocation between 1 and 2 plus, perform FISH. But they recommended only using freshly cut sections based on the breast carcinoma data. And I think that's probably a good practice, not to use stale slides if you can help it. But we did not see enough data specific to gastric or esophageal to make that recommendation in the guideline. And they actually preferred the 4B5 antibody because they liked that for velar epithelium. They called that a positive internal control. They liked seeing that. Whatever. I think that's the choice for your lab, but I thought that was an interesting recommendation. Now, we do have problems with even HER2-positive patients escaping and the tumor becoming resistant. There was a lot of tumor heterogeneity in gastric cancer, and I did see one paper saying that a third of cases show HER2 loss related to targeted treatment. So I think treatment resistance, analyzing what's going on there will be very interesting. And there may be imperfect concordance between the primary and the metastases due to clonal selection during the progression. We were waiting on the results of some HER2 trials for gastric cancer, but unfortunately some of those are negative. The lapatinib trial, the second-line trial were both negative. A TDM1 trial was negative. And we just got the results of the JACOB study, which was dual blockade of HER2 and HER3 back in late 2017, and that didn't meet its primary endpoint. So TOGA is still our best positive study for this, and we're still relying on those data. There is a vaccine strategy using HER2 extracellular domain that may be promising, and there are other treatments in the pipeline, but so far we're still relying on the TOGA trial. There are emerging biomarkers looking at methylation. I think the non-coding RNAs may be interesting in the future, and you see a lot of written about patient-derived xenografts, and I think they may be useful in preclinical studies, but perhaps not so much at this point. So, in summary, HER2 testing in the appropriate clinical setting for patients eligible for treatment with trastuzumab. We're recommending IHC+, go to FISH for 2+ cases, and use the Ruschoff-Hoffman IHC scoring system. Remember, breast cancer scoring system for IHC for HER2 is not appropriate in this disease. And microsatellite instability testing, PD-L1, in patients who are candidates for these therapies. And I will point out that the CAP guideline, the Center Committee for Guideline Development, is putting together a panel looking at MMR and MSI testing, PD-L1, in patients with solid tumors being considered for checkpoint inhibitor therapy, not just the lung cancer, and that is in the early stages. So keep an eye out for more guidelines coming on these tumors. And I think this is another archival picture. I think these were nursing students at the time. As you see, everybody looking in the microscope is a woman, and the instructor standing over them there. So this was from the School of Nursing. I will not be here at 5. I think I'm due to go to the airport. So if you have questions, please catch me at the break. And thank you very much.
Dr. Yantis, can you avoid the hole, or would you like for me to?
Depends on how high your heels are. Yeah, just the high heels.
I got this.
Okay.
I got this.
I can cover it up if you want.
Okay. Do you want me to start, or you want to? Okay.
No. Our next speaker is Dr. Rhonda Yantis, Director of GI and Liver Pathology at Weill Cornell.
Thank you. Speaking of giants, it's always good to talk right after two of the giants in GI biomarker development. Thanks, Phil. So first of all, thanks a lot for the invitation. This is my first time coming to this meeting, and it's really great to see so many people from diverse backgrounds, all interested in the same topic.
So colorectal cancer biomarker testing, there's not a whole lot new. I just want to, in this presentation, I'll talk about 3 things, starting with the most recent developments, and then going back a little bit in time. We'll talk about HER2 amplification, KRAS and BRAF mutations, and mismatch repair deficiency testing. PD-L1 testing has not caught on in the lower GI tract, thank goodness. But it's usually associated with mismatch repair deficiency, and that's why it hasn't really caught on. But there are some emerging data to suggest that PD-L1 staining may be independent of mismatch repair status in some situations. So next year at this meeting, PD-L1 in the colon might be a little bit more important. Okay, so you may have gotten some requests from your clinicians asking for HER2 testing on colorectal cancers. The reason is that about 5% of KRAS wild-type colorectal cancers do show amplification, and data out of Europe from the Heracles trial, and I just have to pause and say the Europeans have the best names for their studies. The TOGA trial, the Heracles trial for HER2 amplification in colorectal cancer, enhanced stratification trial. Basically, what they've shown is that there is a benefit to HER2 blockade as a second-line combination chemotherapy in patients who are cetuximab resistant. The staining pattern that is evaluated is essentially the same as that Dr. Washington talked about in GE junctional and gastric cancers, but the interpretation and outcome for patients is actually different. If you'll notice, the patients who have strong staining in more than 50% of the tumor cells are eligible for the Heracles trial without in situ hybridization, but the cases that are equivocal or subjected to reevaluation with IHC and in situ hybridization are a little bit different. Strong staining in 10 to 50% of the tumor cells still is going to prompt retest with in situ hybridization, and then based on those results, the patient may be eligible for the trial. And the negative category does include some patients who have very focal, highly strong staining of tumor cells. KRAS and BRAF mutational testing, also very important in patients who are considered for adjuvant chemotherapy. As you all know, EGFR signaling is activated in colorectal cancers, and inhibitors of that pathway do improve survival among patients with stage 4 colon cancers. Downstream mutations that activate the pathway regardless of EGFR blockade obviously make those agents less efficacious. So if we think about the normal situation, EGFR-mediated signaling is initiated by dimerization with binding of the receptor ligand. That turns everything on downstream to lead to cell proliferation and decreased apoptosis. When you block this pathway, the idea is that you block cellular proliferation. But in patients who have activating mutations within the pathway, it doesn't really matter what type of blockade you're doing at the receptor level. You're still going to have internal signaling going on. So let's talk just briefly about that pre-analytical, the issues that Dr. Compton was raising. A couple of things to think about when you're doing solid tumor testing is that it's different than germline testing. There are heterogeneous cell types. Many of the alterations you're looking for are oncogenic mutations that are present in one of the alleles. So in a perfect world, you're going to get about 50% of the DNA will harbor those mutations. So when you do your selection of material, you want to choose the block with the highest tumor density. You want to avoid lymphoid aggregates and inflammation. And you want to be sure that there's a pretty good line of communication between the person who's doing the selection of material and the person who's actually doing the testing. So the first general rule of thumb is don't go crazy with giant circling like this. The molecular people are probably laughing at us when we do something like that. Just keep it simple. Circle a very cellular area of the tumor. You want to choose areas that are away from lymphoid aggregates and lots of inflammation, because lymphoid aggregates contain lots of cells and lots of cells that have wild-type DNA, and they can dilute out any findings you may have. So here, for example, we have a case of colorectal cancer that, excuse me, can I go backwards? That has one area that was circled for analysis. It's pretty enriched in tumor, not too many other cell types in the area. Here's the same tumor, another area that looks similar at low magnification, but when you look more closely, there's an intense neutrophil-rich inflammatory infiltrate commingled with those tumor cells, which is not all that uncommon in colorectal cancers. Now, the point is that if you were to select the first area for mutational testing, and this case did have a KRAS mutation, you identify it in about 30%. But if you choose that other area with all the neutrophils, the detection rate goes down. So it's something to keep in mind. You want to avoid contaminating wild-type DNA when possible. Carolyn and I did not plan this. I don't know why she stole my thunder, but PCR is not magic. It's both operator-dependent and tissue-dependent. You want to select the most advanced lesion, the cancer, and you want to use good judgment to select the best area. The most advanced lesion is better, so cancer is better than the adenoma. Beware with neoadjuvantly treated tumors that may be hypocellular. In those cases, you might want to go back to the pretreatment biopsy. And then you, as others have mentioned, you want to avoid specimens that have been decalcified or fixed in weird fixatives. Now, the rest of the time, I'd like to focus on mismatch repair deficiency evaluation. Now, in colorectal cancer, we've been performing mismatch repair assessment for quite a long time. Up until recently, the primary reason was for cancer prevention, screening, and surveillance of Lynch patients. And for the most part, many centers are doing universal testing for this purpose. But it's turned out that mismatch repair status is also important with respect to both prognosis and treatment. Stage for stage, mismatch repair deficient tumors generally do better than their microsatellite stable counterparts. And treatment can also be affected by the underlying mismatch repair status, particularly when it comes to those checkpoint inhibitors that are going to be discussed at length later in the program. So when the pathologists evaluate cases, especially colorectal cancers, for mismatch repair deficiency, we're really addressing two issues. Number one, whether the tumor is deficient or proficient, and number two, whether the deficiency reflects a sporadic tumor or potentially an inherited syndrome. Now, the three major mechanisms for assessing mismatch repair status are PCR for microsatellite instability, immunohistochemistry, and some centers are now using NGS mutational burden as an indirect measure of microsatellite status, although admittedly most of those are places that are not doing PCR for microsatellite instability. PCR for MSI and immunohistochemistry are two different methods for getting to the question of function of the mismatch repair apparatus. Now, microsatellites, as you know, are short mononucleotide or dinucleotide repeats of DNA, usually occurring in non-coding regions, but not always. An important one that we'll talk about a little bit later is MSH6. Now, what happens is as DNA polymerase goes along, replicating the DNA, when it hits these areas of repetitive sequences, can cause base pair mismatches or insertions or deletions of in the daughter strand. In the normal situation, those errors are corrected by the mismatch repair protein complexes. But when those complexes don't function properly, those errors are not corrected. And that's when you get microsatellite instability. So there's an expansion or contraction of those short dinucleotide or mononucleotide repeats. And microsatellite instability essentially requires two things to happen. One, there has to be an error in replication, and two, there has to be a failure to correct that error by the mismatch repair apparatus. So what you expect to see when you compare a microsatellite unstable tumor to the normal DNA from the same patient is a shift and increase in the number of peaks at various microsatellite markers. These happen to all be mononucleotide markers in a commercially available panel. Mismatch repair immunohistochemistry is a surrogate marker of mismatch repair protein expression. Those proteins are normally expressed in proliferating cells like lymphocytes, the colonic crypts, and cancers, and we use the immunohistochemical staining patterns of these markers as a surrogate or as a guide for the subsequent evaluation of mutations when we identify alterations in the expression of these proteins. And the reason is that these proteins have characteristic binding partners. MLH1 always binds to PMS2. MSH2 always binds to MSH6. What's more is that both PMS2 and MSH6 require MLH1 and MSH2 for their stability. So if you have degradation of MLH1 due to a mutation, PMS2 is going to disappear as well. And the same is true for MSH2 and MSH6. The converse is not true. MLH1 and MSH2 do not require PMS2 or MSH6 for their stability. So if you have a defective PMS2, for example, you'll see loss of staining for PMS2 with preservation of MLH1. In other words, you can use the pattern of immunohistochemistry for these four markers to point to the underlying defect in a mismatch repair deficient cancer. Now, which is better, PCR or immunohistochemistry? In the older literature, the data suggested that there was about a 90 to 95% concordance rate between immunostains and PCR. And you think about it, that doesn't seem that bad, but that's really 1 in every 10 to 20 patients you could miss. Most of those data probably reflect errors in immunohistochemistry interpretation and use of the Bethesda panel, which was not quite as good as the commercially available mononucleotide panels. In our experience, looking at more recent data, it looks like there's a much, much higher concordance rate between PCR and immunohistochemistry. Out of over 800 cases, we only had 3 discordant cases. One was a human error, and 2 reflected interpretive errors in immunohistochemistry. And that's really what I want to talk about for the rest of the time. The challenges that we face when actually interpreting mismatch repair immunohistochemistry. So number one general point is that you want to be clear in your reporting. Don't just report the result of the stain. Provide a comment with an interpretation as to what it means. It's a good idea to make sure that there's someone on the receiving end of the information you're providing, usually a geneticist or an oncologist, not just the surgeon. Surprisingly, a lot of the data that we generated for a surgeon in our path reports for surgeons never made it to the geneticist. So it's important that if you're doing this testing, you want to have somebody reading and acting on that information. Now, it's also important to avoid terms like positive and negative when describing staining patterns because, as you know, a positive result is a loss of nuclear staining within the tumor with a preserved staining of the internal control. So using positive staining, positive result, negative staining, negative result can cause a little bit of confusion. Best to avoid those terms. Using and interpreting controls, also another important issue. You want to validate your antibody with an appropriate control. That's not a tonsil. That is a tumor that shows loss of MLH1 and PMS2, and another tumor that shows loss of MSH6 and MSH2. You want to use those controls with every run. You have to show that the antibodies stain what they should stain and don't stain what they're not supposed to stain. So here in this case, for example, or in this image, for example, you would show the two controls that you would run with a colorectal cancer, assessing for mismatch repair deficiency. One of them shows a loss of MLH1 and PMS2, another control with loss of MSH2 and MSH6. If you don't have internal control staining of lymphocytes in the non-neoplastic crypts, you can't interpret immunostaining patterns within that area of the tumor. So in this case, for example, we have a complete loss of staining in the tumor that you might interpret to represent a loss of mismatch repair protein staining, but you'll notice that the background doesn't show any staining either. This is an uninterpretable stain. Now, one caveat to that rule is the patient who has constitutional mismatch repair deficiency. These are patients who have biallelic germline mutations in one of the mismatch repair genes. It's interesting that unlike the general population, which is enriched in MLH1 and MSH2 mutations in the Lynch syndrome patients, these patients usually have PMS2 or MSH6 mutations, probably because biallelic loss of MLH1 or MSH2 is often lethal in utero. This disorder is inherited in an autosomal recessive pattern, and the clinical features are not typical of Lynch syndrome, so your clinicians might not be thinking about mismatch repair deficiency. Patients tend to be young at the time of cancer presentation. They may have café au lait spots. They often have brain tumors and hematologic malignancies. About a third of them have multiple colonic polyps, often with synchronous cancers. And what you'll see is preservation of staining for one or more of the mismatch repair proteins, and then one of them will show, one or two of them will show a loss of staining within the tumor cell nuclei, as well as an absence of staining in the background internal control. So you might interpret that to imply that one of the stains didn't work properly. And given the unusual clinical manifestations, the clinicians might be thinking about something totally different, like a familial adenomatous polyposis syndrome. Number 3, you want to be careful about interpreting stains that are not entirely robust. We like to see immunostains that show an all or none staining phenomenon within the tumor with a nice internal control. But remember that the immunostains for mismatch repair proteins are often finicky. The staining pattern can be patchy, especially with MSH6 and PMS2. Sometimes the staining reaction is weaker than is expected, and these antibodies seem to be more sensitive than other families of antibodies to technical issues like pore fixation or tissue hypoxia, older blocks, and diffusion of the antibody. So a couple of things to keep in mind to help you from going down the wrong path, or to remember those relationships that exist between the proteins making up the mismatch repair complex. It would make sense to see loss if you have equivocal MLH1 staining and PMS2 staining, then that might prompt one to interrogate those stains a bit further. But if you saw a loss of MLH1 combined with MSH2, that doesn't really make any biologic sense, and that might point you more towards a technical issue rather than a biologic one. So any aberrant staining combination should make you question the validity of the stain, especially if the internal control is also negative. MSH6 is particularly problematic. This was mentioned earlier. It often shows a heterogeneous staining pattern, often patchy within a single gland, that may reflect overlapping function with other mismatch repair proteins. It can also be diminished in neoadjuvantly treated tumors, and the loss of staining can be striking. More than 90% of the tumor, in fact, can be negative in some cases that are actually mismatch repair proficient. So this is the pattern we often see in MSH6 in a mismatch repair proficient tumor. We see patchy staining within the tumor, and even in some areas, staining of scattered nuclei and rows of nuclei that are entirely negative. This doesn't imply underlying deficiency in MSH6. In fact, this is pretty much the way it often looks. In neoadjuvantly treated rectal cancer, you can often see extensive loss of mismatch repair protein staining, both for MSH6, but some of the other markers as well. That has become clear in later publications. So if you're facing a situation like this, where you have rare scattered positive cells in a mostly negative tumor, before you label the patient with a deficiency of MSH6, you want to go back to the pre-treatment biopsy and check it out. This is the same patient. So clearly, loss of MSH6 staining is related to therapy. Now, I think Dr. Longacre mentioned clonal loss of MSH6. That can also occur. Usually the situation is a patient who has loss of MLH1 and PMS2 that in the entire tumor, with an area where you also see sharply demarcated loss of MSH6 and preserved MSH6 elsewhere. What this reflects is the fact that MSH6 itself has a mononucleotide repeat in its promoter region, so the underlying microsatellite instability due to this knocks out MSH6 in a somatic fashion. So that can also be something that you encounter. Funny staining patterns are also an important route for error. Remember, immunohistochemistry is a qualitative test. It's not a quantitative test, at least most of the time. Variable staining for mismatch repair proteins is common. It doesn't necessarily mean, in fact, it often doesn't mean that there's underlying mismatch repair deficiency. But if a tumor shows substantially weaker staining in the tumor compared with the internal control, you might want to suggest follow-up with PCR for microsatellite instability, especially if you're in a lab where you're not doing both of those assays simultaneously. So here, for example, we have a patient who has a germline PMS2 mutation that you could easily overlook by calling this weak staining within the tumor retained PMS2. However, if you compare to the internal control, you can see that the staining reaction in lymphocytes is much, much stronger than it is within the tumor. So that should be a red flag to further investigate. This was another case that we had, a 35-year-old woman with colon cancer and suspected Lynch syndrome that on the surface looks like it shows preserved staining for MLH1 and PMS2, but it turns out to be microsatellite unstable. And in retrospect, if we compare the extent of staining within the tumor to that of the control, we can see that the staining reaction is certainly heterogeneous and might not be as strong as it is in the internal control lymphocytes. The other situation in which you might see this pattern of heterogeneous staining is in the patients who have DNA polymerase mutations. Those individuals have alterations in the proofreading domains of the polymerase that are important for DNA repair and chromosomal replication. And as was mentioned earlier, these patients with these tumors have a hypermutated phenotype, and the tumor can be either microsatellite stable or microsatellite unstable due to somatic mutations that happen to knock out one of the mismatch repair genes. Germline POLE or POLD mutations can account for Lynch-like clinical features in patients who lack detectable germline mutations in the mismatch repair gene. So that's something to keep in the back of your mind as well. Anytime you have a case where there's a strong clinical suspicion for Lynch syndrome and you have this kind of wimpy, heterogeneous staining for mismatch repair proteins, you want to think about a polymerase alteration, because remember, MLH1 and MSH2 tend to be very robust diffuse stains, whereas MSH6 and PMS2 tend to be a little bit more woofy. It turns out that this patient had a germline polymerase mutation. The other important thing for pathologists to do when evaluating for mismatch repair deficiency is to determine whether that deficiency is sporadic or possibly inherited. And the reason for doing that is if the tumor is sporadic, there's no need for germline sequencing, there's no need for screening for extracolonic neoplasia, and there's no need for testing or worry on the part of any family members. Most sporadic microsatellite unstable tumors result from acquired methylation of the MLH1 promoter. So the immunophenotype is that of loss of MLH1 and PMS2, similar to a Lynch patient who has a germline MLH1 mutation. About half of those tumors, the sporadic ones due to methylation of MLH1, about half of them have BRAF mutations, usually the V600E mutations, which are extremely uncommon in Lynch patients. So the combination of loss of MLH1 and PMS2 with a BRAF mutation should point you in the direction of a sporadic tumor. There is an antibody available for the BRAF V600E protein. It was all the rage a few years ago. We don't talk about it too much in the colon anymore for a few reasons. First of all, the stain isn't particularly robust. It can be difficult to get working. It usually shows a weak to moderate intensity staining reaction. And in my view, it's more of a research test rather than a clinical test. The molecular test is the gold standard. It's objective, definitive, robust, easily interpreted. The BRAF immunostain is not so robust. It has all the issues inherent to any immunohistochemical stain, and there's no internal control. So it can be difficult to interpret those stains. And by the way, they don't work on serrated polyps or polyps in general either. The protein, the immunostain is directed against the V600E protein, so the less common mutations aren't going to get picked up. And remember that only half of sporadic MSI-high tumors have the BRAF mutation. So if you happen to have a case with loss of MLH1 and PMS2, that's BRAF wild type, you're still going to have to go on and do methylation assays or something else. You haven't excluded the possibility of a sporadic tumor. So immunohistochemistry for that protein is probably not worth doing. Another issue is overstating the likelihood of Lynch syndrome. We used to think that loss of MLH1 and PMS2 in the cases that did not show MLH1 methylation, that those reflected Lynch syndrome, and any other immunoprofile also likely represented Lynch syndrome. We now know in an era of universal testing that biallelic somatic alterations can occur in any mismatch repair gene, and they're not all that uncommon. So we have to expand our thought process and think outside the box a little bit more when we're interpreting these immunostains for potential mismatch repair deficiency. This was an interesting case that was published earlier this year of an 80-year-old woman who had a right-sided colon cancer that shows a pretty solid growth pattern and an absence of staining for all mismatch repair proteins with staining of the internal control. Now, you would think in an 80-year-old woman with a right-sided colon cancer that this is probably not Lynch, that it's due to MLH1 methylation. And in fact, it was interrogated for that and does have MLH1 methylation, but it also had biallelic somatic MSH2 mutations to account for this funny immunostaining pattern. Overall, at least 20% of mismatch repair deficient colon cancers that don't have MLH1 methylation and lack detectable germline mutations in the mismatch repair genes have biallelic somatic alterations. When it occurs in older patients, those patients don't seem to have any other risk factors for colon cancer, but in younger patients, they can be isolated, can occur in an isolated sporadic tumor, or in the setting of Lynch-like clinical features, in which case you got to worry about those DNA polymerase mutations. So all in all, you want to avoid statements about the likelihood of Lynch syndrome when interpreting immunohistochemical stain results. Solid tumor testing for mismatch repair deficiency is not a genetic test. Okay, so to summarize, pathologists play an important role in determining the downstream testing and treatment of patients with colon cancer. Tumor selection for biomarker testing affects the results, and immunohistochemical stains can certainly be used as screening tools for biomarker testing, but important nuances can affect interpretation, and we have to be aware of them. So with that, I will close, and I think it's break time, right? Okay.
Next speaker is the Director of Anatomic Pathology at Houston Methodist Hospital, Dr. Mary Schwartz. Watch out for the hole.
Hole?
In front. Should you walk out?
A hole. Like a manhole?
Yes, right here.
Well, you all have been treated to an amazing afternoon with some amazing women, so thank you all for these incredible talks. Dr. Cagle's talking about holes. I heard about the Cajun Navy. I don't know if you all have heard about the Cajun Navy. It's Louisiana people that have been through lots of hurricanes who are going out to the East Coast. And for all the bashing that we do about our country, it's pretty incredible that we have people that have been hit so hard that go out and help others that they don't know at times of crisis. Okay, I'm not from Louisiana. So there's been a dramatic decrease incidence in smoking-related head and neck cancers in the U.S. over the past 3 or 4 decades, paralleling the decreased smoking rates. Of course, as you see young people smoking, you wonder if that is going to continue. But at the same time, we've seen a significant increase in oropharyngeal squamous cell carcinomas, especially in the U.S. and Northern Africa. And it's been associated, Maura Gillison, who's now across the street, really was one of the first to identify its association with high-risk HPV. And indeed, some have called it an epidemic of viral-induced carcinoma. In the U.S., currently, about 70% of oropharyngeal carcinomas are HPV positive. Chetaverity predicted in 2011 that oropharyngeal squamous cell carcinomas would likely comprise almost 50% of all head and neck cancers by 2030. That's only 12 years away. And it's also been projected that the incidence of HPV-positive oropharyngeal carcinomas in the U.S. will exceed that of cervical carcinoma by 2020. Well, guess what, folks? The lines have actually already crossed for HPV-attributable cervical carcinoma and oropharyngeal carcinoma, and this is from the CDC just a few weeks ago, and you can see, let's see, do I have a pointer? Do I have a, okay. You can see here's cervical carcinoma attributable to HPV, here's oropharyngeal carcinoma attributable to HPV in men. By the time you add the women, there's already more oropharyngeal carcinoma than cervical carcinoma caused by HPV. Most HPV-positive head and neck squamous cell carcinomas are in the oropharynx. They're associated with a better prognosis. You can find high-risk HPV in non-oropharyngeal sites. The numbers are all over the place depending on the methodology that was used to test for them. The important thing is that there is no proven increased survival or response to therapy with an HPV-positive tumor outside of the oropharynx, and that becomes important in how we select patients with tumors in the head and neck to be tested for HPV. So just because you can find it doesn't mean that you go looking for it. 90 to 95% of HPV-positive oropharyngeal squamous cell carcinomas are caused by HPV-16, so a much higher percent than for cervical cancer. Next most common, HPV 18, and there's a few others. The important thing is that HPV in oropharyngeal carcinoma is the driver. It is not passenger it's not a passenger. HPV positive squamous cell carcinomas, and again, we're really talking about the oral pharynx here, have different demographics, a different genetic profile, and a better prognosis than HPV negative squamous cell carcinoma. And this, of course, for those of you that have trained in the VA as your classic patient with an HPV negative oropharyngeal carcinoma. Most of them aren't happy, unlike this gentleman, but they're older, they've smoked cigarettes for many years, they've drunk a lot, they've had poor oral hygiene, bad diet. And this is the face of HPV positive oropharyngeal carcinoma. But really, most of them are more like not Michael Douglas, but the gentleman below that is Mr. Bert Nugent. Bert Nugent is a retired military officer, a father, a lawyer, and has become a very passionate advocate, a CAP advocate on behalf of patients with HPV-positive oropharyngeal carcinomas, and speaks very frankly about the incredible alteration that this disease imposes on people, including, a dissolution of his marriage. In general, these patients are younger than those with smoking-related head and neck cancers. Many of them never smoked. Many of them never drank much alcohol. They tend to have higher socioeconomic status. Many of them are college educated. They're in the prime of their life. What are the risk factors? The major risk factor is lifetime number of oral sex partners, especially for men, and oral HPV infection. And there's a much higher transmission rate of HPV from women to men than vice versa. This is from a study published earlier this year from Maura Gillison and colleagues. And what they did is it's going to be very difficult to prove, to show that HPV vaccination will decrease the rate of HPV-positive oropharyngeal carcinoma because of the long latency. And so since we know that HPV oral infections are a major risk factor, what this group did is that they looked at the decrease in HPV oral infections in a group of men, and they showed that if you vaccinated these young men, you could decrease the rate of HPV infections by 88%. And what this shows you here is what we could decrease if everybody was vaccinated versus what we're probably going to accomplish given the very low rates of HPV vaccination in this country. Things are getting better. When I first gave this talk, when I first started talking about HPV, the rates of vaccination were probably about 11%. Currently, probably nearly 50% of teens are up to date on their HPV vaccination. Texas always does everything differently, and we're not so good. There's lots of angst about HPV. The vaccine, this is an election year. I'm not going to give you my politics, but I am going to give you a plea that your children, your family's children, your coworkers, people you like, people you don't like, encourage them to get their kids vaccinated. This is a terrible disease, and as best we can tell, hopefully this vaccination will have an impact. The greatest risk of HPV vaccine is, does anybody know what it is? It is not death. It is not sexual promiscuity. When you read the papers, it is pain at the injection site. You get over it. Okay. Okay, all of you are familiar that patients with HPV-positive oropharyngeal squamous cell carcinomas actually present many with advanced disease. They have enlarged lymph nodes and very often very small primaries that may not even be clinically detectable. Yet despite a high-end presentation, most of these patients with oropharyngeal carcinoma have a far better outcome than those with similar stage HPV-negative squamous cell carcinoma. And there have been multiple retrospective and prospective trials that have shown that locally advanced head and neck squamous cell carcinoma that's HPV positive, and again, we're talking about the oropharyngeal ones, the HPV status is an independent predictor. And these patients not only have better overall survival, but disease-specific survival and disease-free survival. And the numbers are going to vary from trial to trial, but this is sort of an average number from a meta-analysis that the 5-year survival for patients with HPV-positive squamous cell carcinoma was greater than 80% versus 40% with stage-for-stage HPV-negative cancers. We do know that smokers have an intermediate prognosis. At one time, it was thought to be something about the smoking. It's probably more likely response to therapy. And we also know that about 20% of patients with HPV-positive oropharyngeal carcinoma do have a bad outcome, and so we're still looking for other markers above and beyond HPV, and what those are is not clear yet. So these patients with oropharyngeal carcinoma that's HPV positive do have a better prognosis, but the multimodality therapy that's used to get to that end result leaves them with considerable morbidity. Mr. Nugent has shared he can't go out and eat in public because of the long time it eats, and many of them have a chronic morbidity. And so we were taking young people, relatively young, middle-aged people who were in the prime of their life, we're curing them, but we're leaving them with a great deal of morbidity. And so the question has become, if this disease really has a better prognosis, can we de-escalate the therapy and still have the good outcome? And there are many trials looking at that. So identification of HPV status in head and neck squamous cell carcinoma has become important for prognosis, for determining the most likely primary site for patients that show up with a carcinoma of unknown primary, typically in the neck, and in clinical trials, which are trying to determine if therapy can be de-escalated in HPV-positive squamous cell cancer patients. Now, unfortunately, there are patients who are having that out of a trial, but the current strong recommendation is that if you're going to look at de-escalation, it be done within the basis of a clinical trial. So how do you test for HPV status in head and neck squamous cell carcinoma? There's a variety of tests. When the CAP did a survey across the country, the most commonly used test is the P16 immunohistochemical stain. This is usually absent in smoking-related head and neck squamous cell carcinoma, whether it's through a hypermethylation, a gene deletion, or another mutation. I'm not going to go over the molecular pathology of HPV, but you all know that basically with integration of HPV DNA into the genome, it increases the transcription of HPV E6 and E7. That leads to ultimately to P16 upregulation, and we as pathologists see it as overexpression of nuclear and cytoplasmic P16 when we look at it by immunohistochemistry. So that strong diffuse immunohistochemical staining for P16 is considered a sensitive surrogate marker for transcriptionally active HPV and HPV-positive oropharyngeal squamous cell carcinoma. And this is a good example of a patient with, or patient sample with essentially 100% strong positive staining. And the cutoff in tissue is considered to be considered positive is 70% or more of the cells to have nuclear and cytoplasmic staining. What the threshold is in cell blocks is not known. And Dr. Compton, you talked very eloquently about fixation, and there's different fixations used for cell blocks. The numbers are all over the place. Some people have reported as low as 10 to 15%, and that's based on correlation with tissue that might be available. Most of us are a little bit nervous about going down to that level. And there's an important caveat that not everything that is P16 positive comes from the oral pharynx. So it has to be seen within the appropriate clinical context. Again, I'm not going to talk on this. We went over this 2 years ago about every single one of the tests and its pluses and minuses. The advantage of doing mRNA in situ hybridization is that it's looking at integrated transcriptionally active HPV and also allowing the interpreter to actually see the localization within the cells. However, this technology is not widely available. It's technically challenging, although I know that one of our vendors outside has partnered with 2 other vendors to try to automate this. So, there are a lot of controversies. Which tumor should be tested? Should you test everything from the chest on up? What's the best method for detection of HPV? Do the clinical outcomes vary depending on the testing method, depending on whether you use tissue or FNA? What's the optimal, we've heard this morning about reporting, what's the optimal method of reporting to best inform about the clinical significance? And that Dr. Yantis sort of led us to recognize some of the importance of reporting because people are reading those reports. So the CAP Center brought together an expert panel. They had an advisory panel, and you can see some of the major players. We had patient advocates. One of the key people is in the audience today, and that's Ms. Nicole Thomas, who's a manager guideline at the CAP, who kept us in line. You can imagine you take a lot of opinionated people in a very complex topic, and I see Dr. Washington smiling. It takes a lot of give and take to come up with the final document, and the squeaky wheel does not always get their way, but they have a lot to say. And there's the panel. And so what did this panel do? They systematically reviewed, just like the other CAP Center projects, they systematically reviewed the literature, assessed the evidence, because it's really not what you want to do off the seat of your pants, but, again, back-to-back best practices that Dr. Washington mentioned, and developed evidence-based guidelines, which is, again, that we heard from Dr. Lindemann. He's going to talk more. That's the way we practice. We were into it for the Pathology Guinness Book of World Records, and we looked at more studies and read more papers than any other guideline group before. It drove Ms. Thomas and the rest of us crazy, and we actually had to add a couple members to get through all of this. But the end result was that we came up with a draft recommendation of evidence-based guidelines, and these were reviewed by our advisory panel. They were put out on the CAP website for comments. We actually got a lot of comments, and we did listen to the comments, and half of the recommendations did undergo revisions. The guidelines after that went out to an independent review process, and the guidelines were also reviewed by ASCO's Head and Neck Guideline Advisory Group and their Clinical Practice Guideline Committee, and at that time, they did not offer any suggestions for revisions. So the paper, and Mr. McGonigal was here earlier, but the paper was e-published in December, just a week before Christmas. It was people's Christmas present, if that's what you want, and then came out in press in May. And the timing of this particular Biomarkers Conference is terrific because exactly a week ago, JCO published the ASCO guideline endorsement of the CAP guidelines with a few qualifying steps. But, overall, they strongly endorsed it. They just had some tweaks. So the timing is great because now we get to talk about the CAP guidelines and the ASCO's take on that. So I'm going to briefly go over the recommendations and then address where ASCO has a little bit of difference. The most important the guidelines are going to be up front. Pathologists should perform high-risk HPV testing on all patients with newly diagnosed oropharyngeal squamous cell carcinoma, including all histologic subtypes. So whether it's papillary, basaloid, doesn't matter, keratinizing, non-keratinizing. This testing may be performed on a primary tumor or a lymph node metastasis when the clinical findings are consistent with an oropharyngeal primary. And again, it's important to recognize the difference between oral cavity and oral pharynx. And these are parts of the oral pharynx. This is part of the oral cavity, because when we talk about the significance, the prognostic significance of an HPV-positive carcinoma, we're talking about oropharyngeal primaries, not oral cancers. For oropharyngeal tissue specimens, i.e. not cytology specimens, pathologists should perform high-risk HPV testing by the surrogate marker, P16. Again, it's a surrogate for transcriptionally active HPV. And additional HPV-specific testing, i.e. ISH, PCR, may be done at the discretion of the pathologist or the treating physician or in the context of a clinical trial. And we had librarians to help us. We had a methodologist, actually, the methodologist was also on the ASCO guideline paper, and and they looked at the strength of the recommendation based on all the data, and the strength of this recommendation was recommendation, and all of that is in the paper. We're not going to go over that. There is abundant literature on the value of P16 as an independent predictor of prognosis in oropharyngeal squamous cell carcinoma. It's been used in retrospective trials, it's been used in prospective trials, and there is a need to provide a test that is practical, inexpensive, widely available, reproducible, has ease of use, and P16 meets all of those. The ASCO group did have a qualifying statement for this recommendation. They felt that there was a small fraction, very small fraction, of oropharyngeal tumors that are not driven by HPV yet do overexpress P16, and therefore they felt that pathologists should either have experience or have available confirmatory HPV testing for use at their discretion. Recommendation number 3, pathologists should not routinely perform high-risk HPV testing on patients with non-squamous cell carcinomas of the oral pharynx. That's unusual to find so if you have a lymphoma, a salivary gland neoplasm, a neuroendocrine tumor, there is no indication that you're going to provide prognostic information or therapeutically helpful information. ASCO did come up with a qualifying statement. They felt that if the tumor was poorly differentiated and the pathologist was not certain that it was not a squamous cell carcinoma, that HPV-specific testing is warranted. My personal take on that was if it's a neuroendocrine tumor, do the neuroendocrine marker. It's a high-grade neuroendocrine marker. It's a bad actor. You can find HPV in those tumors, but they're going to behave badly whether or not there's HPV in there. Pathologists should not routinely perform high-risk HPV testing on patients with non-oropharyngeal primary tumors of the head and neck. So when you're friendly or non-friendly, head and neck surgeon, oncologist, etc., wants you to do HPV testing on gingival cancer, a laryngeal carcinoma, there is no evidence-based medicine to support that testing. You could do it, but there is no evidence to show that you're going to provide prognostic or therapeutic information. So you can find the HPV. Most of it's not transcriptionally active in a variety of sites. That doesn't mean that 3 years from now, that statement's going to change as we accumulate more data, and probably the highest rate of finding HPV in the head and neck outside the oral pharynx is in the sinonasal tract, and perhaps 3 years from now we'll have that evidence to support that. But as of today, 2018, there's not the evidence to support routine HPV testing outside the oral pharynx. Now we know that for patients that present with metastatic squamous cell carcinoma to the neck, that about 5 to 10% of them will not be able to have an evident primary even after very careful radiographic imaging, endoscopic exams. And so what happens to those patients is the therapy is controversial, but in general they have comprehensive radiation therapy with a very wide field trying to cover that possible primary, and so that there's even greater morbidity than for other head and neck cancers where you do know the primary. So recommendation number 5, since many of these metastatic carcinomas of unknown primary, and they're also called CUP, will be found to have an oropharyngeal primary, the recommendation number 5 was that pathologists should routinely perform high-risk HPV testing on patients with metastatic squamous cell carcinoma of unknown primary in a cervical upper or mid-jugular chain node, i.e. levels 2 and 3. And an explanatory note should accompany that. So don't expect that everybody reading your report is going to know the significance. So if you have a patient with carcinoma of unknown primary in the neck and you are able to detect high-risk HPV and it's a squamous cell carcinoma, the accompanying statement could be that there's a high likelihood that this patient has an oropharyngeal primary. Not done certain because it still might come from somewhere else, but that will, and I know that I've been involved in this for a long time, and one of our head and neck surgeons, I knew this patient had a oropharyngeal or a base of tongue primary, and it took them 3 times to go back, but it was found, so it's there if you look for it. But again, this is clinically useful information. For tissue specimens for patients presenting with metastatic squamous cell carcinoma of an unknown primary, pathologists should perform P16 immunohistochemistry. And again, it's important to know that we're looking at levels 2 and 3. If the nodes is outside of levels 2 and 3, which are the upper to mid-jugular lymph nodes, or for tumors with keratinizing morphology, the recommendation was to do additional HPV-specific testing. Pathologists should perform high-risk HPV testing on head and neck, FNA, squamous cell carcinomas from all patients with either a known oropharyngeal primary or with suspected oropharyngeal squamous cell primary or with metastatic squamous cell carcinoma of an unknown primary. And it's just some representative examples. We were not able to find enough literature and evidence to make a specific recommendation about which methodology to use for FNAs. If pathologists do P16 immunohistochemistry staining, and I think that's been corroborated by several of our speakers, there is a need to validate that testing in your own laboratory, which of course is an onerous task. The qualifying statement from ASCO was that IHC alone is not sufficient, especially with cytology material, and additional confirmatory testing should be performed they left it a little loose, at the discretion of pathologists and or clinicians. And they recommended a 70% cutoff for P16, regardless of whether you're looking at tissue or cell blocks. I can tell you here at Houston Methodist, for the FNAs, we do, if we have a cell block, we do a P16, but we do corroborate with a HPV-specific test. Some caveats: branchial cleft cysts can be P16 positive. You can get P16 positivity in up to 40% of metastases from cutaneous primaries. So again, very important to put in the clinical context. There's a variety of ways that you can look for high-risk HPV on cytologic specimens, and many of them employ liquid-based samples. Pathologists should report P16 positivity as a surrogate for high-risk HPV in tissue specimens using that 70% or greater. The ASCO came out with a qualifying statement saying that if the tissue did not meet that 70% threshold, but there was a strong indication that this patient might have an oropharyngeal primary, that you could go for more specific high-risk HPV testing. Actually, if you look at the CAP guidelines, we gave some wiggle room for that in the 50 to 70% range. Number 9, pathologists should not. So all these recommendations so far have been what to do. Now it's what not to do. Pathologists should not routinely perform low-risk HPV testing on patients with head and neck carcinomas any more than they should be looking at low-risk and cervicovaginal specimens. You can find low-risk HPV in squamous papillomas and warts, but they're not associated with oropharyngeal squamous cell carcinomas. There is no indication to repeat. If you have a patient who has a known HPV positive oropharyngeal squamous cell carcinoma and they show up with a local recurrence, a regional recurrence, distant metastases, there is no indication to repeat that testing. You may repeat it if it was not done on the primary, or if you're concerned the patient has a new primary. Terminology, and this one actually was one of our most internally contentious. Pathologists should report primary oropharyngeal squamous cell carcinomas that test positive for high-risk HPV or its surrogate marker P16 as either a squamous cell carcinoma, HPV positive, or squamous cell carcinoma P16 positive. I'm going to give you my personal take on reporting P16 positive, because when you go to a patient and you tell them that they have an HPV-related cancer, somehow telling them they have a P16 positive cancer just doesn't mean anything. We tried to make our terminology similar to what the WHO was recommending, and some of us were actually involved in the WHO New Blue Book, and the WHO is recommending squamous cell carcinoma HPV positive and HPV negative. The AJCC, which just now went live, I guess, January 1st of this year, wanted to be a little bit different, and they are recommending HPV mediated, in parentheses P16 positive if you're going to use P16, oropharyngeal squamous cell carcinoma. Pathologists should not provide a tumor grade or differentiation status for HPV positive, P16 positive oropharyngeal carcinomas. And why is that? It's because whether it's what we classically think about well differentiated, what we classically think about poorly differentiated, whether it's keratinizing, whether it's non-keratinizing, if it's an oropharyngeal primary and it's high-risk HPV positive, it's going to likely have a favorable prognosis regardless of what the morphology is. So, we typically think of this, We typically think of this as well differentiated because it's keratinizing. Before we recognized about HPV positive cancers, we would think about this as poorly differentiated, but this is the morphology of most squamous cell carcinomas. Actually, Bill Westra has pointed out to us that we shouldn't even, we just need to dismiss the concept of poorly differentiated for oropharyngeal carcinomas to begin with. And Bill Westra has actually pointed out that you can actually think of these cancers as well differentiated because they replicate the reticulated epithelium of the tonsil. This was definitely our most contentious recommendation when it went out for public comments. I think that's a non-issue now because the AJCC most recent staging manual, the 8th edition, specifically tells pathologists to not provide histologic grading of squamous cell carcinomas for P16 positive cancers. Pathologists should not alter the high-risk HPV testing strategy based on patient smoking history. We do know that tobacco use is a variable in treatment response. However, there's no evidence that smoking changes the result of HPV testing, whether you do it by HPV-specific testing or immunohistochemistry for P16. This is the algorithm in the archives article, and that's a free download. And the overall, again, ASCO overall endorsed the CAP guidelines with a few caveats, and most of those relate to doing specific HPV testing in selected circumstances. And the ASCO also provided a somewhat more streamlined algorithm, and both of them are available for free downloads. So in summary, given the unique biologic and clinical characteristics of HPV-positive oropharyngeal carcinoma, it's critical that patients be identified by routine testing for high-risk HPV status in clinical practice. It's important in prognosis. It's important in helping to establish the best therapy for those patients. The CAP recommendations are evidence-based and were developed to provide standardized testing, whether you live in Texas, Louisiana, New York, Japan, etc. And the recommendations are, just like all guideline recommendations, are expected to evolve with review of future research and literature updates. Thank you very much, and I know that there's a break out there waiting for you.
Thank you, Dr. Cagle, and thank you for the invitation to participate in this wonderful conference. I have heard only very good things about the conference everywhere I go. So today, I have no financial conflict to disclose. Today we will talk about, in this half an hour, about skin and uveal melanoma. We will try to touch on clinical biomarkers, histopathological biomarkers, and genomic biomarkers that affect these patients. So in the skin melanoma, as you may know, it accounts for 75% of skin-related deaths worldwide. It is, for the pathologists and the clinicians too sometimes, a diagnosis very challenging due to the large diversity of these morphological patterns that they can present, and is the second highest source of litigation in surgical pathology because of these main reasons that I said before. So something that we pay a lot of attention. As this biomarker
figure that I have here, you already had been hearing about this throughout the day. But in melanoma, this applies very much. The diagnostic biomarkers are very important, as well as the predictive and the prognostic that will affect the patient treatment. So in the skin, the first thing to do is to have a diagnosis. So benign nevus versus melanoma. After we have the diagnosis of melanoma, then very important is to decide if these patients are in early stage or late stage. And this is based on the microscopic staging, molecular staging, and most importantly at the end, the whole thing together, clinical staging. For the histopathologic staging for the prognostic biomarkers, first of all, get to the diagnosis of melanoma. Because this is not the topic of this talk, I'm not going to talk much about the criteria for diagnosis, but what is important that affects the patient outcome. So the thickness is one of the things that is very important. The thicker the lesion, the worse it is. And this is the basis for the Clark's and the Breslow's prognostic features, where the Clark talks about how deep it goes, the melanoma invading into the skin, the dermis, and the worst would be into the subcutaneous tissue, as we can see here. So it goes from level 1, contained here, into the superficial dermis, and to the level 5. The Breslow's is the depth of invasion, and it's very important because we see how this correlates with 10-year survival rates. So the deeper the tumor is, the worse for the patient. So here we have the combination of the Clark depth of invasion and the size in millimeters. And so then another thing, the characteristic of the tumor that is important is the ulceration. So the tumors, we need to see if they are ulcerated. They have worse prognosis, and it goes along most of the time with the size, but not always. So we have to describe both things. Then the histologic type, where if this is nodular or acral, melanomas are worse. Nodular is usually because it has a vertical pattern of invasion. And then the mitosis. Yeah, there are other features that are important, and actually we record for the staging, but they still don't have a precise value. One of them is the tumor-infiltrating lymphocytes, and we say if it is present and if it is brisk or not brisk. Regression, sometimes, the lesion has these areas look like a scarring that correspond to regression. Perineural invasion, like in this case, you see the nerve here and the tumor around the nerves. And lymphovascular invasion, most likely this patient may present with lymph node metastasis. Then the mitosis, we counted by square millimeter, and away from the epidermis, so that you are sure this is an invasive component. And this is also recorded. And so the more mitosis they have, the worse prognosis these melanomas have. Age, older patients have worse prognosis than younger patients. The site and anything above the waist is worse prognosis. And then the mutation type. So melanomas are highly heterogeneous disease, and they have frequent driving mutations that regulate the signal transduction pathways, developmental and transcriptional pathways, and the cell cycle. They are different for each type of melanomas, cutaneous, mucosal, or uveal. In this talk, we are only going to talk about the cutaneous and the uveal, but the mucosal, like the conjunctiva, has different combination of markers too. and they have different mechanisms of tumorogenesis. So this is an example of, in this list, what is the most frequent by the site and association with metastasis or not. So, for example, here the c-KIT is more important in the acral and mucosal melanomas and not as much as the uveal or cutaneous. Or the GNAC, which is very typical for the initiation of the uveal melanomas, but not so much in the cutaneous, because as you can see there, 85% of the blue nevi, which is a benign nevus, has this mutation. So it doesn't have much correlation there. Then the third, and it is more associated with the metastatic melanoma, cutaneous melanoma. And then the P10 also has, it's associated to malignant the melanoma, not the nevi. And TP53, we use it more for the conjunctival melanomas. So there are predictive markers, and these are aimed to predict the patient's response to treatment or the combination of treatments. So these are helpful to identify, to do more personalized treatment. And unfortunately, not that many treatments are available. BRAF, about 50% of melanomas, cutaneous, not uveal, will have BRAF mutations. And these are an independent prognostic marker that has shown conflicting data because it also found in benign nevi. More frequently with vertical growth phase, so the thicker melanomas, and it's associated with disease progression rather than the genesis. This prospective study shows worse survival for the BRAF mutated melanomas compared with the BRAF wild, and other studies have shown that too. So 95% of these mutations are found in AA600, leading to a constitutive MEK-ERK pathway activation. So here you see the pathway from RAS, BRAF, and then activates the MEK and the ERK. And then the cell proliferation and the production and evasion of senescence and apoptosis in the melanoma cells. So this is the most common mutations that we find, and these are very specific for these treatments as well. So you have to study, if you are looking for them, you have to study and look specifically for the V600E mutation, because induced complete or partial tumor regression in 81% of these mutations in patients that can be treated with this specific inhibitor. So there are inhibitors for this, multiple, and the names are not that important, but people can use it specifically. And then when you use it in combination with the inhibitors for the MEK pathway, then it has much better prognosis. However, these patients get a lot of second complications, and some of them, the toxicity is too high, they cannot complete the treatments. As you can see here, they have increased survival time, not too impressive, but they can do better. And this is because they get resistance due to the upregulation of bypass pathways mediated by this cancer Osaka thyroid kinase. And they can develop de novo NRAS or MEK mutations. So they go well for a while, and then they develop this resistance. For that reason, and you see later on, we prefer right now they do combination of treatments. So how to test for this? The RAF mutation, you can do a DNA sample out of the paraffin-fixed tissue and through PCR. Or you can do also a immunohistochemistry with a specific antibody. And then you can correlate it with the molecular test if necessary, or if it is not clear, the results. And the antibody used is this one specific BRAF VE1 antibody. So this is a paper from across the street, our colleagues in MD Anderson, where they show that when you have this homogeneous staining, it's more reliable than when you have this heterogeneous staining. And they suggest that when you have the heterogeneous staining, then to do the molecular testing to confirm the findings. The NRAS, 20% of the melanomas show this mutation, and as a prognostic indicator has shown mixed results. No difference in melanoma-specific survival compared with the wild-type tumors. And NRAS mutations frequently found in nevi and early melanoma, so that's why it's not that specific for that. But if you look at the ones that are mutated, you can see that it correlates with thicker again, more than 1 millimeter, and more than 1 mitosis per square millimeter. And they're associated with poor prognosis survival, especially when they have a T2 stage. NRAS and BRAF mutations occur in an exclusive fashion. So you either have one or the other. They are direct inhibitors, have not demonstrated significant clinical activity towards NRAS right now. We have to test immunohistochemistry with a specific antibody as well. So for your primary tumor, these are the things that you should record or take in account for prognosis and treatment, which is the thickness, ulceration, histologic type, mitosis, age, site, and mutation type. With the new edition of the HACC, there had been changes because in the previous edition, you see here that the mitosis was important, and now in the new edition, the mitosis is gone. And now, instead of that, the status of the ulceration status of the tumor becomes more important and is applied to each of the T categories. And the size is better explained because before 1.01 to 2.00, it was more difficult because 0.1, depending how you are measuring, and it's not across two different pathologists will have exactly the same measurement. So in here is more broad, and you approach it to the next number that you get. And so here the sizes are the most important thing, plus the ulceration. So T1 to T4A will get, without nodal metastasis or systemic metastasis, is the stage 1 and 2. And the survival corresponds really good with this staging to T1A, 98% survival rate at 10 years, versus the T4B, where you have 75% survival rate. Now, after that, you then come to the stage 3 melanomas, which the difference now is the nodal metastasis. So now they go to the lymph node, and this is one important factor is how much tumor you have there. So how many nodes do you have? For that, it's important to look at the sentinel lymph node. So the sentinel lymph node is what everyone is doing because you are directing your search for the metastasis specifically to the lymph node that may have it. So you get your lymph node, and it's better when you cross-section breadth of it, because that way you increase your surface where you can, you can look at more surface rather than if you bisect it, like many people may do for other type of lymph nodes. So then you process it, you get your slide. Better to have more than one H&E so you have more levels to look at. We here do 3. Across the street, they do 2 levels. And then you have also to have at the same time 2 on stain slides. So if you need, because you didn't find the first time by H&E your metastasis, then you can do immunohistochemistry. So when you get your sections, the location of the metastasis is important to record. Usually they are subcapsular, but you can find it in the middle in the parenchyma or extracapsular extension. Then the size of the lesion. So you measure the length versus and the width of the lesion. This is very nicely explained in this paper by Dr. Prieto. The features associated with prognosis are the amount of lymph nodes with metastasis of whatever they have taken, location of the tumor in the lymph node, and the size of the tumor in the lymph node. So 3 or more lymph nodes are worse. Intraparenchymal or extracapsular location is worse, and more than 2 millimeters is worse. So all of 3 things will be worse prognosis for this patient. This is an example of this sentinel lymph node. When you see, this is 1 of 3, and you can see that with the H&E, you can see that there's a subcapsular tumor. And then if you do HMB45, which we prefer to do a pan-melanocytic and HMB45, you can see that it's in the subcapsular area. And one caveat is that there are capsular nevi. And there's a study that has studied many, many lymph nodes from different causes that people take out. And it's about 20% of the lymph nodes have capsular nevi. So if you do a S100 or any of the stains, you will see the staining in there. But look at the location and look at the pattern of a staining, compare the cytology features, morphologic features of the cells with the metastatic melanoma. S100, we try not to use it because it stains everything, the dendritic cells, and it just confuses the features. HMB45 is very good marker. Then you can, measure the width, the length, and record it. So for a stage 3, also, it's important to, in the new staging, the satellite and in-transit disease is important. So this means that the tumor that is spreading towards the lymphatics in the dermis or subcutaneous tissue outside of the nodal basins between the primary tumor and the lymph nodes, it's important to record. Category in this includes the local metastasis, satellite lesions, in-transit tumor, and of course the nodal metastasis. So this is the graph in the new staging where it shows the importance of this because, the category, all of these ends. The important thing is that it really separates in 4 groups. So this has shown that it really has an impact. The most important things here are tumor thickness, ulceration, lymph node number and amount, and the microsatellite or the in-transit tumor. When you jump to the stage 4 now, you have now the difference from before is that we have, they have added the M1D, which is now CNS involvement. And now every other difference in the staging is associated to the LDH status level. So you have M1A, 0, no elevated LDH, and so on when it's positive. Other additional features that they recommend to record for clinical care, but it's not part of the staging, are all of these that we already discussed, most of them, if not all of them. Now, with all of this, there are still some thin melanomas that present metastasis and poor outcomes. So now people are moving into trying to see which is the difference, what is making this different, these melanoma cells, that even they are very small and they create this metastasis. In this study, they did global gene expression to discriminate these melanomas, and they concluded that they concluded there were very few differences between these groups. They could not statistically significantly differentiate what is going on by these studies. And there are other studies that have shown that there's not a precise difference yet. So we need to continue studying that part. So to look at biomarkers for metastatic melanoma, patients treated by immune targeted therapy, all of these things are important. There are many of these topics that you have talked about before in this conference. So specifically, it means histochemical markers in melanoma. So what is the challenge in these melanomas? One of the things is that the melanin pigment is brown or very dark, and our usual chromogen is brown. So we have to manipulate that. There are tumor-associated lymphocytes, stromal cells, many marked with the proliferation markers when you are trying to distinguish a nevi versus melanoma. So what to do? Bleach your slide before, or do the chromogen differentiation with another color, red, blue. We do it with red, or the double staining, which is the best because you can see the cytoplasmic marker with the nuclear proliferative marker. S100 is very sensitive for melanocytic, but it's not specific. But is very good for desmoplastic melanomas. The caveat, again, is that 60% are negative for uveal melanomas. So uveal melanomas, we don't even care about the S100 staining. HMB45 helps differentiating between benign versus malignant melanoma because the way it stains, the pattern of staining, is different in melanoma, which is more patchy and it stains the deeper infiltrates. The others are SOX10, and this one stains very good as a melanocytic differentiation, but it also stains many other things. Again, it's good for desmoplastic. And then the proliferative markers. So this is what we do with the proliferatives. You can do with melanA or HMB45. We actually do with HMB45. This is an example with melanA. And you can see the cytoplasm in red and the proliferated melanoma cells in brown. Now, of this, the gene profiling expression and the tumor somatic mutations, now people are looking beyond why these tumors may not respond to treatment. So to do primary and metastatic sampling of the tumor for these mutations is important. This paper that just came out in August talks about the concordance of, they try to look the concordance, and they show that for these mutations, BRAF, TERT, PDL1, there is no concordance in the tumors. So you may think that your tumor has this mutation, you are treating for that and everything, but then the metastasis has changed. So it's now recommended to start looking also at the metastasis. There are other studies looking at that too. So now these PD1 receptors on T cells that tumor evasion and proliferation. Melanomas with this aberrant expression have poor prognosis, and we can treat them with this anti-PD1 immune checkpoint inhibitor. And as you know, you had been talking about this before, but in this treatment of melanoma, you can do, now people do more combination of treatment. So you will use your anti-PD1 therapy, but also you can combine it with your blocking pathways therapy here with the melanoma and have better prognosis for the patient response. Now, more is needed, so the peripheral, the liquid biomarkers. So there are many things that you can look, as in this paper they have shown that, tumor cells, protein, metabolites, nucleic acids, immune cells. The problem is that we still don't know exactly what it means. Some patients have these markers but do not present broad metastatic disease. Others don't have it and present it. In melanoma, there's also these other things like the microbiome. They see that when patients are responding to treatment, this microbiome may change, and you can identify the change. Fatty acids in the blood also change, and the vitiligo and rash in these patients, there are studies that have shown that the better response, they present more vitiligo. We still don't know exactly in which patients this will happen. And we have all heard about this, and everyone wants this treatment to work like it worked with President Carter, that in 2015, August, he presented with a diagnosis of metastatic melanoma. He was treated with combined immunotherapy and radiation. The radiation activated the damaged iron cells, and which attract the immune cells, and then treated with the checkpoint inhibitors and had a complete response. And 3 months later, he had the response, and 3 years now, he still has the response. And he is 91, so he's the older patient population. So when it works okay, but not everyone will have this response. Uveal melanoma. So this is different. Here you have, again, your clinical diagnosis. The melanomas can be treated by radiation plaque, and then if you want molecular prognostication, you need a biopsy, or by enucleation, and then you do your confirmation diagnosis. And then, most of the melanoma goes to the liver. This is the most frequent primary intraocular tumor in adults, but it also can present in children, 1%. Older adults and younger adults have different prognosis. That's why it is separated here. Arises in the choroid in the back, or in the middle of the uvea in the eye, or in the iris. There are different patients that can get more frequently the melanoma. So white, slightly pigmented, blue eyes, people have it more melanomas. Also predisposing factors, melanocytosis, nevus of Ota, BAP-associated tumor predisposition syndrome, and which is, this is the melanocytosis. You can see the patients with this melanin in the melanocytes in the sclera, and previous nevus in the choroid. 6 cases per million in the United States between 60 and 70 years of age is the common age. And this is the important thing. About 50% of the uveal melanoma patients will develop metastases. 50%. There's an estimated risk. This is very important because many people have choroidal nevus, and about 1 in 8,845 will transform to melanoma, and you don't know which one is that, so patients need to be followed. Different from other tumors and other melanomas, the standard of care for diagnosis and treating patient is clinical. You don't need a biopsy for this. And they have a combination of the clinical picture, ultrasound, OCTs, and all that to get to the diagnosis. 80% metastases go to the liver. 90% have it in the liver prior to death. 1/3 of the metastases are solely to the liver. And there's no difference in survival to whatever treatment you do to the patients. High risk, like in the skin, the locations is important. The ciliary body presentation is important. It presents later and it's larger, has worse prognosis, and we think it's because it's hiding behind the iris. The iris has the best prognosis because you can see it in the mirror. It's very small when you find it. you find that in 10 years earlier, so younger patients, and it's not aggressive. Over 10.5 millimeters at the base and 5.5 millimeters in thickness is worse, is when it starts to be a high risk. Metastasis, millimeter by millimeter, so this is from Dr. Shields in Philadelphia, and they have shown that the thicker the tumor is, and this is also in the COMS study, the worse it goes for the metastatic risk. So 10 millimeters or more, 50% mets. This is a large tumor in the ciliary body, so location and size. Of the HICC new staging, it goes really well with the prognosis, as you can see here, for the size. So it goes incremental at 10 years, the percentage of metastases. Cellular type is very important. Spindle is less aggressive than the epithelioid. Vascular mimicries are also bad. Uveal melanoma genes that are implicated. So here you see different genes that we had been talking. These are in the development of the tumor, and these are more prognostic. Monosomy 3 is bad, and gain of chromosome 8q is also one marker that is of bad prognosis. And now, lately, we have identified also PRAME as a bad prognostic for metastasis. These mutations are exclusively mutually exclusive, so you have one or the other, and they associated with the prognosis for metastasis. So this is tumor transformation, and as we said before, in blue niva you can have that, but in ocular melanoma, 46% you can find that mutation. So these occur later in the tumor progression, and they have significance. BAG1, which is BRCA-associated protein 1, is a tumor suppressor gene, is located in chromosome 3, which we already said is very important, and is found in other tumors as a bad prognosis. It also gives the morphology of the epithelioid cell. So this is very important because it's associated with what we have already learned that it was a bad prognosis, the epithelioid cells. So 47% of the uveal melanomas will have this mutation. And this just proves that the theory of the two hits, because one allele in this patient is already taken by the monosomy, and then you have other mutations that inactivate both alleles. 40% of uveal melanomas will have that. The cutaneous atypical and epithelial melanocytic lesions may have it. Also in clear cell melanoma, clear cell carcinoma, and the mesotheliomas, which is the epithelioid type. You can test by direct Sanger's, by especially in patients that have the BAP1 related predisposition syndrome, the family members, by RT-PCR in the tumors, or by staining, because the negative staining is what is giving you the positive correlation with the mutation. So let me see. The other type of genetic testing in melanomas, DNA-based, mRNA, FISH, or sequencing. By gene expression profiling, mRNA testing, there's these three classes that had been identified by this gene expression profile. Class 1A, very low risk, 2% chance of metastasis 5 years. Class 1B, 21% risk for metastasis, and 2 is 72% 5 years. And you can see here the genes separate really well, the class 2 and the metastatic, with different genes, and here you see the different genes that we had been talking about. This one is associated with younger patients, and these are with greater, larger diameter. PRAME. PRAME is a cancer testis antigen, preferentially expressed antigen in melanoma, And this is a biomarker for increased metastatic risk in class 1. So there are some small tumors that metastasize, or class 1, and they have the PRAME mutation. So this is a very important thing also to take into account. This is a nice figure from this paper from Harvard et al., where it puts together all these mutations and where you could manipulate this. But here's the PRAME that changes the class 1 into possible metastatic tumor. So it's important to have adequacy of sampling. So here we do adequacy check at time before they put the plaque. We do they do the biopsy, and then we do the adequacy to make sure that they are getting the tumor for the molecular testing. And then we can also further do stuff with the cell block. We identify the spindle cells too, the epithelioid cells. This adds to, we can check for T cells or other markers in the cell blocks. So, so far, most of the treatments there's no treatment. So 50% of these patients will die of disease, but still they want to know. They want to know because you can put them in clinical trials. And there's some adjuvant treatment that is being done. It works better in younger patients than in older patients. It's an stimulant. These are some results for some publications that people have done. But at the end, you see that it's almost the same, although in the younger patients, there's a better survival compared with the non-treatment, 85% at 6 years versus 40% not treatment. But in older patients, this difference is not seen. So they're related, maybe related to more comorbidities in the older patients or delayed diagnosis, and in the patients with younger patients with better immune system. Now, this one is important, stimulated T cells. You can do it with different ways. Here at Methodist, they do, for the metastasis, gene therapy with radiotherapy to the larger metastases, and then checkpoint inhibitors and T cells that are manipulated to get to the tumor. So this is an example with these IMTACs, where you have a specific enhancement of the T cell receptors. This is an example of a patient in the early trials with this. Dr. Carol Shields gave me this patient. So you have this patient, 9.5 millimeters, liver metastasis, 7 years later, more than 30 metastases here, and otherwise he will be dead in 3 months. Now he's 2 years later, following the intact, all the tumor is gone. So in some patients, it really works. Minor side effects are the depigmentation of the skin hair. Currently, as I said, this is the only thing that has worked. And so 70 to 80% are alive at 1 year in this trial. Now it's going to be open to more people, this trial, to all the United States. I think we are going to participate. So that fail intacts, they can respond to the checkpoint. So this is another case from hers, that after the intact, this is the initial before, then responded some, but started failure, and then with the checkpoint inhibitors, and totally regress. So the combination of this is very important. Here at MD Anderson, they are doing that. We are also started to do that. So in conclusion, skin and uveal melanoma, diagnostic primary lesion thickness and ulceration in the skin is important. The stage 3 melanoma, important to identify the lymph node features. In uveal melanoma, the first genesis and progression with molecular markers, then skin melanoma. Molecular status of the primary tumor and metastasis is important now for treatment, and combination of treatment approaches is important for success. High-risk biomarkers identified patients with potential response for treatment. Need for more liquid markers is now very important because with all these treatments we could assess success and identify biomarkers in the smaller thin lesions for early treatment or neoadjuvant treatment. It's important. And thank you very much.
Our next speaker is Dr. Dan Arbour. He is the chair at the University of Chicago. Dr. Arbour.
Thank you. Thank you very much. Thanks for this invitation. It's a pleasure to be here. I do want to point out that some of the materials you received said I was in New York, but I am from the University of Chicago and have not left. It's a pleasure to be here. As I said, I think I have one of the longest attachments to Houston Methodist Hospital of anyone. I was born in Houston Methodist Hospital. So I was tasked with giving an update on leukemia biomarkers, which there are lots of leukemias, so we'll be here for about 4 hours going over these biomarkers. And when I got this, the first thing I wanted to make sure is I knew what a biomarker was. So I looked at this NCI Dictionary of Cancer Terms, and they say it's a biologic molecule found in blood or other body fluids or tissues that's a sign of normal or abnormal process or a condition of disease. That's pretty broad. That's a lot of different things. And when you're dealing with leukemias that are floating around in your blood, you've got lots of biomarkers related to those cells that can be useful. So how to kind of address that in 30 minutes or less? Well, first I want to just kind of summarize the different types of leukemias. They're usually broken down into lymphoid and myeloid diseases and then further broken down into acute and chronic. The chronic lymphoid diseases include chronic lymphocytic leukemia and other chronic lymphoid leukemias, and those have a great deal of overlap with the lymphomas, which you'll hear about from Dr. Crane next. While the acute leukemias in that category are acute lymphoblastic leukemia and lymphoma, which are now known to be biologically related diseases. Some present as leukemias, some present as lymphomas. For the myeloid disorders, chronic myeloid leukemia that's BCR-ABL1 positive is the major chronic myeloid disorder, but there are myeloproliferative neoplasms that include essential thrombocythemia, primary myelofibrosis, and polycythemia vera. And then there are cases that have mixtures of features between myelodysplastic and myeloproliferative disorders. The most common of those is chronic myelomonocytic leukemia. And then there's acute myeloid leukemia, which is a whole bunch of other diseases. And then there are leukemias of ambiguous lineage, which really just means we don't know what they are, but we put them into this kind of wastebasket category of either undifferentiated leukemias or leukemias that express both lymphoid and myeloid markers. And I'm not going to really spend much time on those. So there are lots of different biomarkers related to leukemias, ranging from proteins that are expressed or gene expression, gene fusions and gene mutations, which are the ones that are the most commonly published and studied right now. There's certainly epigenetic changes that occur in leukemias. And then, in a way, morphology is a biomarker that at least gives us clues to investigating, trying to figure out what is driving these distinctive morphologic features. And I'll show you how that has worked in some of the, I think, most mature diseases in terms of looking at genetics. So biomarkers in leukemia have a lot of different roles. They can be used to help detect and diagnose leukemia. They can help determine the prognosis, and that's been a big feature for a lot of the molecular genetic changes in leukemias. And they do now drive therapy. The treatment, particularly of acute myeloid leukemia, for many years was the same. And just in the last few years, there have been new drugs that have been developed that really target some of these specific changes. And they can detect residual disease, although that's fraught with some difficulties, but some of the molecular genetic events, if detected after therapy, do indicate a high risk for relapse or residual disease. So there's a lot of data. There are really thousands of papers about molecular genetic events in leukemias. And there are lots of ways to look at data. You can look at a bunch of papers and just decide which ones you like and go with those. You can look at expert opinion, which is really what the World Health Organization and the European Leukemia Net and the National Cancer Comprehensive Network guidelines are. They look at literature, but really experts kind of get together and decide which ones are important and make decisions. Or you could look at a meta-analysis, and the CAP-ASH guidelines, which were published last year, looked at, for acute leukemias, tried to synthesize a bunch of individual studies, used methodologists to help determine which studies were the strongest, and then tried to determine which, particularly the molecular markers, were most important in the diagnosis of acute leukemia. And some of them have conflicting data. You'll read one paper that says this marker has no significance. You'll read another one that says it's a good prognosis, and you'll read a third that says it's a bad prognosis, all for the same gene. And that meta-analysis, looking at the methodology, really helped us kind of tease out which ones were important. And I'll talk a little bit more about that as we get farther along. For protein and gene expression in acute myeloid leukemias, there are 4 that really have fairly strong evidence of being predictors of poor prognosis in acute myeloid leukemia. About 40% of acute myeloid leukemias have a normal karyotype, and in that setting, detection of BALC expression, ERG expression, or MN1 expression is associated with a worse prognosis. And this has been borne out on numerous studies. In patients that have KMT2A translocations, most commonly the 9/11 translocation, expression of MECOM, which is previously known as EVI1, also is associated with a worse prognosis. The data was very strong when we looked at these through the CAP-ASH guidelines process, but when we put them out for public review and comment, it was correctly pointed out that these assays are not available in most laboratories, and they probably don't provide you significant additional information compared to what else you get now when you work up an acute leukemia. So the guideline says these may be useful, but they're certainly not recommended. But if your center does them, then it may be an additional biomarker you can use at the diagnosis of acute leukemia. Probably more importantly are the results of translocations and gene fusions, most of which are detected by karyotype analysis. And really, the WHO classification, starting in 2001, called out specific AML types with balanced translocations, and in 2008 added acute lymphoblastic leukemias, and there's certainly some chronic myeloproliferative disorders as well, which I'll show you the most common one. The prototype for this, for AML, is acute promyelocytic leukemia, which was originally described based purely on morphology, having lots of cytoplasmic granules, as shown. See, that's bad, right? Lots of cytoplasmic granules and abundant hour rods, and then it's later noted that they have these kind of butterfly-shaped nuclear features, and these were felt to be distinctive and were called out in the older classification called the French-American-British classification as M3 leukemias. It was then discovered that this morphology correlated fairly well with a 15-17 translocation, and then it was discovered that 15-17 translocation resulted in a fusion of PML and RAR alpha. Interestingly, it was also discovered that if you give patients all transretinoic acid, you can overcome the defect of this PML-RAR alpha fusion, and combined with traditional chemotherapy, these patients suddenly did very well. And now it's been shown that if you give patients atra and arsenic trioxide, you don't have to actually give them traditional chemotherapy, and they do exceedingly well. And this just shows that with arsenic trioxide and atra, you have over 90% long-term survival as long as the patient survives long enough to get to treatment, because they're at high risk of dying from bleeding before they're diagnosed. So this is a great story of how the morphology kind of triggered further investigation that led to a karyotype abnormality, and then to understanding of the genetic events, and then a therapy. Now, the therapy was kind of coincidental at this time. It wasn't a target. It wasn't developed to be a target for this, but it was found that it worked. The other example is the BCR-ABL1 fusion. This was first discovered in chronic myeloid leukemia as the so-called Philadelphia chromosome, discovered, and it's this little funny-looking chromosome on kind of crude karyotype analysis that was discovered in Philadelphia at University of Pennsylvania by Noel and Hungerford. Janet Rowley at the University of Chicago, which I have to mention, discovered that this represented a fusion of chromosome 9 and chromosome 22, which was later shown to be a fusion of BCR and ABL1 genes. This now finding this fusion is now essential for making a diagnosis of chronic myeloid leukemia. 100% of cases have it because it's definitional. If you don't have a BCR-ABL fusion, you can't make the diagnosis anymore of chronic myeloid leukemia. About 5% of patients don't have the actual 922 translocation, but when you look at them on the molecular genetic level, they have a fusion of BCR-ABL, so you can still make the diagnosis. About 25% of adult acute lymphoblastic leukemias also have this translocation and have a very bad prognosis. And a small percentage, but still some percentage of de novo acute myeloid leukemias also have this translocation. And the reason this is important is there are actually therapies now for this. So this is an example of chronic myeloid leukemia. These can transform to myeloid or lymphoid blast crisis, but when I talk about lymphoblastic leukemia, I'm referring to de novo cases and AML's de novo cases, which are fairly infrequent. But this is important because the BCR-ABL fusion alters the ATP binding site, and this results in activation and proliferation, and that's why you get all these myeloid cells turned on and increased white counts in patients with chronic myeloid leukemia. And this is the target of tyrosine kinase inhibitors, that when they block this ATP binding site, it shuts down this proliferation and has been extremely successful in the treatment of chronic myeloid leukemia. Before this was discovered, the only way to cure chronic myeloid leukemia was bone marrow transplantation. This shows the survival of chronic myeloid leukemia by decade, and imatinib, the first tyrosine kinase inhibitor, was introduced in 2001, and you can see dramatic increase in survival compared to prior decades based on this. Now, this is not only an important marker at the time of diagnosis, but these patients are followed by their burden of BCR-ABL. And this shows that if you can show a 3-log reduction of BCR-ABL, then their survival at, in this case, 2.5 years was essentially 100%. So monitoring this is very important. And when they can't get this reduction, they can also, now there are molecular assays to determine if they've acquired new mutations, and they may be better suited for a different tyrosine kinase inhibitor. So those are the prototype translocations in leukemias, the 1517 and the 922 translocation. But these are the other categories of leukemias in the 2016 WHO classification that are associated with cytogenetic or mutational abnormalities. There are others. So this is just some of them. So there are lots of different types of leukemias, and some of them are quite rare, but some of them are fairly common. So just a karyotype gives you a lot of information that helps you subclassify cases, but also helps determine prognosis. This is taken from a European LeukemiaNet paper that was published last year, where they just took AMLs and showed the genetic complexity of acute myeloid leukemias. The pieces of the pie are mostly the, I'm sorry, I keep pushing the wrong button, of the WHO subgroups of acute myeloid leukemia. This big piece are AMLs with mutated NPM1, and then this just shows all the other mutations they can also have. So it's complicated, but in reality, most leukemias are less complicated at the genetic level than solid tumors. They have fewer mutations per case. But understanding which mutations are important and which ones can be targets, I think, is the challenge in leukemia. So these are some of the ones that are important. For acute lymphoblastic leukemia, I talked about a quarter of adults have BCR-ABL positive acute lymphoblastic leukemia, and it's associated with a bad prognosis. About 25% of the other patients have what's called BCR-ABL-like acute lymphoblastic leukemia. They don't actually have the Philadelphia chromosome, but they have a gene expression profile that's very similar, and they have a prognosis that's also bad, and they may respond to tyrosine kinase inhibitors as well. And there are a whole battery of mutation and fusion assays that now need to be done to help clarify if patients have this BCR-ABL-like acute lymphoblastic leukemia. Unfortunately, there aren't a lot of labs that are offering this, but this is something that's becoming much more prevalent, and it's important, I think, and will become a more common test. For the myeloproliferative neoplasms, I think if you do hematopathology, you know about JAK2. It's the most common mutation in myeloproliferative neoplasms, and it's very helpful because we used to really struggle whether they were benign or malignant. If we can get a JAK2 mutation, that gets us out of that differential, and we can work on subclassifying them further. The ones that are JAK2 negative, many are CALR positive, and a smaller percentage are MEPL positive. There's a small group that are triple negative, and those, depending on the diagnostic subgroup, may be a better prognosis or a worse prognosis. But these three tests need to be performed in myeloproliferative neoplasms. Now, they don't all have to be performed up front. If they're JAK2 positive, you probably don't need the others. And then for AML, there are some mutations that are disease-defining, like mutations of NPM1, biallelic mutations of CEBPA, and there's a provisional entity related to de novo cases of AML with mutated RUNX1. And then there are a couple of mutations that are really called out strongly, FLT3, internal tandem duplications, and KIT mutations, but there are many more mutations discussed in the WHO. In fact, there are pages and pages of tables that summarize translocations and mutations that are not specific disease groups, if you're interested in learning more about this. And this is a summary of the more common mutations in acute myeloid leukemia, and not all of these are ones that are disease-defining in the WHO classification. So DNMT3A is a big one, FLT3 is a big one, and FLT3 is not a disease-defining category in the WHO because it crosses other genetic categories. So you can have acute promyelocytic leukemia with a FLT3 mutation. That means they're going to have a slightly worse prognosis. It really varies from disease group, but FLT3 does not really define a distinct subgroup of diseases, but it's important for prognostic reasons to perform that assay. So this is a figure from the Cancer Genome Atlas Project where they sequenced 200 cases of acute myeloid leukemia and looked at mutations in those cases. Many of them fell into categories we already recognize, like acute promyelocytic leukemia with the 1517 translocation, AMLs with inversion 16 or the A21 translocation. This is a big group of AMLs with mutated NPM1. And what I really want to point out is these patients have a lot of other mutations, and that's important. A patient with a mutation of NPM1, you don't know the prognosis until you know some of the other genes. If they have a mutation of FLT3, and probably if they have a mutation of DNMT3A, they have a worse prognosis than if they don't have that prognosis, have those mutations. If they don't have a FLT3 or DNMT3A mutation, they're going to do very well and probably don't need to have a transplant. If they have these other mutations, they probably will need a transplant to have long-term survival. This shows that interplay in another study. This is from Memorial, and it just shows that mutations by themselves are not as important. You have to kind of understand the key mutations and which interactions are important. And that's really something that we're still learning. This kind of raises the whole issue of then what tests do you need to do and how do I interpret it? And this was a challenge that was made to CAP and ASH to come up with guidelines to help both pathologists and treating clinicians when they're working up a new leukemia, what tests are important. This covers the whole gamut of the workup of acute leukemia, but does include molecular testing. So this is the one that did the meta-analysis that I was talking to earlier. Of course, around the same time, the WHO came out with their classification that was published in 2016, and then the whole book came out in 2017. So you hear about it as the 2016 classification or the 2017. They're talking about the same things. There's no difference between these two. These had which molecular tests you had to do for disease-defining categories and then discuss some of the other abnormalities, but really don't have an opinion on which tests have to be done outside of the ones that are needed to make a diagnosis. And then the European Leukemia Net worked closely with the WHO, but then kind of came up with their own proposals. And this is what they came out with, a risk stratification, which they had done before, but they kind of modified it using 2016 WHO and adding some new mutations. And the ones that are most important, most of these are not surprising, but the things that kind of jump out from this is when they talk about FLT3 mutations, they don't just do them as positive, negative. They have to have a high allele burden, and many labs don't do that. So that makes it a little more difficult. They also call out mutations of ASXL1 as being important, and actually the CAP-ASH guidelines felt the data on ASXL1 was too variable to make a recommendation. But this does recommend that you put someone in an adverse prognosis group and treat them more aggressively if they have a mutation of ASXL1. So how do you sort this out? These are the mutations kind of mentioned in the three major publications over the last couple of years. For the WHO, you need NPM1, CEBPA alpha, and RUNX1 to be able to accurately diagnose cases. You need FLT3, ITD, and KIT for specific subtypes to determine prognosis. KIT mutations in the setting of AMLs with an A21 translocation or an inversion 16. If you have a KIT mutation in that setting, it has a worse prognosis. KIT mutations are very uncommon outside of those groups. The CAP-ASH guidelines made similar recommendations, but the further data suggested that FLT3 ITDs, DNMT3A, IDH1, IDH2, KIT, TET2, TP53, and WT1 had enough data to suggest that you do those. It's not a requirement, but they suggest if you're going to do mutations, at least do these. Now, there is wiggle room because it says, and others, and that's because it was recognized when we started doing the CAP-ASH guidelines, most people weren't doing next-generation sequencing. By the time we finished them, it was very clear that was the future. So if you're going to do a next-generation sequencing panel, just make sure that these are in it. Now, if you look at the European Leukemia Net, the only real addition is ASXL1, and because many people use that for risk stratification, I recommend that you add that if you have a panel. But also, there are now targeted therapies against some of these. They're FLT3 inhibitors, and while the point mutation or TKD mutation does not have great evidence of being a prognostic marker, some of the FLT3 inhibitors have activity against TKD mutations, so it's probably advisable to now do those if you're doing a panel. And the others are already in IDH mutation or IDH targeted therapies are out there as well, but that's in the recommendation. So I'm not going to talk at length about gene methylation. I mentioned it at the beginning. There are numbers of studies that show methylation of specific genes and global methylation of the genome in acute myeloid leukemia has a bad prognosis. But it's not really clear how to use that, and methylation studies are not common in diagnostic laboratories. Interestingly, many of the genes that are important, at least in acute myeloid leukemia, are involved in the methylation pathway, in hydroxymethylation and hypermethylation. And these are DNMT3A, TET2, IDH1, IDH2, and WT1. Interestingly, though, individual mutations do not strongly correlate with global gene methylation, and so it's still not clear. But many of these genes have prognostic significance. I mentioned ASXL1. It's a gene that was originally described in AML, and there's some groups that say it highly correlates with AML with myelodysplasia-related changes. The results are a little bit variable. It's an interesting gene because it's involved in a lot of different pathways, and it's probably worth a lot more study to see if there could be something more there and possibly a targeted therapy. It occurs anywhere from 3 to 19% of AMLs. And some studies suggest it's associated with a bad prognosis, but not all. TP53, you're going to hear about probably in every talk. It's bad wherever it is. In AML, it occurs in patients with complex karyotypes, and they're associated with an even worse prognosis. A complex karyotype is a bad thing to have if you have AML, but if you have a TP53 mutation on top of that, it's even worse. U2AF1 is an uncommon mutation in AML, but when it occurs, it's associated with AML with myelodysplasia-related changes and a dismal prognosis. So this is an interesting gene. It tends to be associated with myelodysplasia. In AML, it's a horrible prognosis. In some other diseases, it really doesn't impact the prognosis at all. So if you define diseases purely by their mutations, the prognosis is going to be all over the place for those diseases. Now, I talked a lot about acute leukemia. In chronic myelomonocytic leukemia, there are a number of genes that are mutated. Some of them are similar to what I talked about. ASXL1 is fairly common and has prognostic significance, very clear prognostic significance in chronic myelomonocytic leukemia. The problem with this, and it brings up the whole problem with using mutations before you have a diagnosis, is that the mutations, some of the mutations that are chronic in CMML, which is a disease with a median age at diagnosis of 75 years, are also what are in so-called clonal hematopoiesis, or CHIP. CHIP was described in 2014 by 3 different groups. In patients, particularly over 70, there's a relatively high frequency of gene mutations in perfectly healthy people, and they don't necessarily go on to develop a hematologic neoplasm, and some of them have a higher risk of cardiac disease. In some of these mutations, particularly ASXL1, is the one that is common between CMML and CHIP. So if you have a patient with monocytosis and and they're 75 years old and you get an ASXL1 mutation back, that doesn't help you at all. But that doesn't mean that mutations are not helpful, particularly in the post-therapy setting. And this is a study that looked at mutations at diagnosis and at apparent remission to help predict which ones would determine prognosis. Now, here's DNMT3A, which is one of those CHIP mutations, and ASXL1 are common. But if you look at the ones that aren't CHIP mutations, like NPM1, it's not very common to be present after therapy, but when it is, it's associated with a bad prognosis. So it's a good biomarker for following patients. And they showed that if you could find if you found a variant allele frequency of less than 1%, patients had a good survival. And that was particularly true if you took out the CHIP, the most common CHIP genes. And usually they take out 3 genes in these studies, DNMT3A, ASXL1, and TET2. So I've quickly gone over really just a subset of the leukemias to kind of give you a taste of how genetic events and biomarkers occur in those. There are a variety of potential biomarkers that exist for leukemia, and there's already been some success in leukemia in treating patients with some of these abnormalities. Translocations and gene fusions, as well as mutations, impact disease mechanisms, and many of them are under active investigation. And there are new drugs coming out pretty frequently now that target molecular events in acute leukemia in particular. These by themselves may not be enough because patients have more than one mutation, but combining these with other therapies have a lot of promise for success. And with that, I will stop, and I don't know if we have time for questions, but thank you very much.
We'll do the questions afterwards. Okay, thanks. Our next speaker is actually the person who probably is the most in charge of our Twitter charge here. Dr. Eve Crane actually registered our hashtag back in August, so thank you very much for that. Dr. Okay, come on. I know Neil isn't tweeting over here, but he's proud of you. Dr. Crane is now at Weill Cornell, so welcome to Weill Cornell South, Dr. Crane.
All right, thrilled to be here today and to continue the best part of the afternoon Heme Path series here following Dr. Arbour. So no disclosures, but I'm inspired by the talk this morning to potentially find some. Similar to Dr. Arbour, I kind of looked at and see, what all would a biomarker incorporate, and trying to think of all the ways we're potentially using biomarkers in lymphoma, and it's relatively astronomical. We're looking at cell intrinsic changes, DNA, RNA, protein level. Even in some instances, you could look at metabolites as well as the tumor microenvironment. And then I forgot to even put on this slide, but a lot of the clinical parameters are also used as biomarkers in lymphoid neoplasms as well. And every line is on here is an example of a way that we're definitely using this in practice or for diagnosis, residual disease testing, prognosis, or altering therapy. So I'm not going to attempt to try to cover all of that, obviously, but just to give you an overview of what I'll cover, looking at 2 of the areas where we've really had intense biomarker development historically, chronic lymphocytic leukemia and myeloma. We now have increased need for minimal residual disease testing in both of these because of substantial improvements in therapy. Also talking about some of the most rapidly evolving areas, large B-cell lymphoma, even since the publication of all of the awesome guidelines that Dr. Arbour has been a part of and our WHO monograph, we have even new biomarkers that have emerged since their publication last year. In addition, I'll talk a little bit about some of the emerging technologies which we've covered earlier today, including next-generation sequencing, as well as the potential that proteomics may get in on the game a little bit, looking at the downstream consequences of this complex genetic landscape. So just to begin with chronic lymphocytic leukemia, the biomarkers developed there that we look at in pathology in particular, kind of focusing in on cell of origin, which we can measure in a variety of different ways, particularly looking at the IGH variable region mutation status. If that's heavily undergone somatic hypermutation, then these patients tend to have a better prognosis. We can also look at that with flow cytometry markers such as ZAP70, CD38, alpha-4 integrin that tend to be on the more naive B cells versions of CLL. And it's also been reported that you can look at this nicely by epigenetics. But again, nobody is really widely adopting that yet. And of course, cytogenetic markers, as they are in AML, are also very powerful in CLL, with particular genetics being associated with a worse prognosis. Of course, P53, either deletion of 17p or mutation of P53 otherwise. 13q aberrations are the most common, however. And there's also a routine panel that most places are doing, looking at mutations to kind of group these patients prognostically, because whereas it's relatively common, relatively indolent disorder, there's a lot of heterogeneity within that, and trying to figure out who needs treatment and to give the patients an idea of their prognosis. And of course, there's an elaborate clinical staging system with the Rye and Benet staging systems that have been developed, looking at more clinical parameters such as anemia and thrombocytopenia. So what's now on the horizon that we're looking at more closely in hematopathology are better ways to actually monitor response to treatment, because we now have patients that are actually achieving prolonged disease-free survival on chemoimmunotherapeutic regimens. That is, these fludarabine, which is a purine analog, as well as rituximab. These patients are actually, some patients are doing quite well. And MRD is emerging as one of the most powerful markers that we can give patients prognostically, which has been defined in this setting as having less than one CLL cell that you can detect per 10,000 normal leukocytes, around 0.01%. So far, it's been used prognostically. People have been a little reluctant to use it for directing therapy, but it certainly can be and is under investigation, because we do have additional therapies that are emerging with multiple ways to target the B-cell receptor signaling through ibrutinib or PI3 kinase inhibitors, as well as targeting BCL2. We can do this by a variety of different ways that are sort of competing, and right now it's kind of emerging which may be the best. Multicolor flow cytometry has been around a little bit longer and more established. We initially using 4-color assays with 4 different tubes, you could get the sensitivity of 0.01% as long as you ran greater than 500,000 events, or basically cells. It's now increasing to around 6 to 10 colors. Most people are using, you can use fewer tubes, do it a little bit more efficiently. These instruments are more widely available. And this is great because you get results the same day. I guess there's mechanisms for us to bill for it too, which is one advantage. But you can also do this from a genetic standpoint, because B-cell neoplasms, of course, have clonally rearranged genes. And you can do this by PCR-based amplification. It's most sensitive, however, if you would use patient-specific primers, which are somewhat labor-intensive to develop. And of course, everyone is now switching to thinking about doing this in a high-throughput sequencing method with next-generation sequencing, where if you know that malignant clone sequence at baseline, you can then quantify it subsequently using these algorithms and identify it quite precisely and quantitatively within that polyclonal background, getting around to the 10 to 5th level and sensitivity at 10 to the 6th. So that's pretty cool. Like, you can get these really sensitive measures, but there are several caveats. Well, for one thing, we know that at the time of diagnosis, CLL is kind of everywhere. It's in the blood, it's in the bone marrow, liver, spleen, lymph nodes. It is small lymphocytic lymphoma as well. And we really are not exactly sure after treatment where the reservoir of potential residual disease could be. And it could certainly vary between patients and between treatments. Thus far, on these chemoimmunotherapeutic regimens, it appears that the bone marrow is more likely to be positive for residual disease as compared to the blood. And so it may be more relevant to measure that site. However, as we know from variety of talks today that we can measure, we can use NGS in a variety of things, cell, tissue, plasma, and indeed measuring the cell-free DNA fraction may be more sensitive for residual disease, and then you're getting that whole body picture. In addition, you may get a different, if you look at that initially, you may get a little bit of a different picture than if you just analyze the genetics of a cell pellet. You may get a broader picture of the diversity of that disease and may have slightly different mutations in different compartments. But it's, even though that this appears to be emerging as one of the most powerful methods, it's not that we should just throw away all of our other elaborate biomarkers. In fact, they're still quite relevant. P53 is still terrible. There's no way around that. And unfortunately, these patients, even if they achieve MRD negativity by certain methods, then they still have relapsing disease. So additional work is being done to figure out whether or not it may be residing in one of these other residual compartments. In addition to just looking at IG rearrangements and monitoring whether disease is there or not, NGS, of course, offers a potential to look at other things. You could look at clonal evolution, and you can also look at the emergence of disease resistance. And this can be quite powerful. For example, with these Bruton tyrosine kinase inhibitors as well as PI3 kinase inhibitors, we know what those emerging resistance mutations look like, and so they can be investigated specifically. And indeed, they were found around 20% of patients will have relapse, and you could find these resistant clones emerging much earlier than the clinical relapse, like 15 months earlier. And so that gives you a window when you could potentially target or change therapy for these patients. And this cell-free fraction appeared to be more sensitive for measuring that, and both obviously more sensitive than using traditional Sanger methods, which have been used in the past. So the circulating DNA is also an extremely powerful tool for our non-circulating lymphoid neoplasms, and several papers have recently come out in both classical Hodgkin lymphoma and diffuse large B-cell lymphoma. Classical Hodgkin lymphoma is particularly interesting, I think, because we know these Reed-Sternberg cells tend to be very rare. Maybe they're only 1% of the cells within this inflammatory background. And so, as we pointed out, you don't really want to circle cells and try to do a DNA analysis of something that's a whole bunch of inflammatory cells, because you're not going to get anything. But it turns out the Reed-Sternberg cells possibly are turning over, apoptosing more, they're contributing more to the cell-free DNA fraction, and this may be a way that we can actually look at that profile of these cells at baseline. In addition, a novel way to follow them for recurrence. These are typically young patients. Getting repeated CT scans is what we currently do, and it's poorly sensitive. In addition, it puts these guys at risk of the radiation exposure. So this idea that we could use cell-free DNA not only to better understand the tumors at the beginning, but also to follow them is extremely exciting, I think. And initial data does suggest that this can work. It's also been used in diffuse large B-cell lymphoma. This is still kind of all of the investigational standpoint, but again, it's the potential to kind of look at tumor heterogeneity, tumor response to treatment, and you look at as well for minimal residual disease testing. There are several caveats, like if you just do it using just immunoglobulin rearrangements, you may not be able to necessarily detect that in every patient at baseline, and it's not as good if you only have paraffin-embedded sections to begin with to be able to identify that clone. But in fact, rather than just looking for that clone, again, you can look at that whole mutational profile and combining it with both looking for mutations and looking for that IG clone. You can have a relatively sensitive method for residual disease and disease evolution. And our current methods also there are following with CT scan, which is more sensitive in some studies, but then it's also not as specific. These are a couple examples, which I guess are the only examples of histology I have in my slide, or this granulomatous inflammation that's not lymphoma. So I think there's a lot of power in certainly combining these to know, are we really dealing with recurrence or we're not, and what is, and does it have additional mutations that are relevant for therapy? So now switching more in earnest to looking at some of the advances that have been made in large B-cell lymphomas. This is the diagram that was published in the 2016 Blood Updates in Lymphoma and was kind of a major transition in the biomarkers we use to look at large B-cell lymphoma, and in particular with a new category, this high-grade B-cell lymphoma. We're now obligated to look in these diffuse large B-cell lymphomas whether or not we have translocations in MYC and or BCL2 and or BCL6, and these patients tend to have more aggressive disease and maybe more aggressive upfront therapy if they're able to tolerate it. And exactly which diffuse large B-cell lymphomas should be tested for this is somewhat variable between institutions, but certainly anything that looks like it's going to be a very high-grade neoplasm, most people are testing. But we are still left with a fairly large category of diffuse large B-cell lymphoma, and that diagnosis is not made just as simply as this diagram would suggest. But in fact, in addition to that, we have a whole other series of biomarkers and testing that we must do each time we get something that looks like it could be a large B-cell lymphoma, in particular to exclude all of these other subtypes, which have been slightly revised with the new guidelines. In particular, we want to know, do we have something like this EBV mucocutaneous ulcer, which is actually kind of an indolent, self-limited thing that sort of resembles Hodgkin disease, but you just ignore it and it goes away. So you want to make sure you look through and identify those. In addition, primary mediastinal large B-cell lymphoma, young women has some Hodgkin-like features, intermediate between large B-cell and Hodgkin. These folks may require more aggressive therapy. So we need to do that. We need to make sure it's not a double or triple hit and should be categorized as high-grade B-cell. Next, we now, I think most everyone is staining for MYC and BCL2 to see is this a double expressor. These are not probably quite as bad as the double hits. There's some overlap with the double hits, but these encompass a larger fraction of the diffuse large B-cell lymphomas and may also require additional or more aggressive therapy. In addition, we want to know the cell of origin, which is a new requirement in the revised WHO, which is initially based on gene expression studies that were done to look at, does this look like a cell that was a germinal center B cell, or is it something that's more on its way to becoming a plasma cell that's left the germinal center? And this was done not on mutational analysis, but actually the gene expression patterns. Which gene expression cell type did it actually most closely resemble? And the importance of this is that it does correlate with long-term survival. Those with the germinal center B cell type tended to do much better, around a 76% overall survival. Now, this method of gene expression profiling unfortunately hasn't widely caught on. There is now an assay available, this LYMPH2CX, which can be applied to more broadly or more easily with clinical specimens, but it's also acceptable to do this by using IHC assays, by staining, for example, one of the algorithms, the Hans algorithm, using 10 BCL6 and MUM1, which classifies them either into activated B cell or into germinal center or non-germinal center type. There's also a small subset that don't really fit in either group, but we're not able to identify those very effectively with the IHC methods. So this, I think, is a major advance and is part of most clinical trials now, but these groups remain very heterogeneous. And there have been several large studies that have come out since the WHO revision doing wide, just large-scale sequencing efforts to identify whether or not there may be better ways that we can subclassify these patients and perform and maybe direct them to better therapeutic options. And this is the first one. Bear with me through these three sequencing papers, but I think they are extremely important to our field. The first one was from the Dave lab, where they looked at over 1,000 diffuse large B-cell genomes and found around 150 genes with recurrent somatic mutations. And they did indeed find these genes that had been typically associated with either the germinal center B cell type or with the activated B cell type, and they tended to go together. Like these clusters that we're identifying by gene expression profiling are real. These are reasonable groupings based on the biology and what we see. But by incorporating all of the additional data that they had in there, including copy number alterations, gene expression, and additional mutational analysis, they developed a novel prognostic score, like a genomic risk model. And they found that with this risk model, they could substratify within all the categories that we normally think about. So the germinal center B cell type, yes, overall they had a better overall prognosis than the activated B cell type. But within that, there were some that did really well and some that did really poorly. And similar with the activated B cell type, we don't want to necessarily tell these guys that they're all going to do poorly, because there's a subset that end up doing quite well. And you could also stratify based on International Prognostic Index, as well as these MYC and BCL2 double expressors. So they have that online where you can kind of plug in your own data and see where patients fall. Additional studies, So additional studies that came out subsequently, this is one from Margaret Shipp's lab, which they also looked at around 300 diffuse large B-cell lymphomas and tried to say, okay, let's scrap the original groupings and try to regroup these based on the data that we get in an unbiased fashion. And they came up with essentially 6 different groups. One group was C0, they didn't really find any mutations. These tended to be like T-cell histiocyte-rich large B-cell lymphomas, so they're probably just missing it based on low tumor fraction. But they did find 5 groups that had fairly distinct genetic features. Interestingly, we see that the activated B-cell types split into 2 different clusters, similar how they were able to split them with the Dave lab data. And the germinal center B-cell types also split into 2 distinct clusters. And what we see is that there was a subtype of these activated B-cell, like diffuse large B-cell lymphomas, of patients that actually did very well. Their lymphomas sort of looked like marginal zone lymphomas based on the genetics, although histologically they did not. They tended to have BCL6 structural variants, frequent Notch2 mutations, and PDL1, PDL2 structural variants, and mutations in MYD88 that were not this L265P mutation. And they did quite well. As you can see here, they were actually in this group, which was with the better GCB patients. There was a separate group of so-called cluster 5, and these tended to be extranodal disease. All of these lymphomas that we have kind of special subtypes for that we know are bad ended up falling in there, such as primary central nervous system lymphoma and primary cutaneous DLBCL leg type. These things had more uniform 18q gain. They had defects in the NF-kappa B pathway with CD79B and this MYD88-265P mutation, around half of them, that's shown here. So they really did kind of have this distinct cluster, this NF-kappa B activation, which is what we'd kind of been associating with ABC type anyways. And they had this very poor prognosis. But looking at their GCB, they also divided those into 2 subsets. This C3 type had a worse prognosis. These guys tended to have, BCL2 mutations and as well translocations and often PTEN loss or truncations. And then they had a C4 group that tended to be more histone proteins, and they did pretty well with very rare mutations in BCL2. So it seems like there will be a role in the future for more detailed genetic analysis of these patients to help subclassify them and potentially with these pathways to direct targeted therapy, but it's still very much under evolution. The final paper was from Dr. Stout's group at the National Cancer Institute, where they were trying to figure out, because we have the activated B-cell type, germinal center B-cell type, these unclassified lymphomas, is there a way we can better classify that group? So they tried to enrich the 574 DLBCLs that they looked at for those unclassifiable ones. And they developed new categories based on their sequencing efforts, similar to what Margaret Shipp's group had done, but they actually could only fit around half of them into these new categories. The other ones just got left out. But I think that's okay because they didn't find distinct ways to group them, so they just focused on things that they could group. And what was very cool about that was they found very similar groupings as the SHIP group. These things, they decided to name it MCD, which had the MYD88 mutations, and CD79B mutations, and tended to be extranodal, tended to do very poorly, which are shown here. And then these BN2, which are essentially like the C1, that did quite well and kind of had the marginal zony type of mutations. Their GCP groups really didn't stratify as well, and they all kind of had an overall good prognosis, which I guess goes along more with what we have from other data. But within GCB, these ones that had the BCL2 translocations did do a little worse than the other GCB. So I think that area still remains, certainly needs a lot more investigation before we can do anything. So just briefly on the T-cell lymphomas, this is an area where I think there's going to be a lot of advances coming in the future. We still have a very large category of peripheral T-cell lymphoma, not otherwise specified, which is, if I'd known about the theme of the meeting, I would have gotten that Oscar the Grouch garbage thing for that part, but I don't have that. But it's still a wide area where I think we definitely need to subclassify better to direct treatment. But within T-cell lymphomas, one of the most powerful biomarkers that we have is with anaplastic large cell lymphoma and ALK. And patients that have ALK positivity, either one of the characteristic translocations, which can be detected by protein analysis, these patients tend to do very well, around 80% long-term survival, compared to the ALK negative ALCL, which around 40% survival. ALCL, ALK negative, is now a definite entity within the WHO, but it still is and so it has a very defined classification, but within that, there are very important differences in the subgroups. In particular, there's a new translocation involving 6p25, this DUSP22 translocation. These patients tend to do very well, and it tends to be more on the par of a 5-year survival, similar to ALK positive. By contrast, patients that have a TP63 mutation, which is also in the P53 pathway, these patients do terrible. It's around a 17% survival. So we don't necessarily want to tell a patient that we don't want to group that into the same basket when they have such widely different potential prognoses. In addition, there's a lot of targeted therapies that are coming out, both ALK positive and ALK negative. ALCL will have activation of the JAK-STAT3 pathway, which can potentially be targeted. In addition, a paper that just came out is stating that all of these tend to have type 2 overexpression, which is a kinase related to JAK, and a subset have type 2 translocations that could also be targeted. There's also evidence that a subset that don't have translocations may have ERB4 expression and may be able to potentially be targeted in that way. So briefly, I just will say a little bit about myeloma because it is the home of, not to try to have a little sibling rivalry with Dr. Dillon or anything, but we have the very first biomarker within HemePath as our claim to fame. And dating back to 1845 was when Henry Binns-Jones actually first saw this patient. And 2 different clinicians actually brought him. He was a known chemical pathologist or chemical kind of physician at that time. And 2 different clinicians that had seen this patient brought him the urine to analyze. And they actually published the results separately, and he published the results separately 3 times of this very unusual urine. But the patient was, I believe, a 39-year-old grocer that had these horrible bone pains, bony lesions, and a very unusual protein in his urine that was somewhat similar to albumin, but they could tell it was different. And Binns-Jones hypothesized that it must be related to this so-called Maltese osseum. He couldn't quite figure out how, but emphasized the importance of identifying other patients with Maltese osseum and seeing if they also had this protein in their urine. It actually took another 100 years to figure out what the heck that protein was. So I was like, somebody decided to call it plasma cells. They actually could see the plasma. They did do microscopy on the lesions, and they saw the plasma, these kind of monotonous cells in the bone and at that time, but they weren't termed plasma cells until about 50 years later. But we didn't have gel electrophoresis to discover like the M protein until the 50s, with finally the recognition of kappa and lambda light chain in 1956. And then subsequent to that, myeloma really has had further development of biomarkers, including clinical staging systems with the Dury-Salmon staging system, the international staging system, a very intense cytogenetic classification, which is important for patient management, and also board exams, of course. And then we have, on the bottom half, kind of the development of therapies. And this chart actually, we see the proteasome inhibitors, lenalidomide is developed, and now subsequent to that, we have a tremendous increase in the number of potential drugs that are available. And so traditionally we have, it's, with the diagnosis of myeloma, it's not enough to say, oh yeah, I got some plasma cells that are clonal, done. We don't even know what to call it without pulling in a whole bunch of different biomarkers. We've got to look at the clinical presentation, make sure there's no in-organ damage, how many plasma cells are there, and in order to say, is this just undetermined significance, is this smoldering myeloma, or this is someone who actually needs aggressive treatment and we need to call this symptomatic myeloma. And these are diagnoses that we make in conjunction with the clinicians, and I think this is probably one of the most exciting areas for biomarkers because we really do use them all in a variety of ways to determine who needs treatment and who's more likely to progress and have a worse potential prognosis. And of course, clinical parameters as well as cytogenetics, as I mentioned, go in there, including TP53, as always, being a worse prognosis. So at the moment, on the horizon, we have a similar problem as we have in CLL. So we have kind of all these classic measures that we were doing of myeloma, but now it's not just enough to kind of classify it. We really need to develop better methods to kind of measure very low levels of disease. And the MRD is becoming a new biomarker for myeloma. In particular, with some of these 3-drug regimens with bortezomib, 80% of patients could achieve a complete response. But if they don't, there's a lot of other potential medications in the arsenal, including our anti-CD38 antibody, daratumumab, second-generation proteasome inhibitors, and a whole bunch of other things. So if we know who's relapsing, who's not responding properly, there's a number of potential options. Again, in this disorder, they define MRD negativity as being less than 1 in 10,000 cells, and that has been associated with longer progression-free and overall survival. Here, of course, we're typically looking in the bone marrow because plasma cell leukemia does occur, but is very poor prognosis, so we don't typically look there. You can do similar methods with allele-specific quantitative PCR and as well NGS high-throughput sequencing. But I think in myeloma, it's also even that much more critical not to just say, oh, I looked for MRD negativity in the bone marrow, I'm done, because there's tremendous potential, particularly with people with aggressive disease, to have plasmacytomas or other extramedullary involvement that you're not going to measure. In addition, the involvement of the marrow itself is well known to be patchy. So we already have a biomarker, well, similar to the Bence-Jones protein or M protein, that we follow to see if there is residual disease to do that. Unfortunately, it's not very sensitive. And so there's been a lot of efforts, predominantly at Mayo Clinic, to develop kind of more sophisticated assays to get more detailed information about the level of M protein that we may be able to more closely follow that to look for minimal residual disease. And it's actually pretty cool. You can actually look for a clonotypic peptide, a little tiny peptide that you can measure from partially digested fragments of these immunoglobulins and run it through liquid chromatography, mass spectrometry, and actually measure those and get a much more sensitive measure of the M spike. And this is some sort of assay that could be used to follow along for recurrent disease. And of course, you could alternatively use NGS sequencing to do this type of thing, and maybe probably would be a little bit easier, but I don't know, wouldn't be as cool. But anyway, the clonotypic peptides, I think, are, once it's developed, could potentially be a very rapid and useful way to follow disease. But anyway, so in conclusion, I think there's a lot of exciting areas for biomarkers in lymphoma, particularly I think currently this evolving area of minimal residual disease measurement is an area where pathologists can really have a huge impact, where we're working closely with clinicians and we're making a big difference on for the patients in terms of clinical decision making. And it's not just a simple yes or no answer. We're really putting all our science forward to do this in the best way possible and to get the most information possible for the patient, looking at clonal evolution, clonal heterogeneity, resistance mutations, etc. So I think, maybe in another couple years we'll have more updates on how MRD is evolving, but I think it's certainly one of the most exciting aspects of pathology. And with that, I just wanted to thank Dr. Cagle for having me here and the entire team at Cornell for allowing me to join their team. And that's it.
Okay, so if this afternoon's speakers could please come up and have a seat. I'm going to let LJ should have a few other moderators. This time we've changed it up. We're going to have the speakers from the afternoon sit up here. And I'm going to let you all do it from the podium and walk around line.
Carolyn and Kay left you here. Oh no.
You're all alone.
I can say anything. I'm glad Stan's over there. He can help me out if I get stuck.
Here, Dr. Bernard over there, Dr. Hamilton, Dr. Jones. I think Dr. John is trying to defer.
Yeah, you're the John. Today is John.
Well, go ahead. We'll let it go.
All right, okay. Any question? While you're still thinking, I have a question for Dr. Yantis. That's about the MMR, and a lot of times we get requests about MMR, doing MMR on biopsy material. In general, we don't do that on a biopsy. We would like to have that on the bigger specimen, more to avoid the problem of heterogeneity. So how do you deal with that?
So the question is, one, do you do mismatch repair immunostaining on biopsy material? And two, how do you deal with heterogeneity of staining? The answer is yes, we do it on biopsy material, and I don't think heterogeneity is really a problem when you have enough tissue. I mean, really what you're talking about with respect to heterogeneity is usually with MSH6, and it's within a single gland, so I don't think that it's a huge problem, and there are plenty of data to suggest pretty good correlation between biopsy results and the findings in resection specimens. We recently did a poll of the Roger Haggett GI Pathology Society membership and others, surgical pathology directors across the country. And it turns out that most institutions, both in the community and in academia, are doing the initial mismatch repair evaluation on the biopsy. It can affect the type of surgical management that's done, and then also, obviously, in the neoadjuvantly treated rectal cancers, sometimes the staining's not so great. So I would encourage people to do it on the biopsy if you have enough material. I don't know if...
We certainly do it on biopsies. I think the only time that we've ended up in trouble, or I've ended up in trouble, is on cell block material where there are very few cells.
Yeah.
And given the heterogeneity, but we routinely do for colorectal cancer because it will drive surgery. Yeah. And have not had an issue with tissue biopsies.
MSI testing, different story, but for
right,
the
molecular more
immunostain,
sensitive,
yeah.
Well, I really enjoyed this afternoon's hematopathology lectures as well as everything else, so thank you. I have two quick questions about myeloid mutation data results. So I'm certain that we're going to, the lower limit of detection for most NGS assays clinically available now is around 4 to 5%, but as we enter into more widespread utilization of other NGS techniques like UMI, adapted NGS platforms, I expect that we will see at initial diagnostic samples, not MRD type, but 1 to 5% range variant allele frequencies. My question is, I believe it's inevitable. What would you think about in the initial diagnostic setting, whether it's a MPN or AML, et cetera, significance of low abundance mutations among like common driver, myeloid genes like JAK2s and CALRs, NPM1s, or whatever. I mean, aside from NPM1, MRD, if I have a low abundance, like 1 to 5% range, what am I going to do with this data once I inevitably start generating it?
I think we have to get a lot more data to know what to do with it. I don't think those really, at the time of diagnosis, I think you need to have a decent amount of the mutation, particularly for the myeloproliferative neoplasms. I'd feel really uncomfortable calling someone a myeloproliferative neoplasm based on 2% JAK2 mutation.
Yes. I've seen a number of cases like that, and I'm left with the same questions. Number two question also about myeloid mutation data analysis. I mean, it's a major challenge in the field is distinction from CHIP and CCUS, et cetera. But I did see some publications in Blood in 2017 talking about significance of maybe perhaps multiple mutations or relatively higher abundance mutations being perhaps predictive, more likely to be predictive of myeloid neoplasms as opposed to overt CHIP. Are you aware of a trend in the literature currently that this is going to be resolved soon, perhaps on cytopenic patients, that multiple mutations might more likely portend overt MDS in morphologically subtle cases?
Well, there's some big publications that have concluded that. I know we did a study where we looked at patients with pancytopenia with long follow-up that didn't evolve to MDS, and we had a number of them that had multiple mutations. But other groups have, I think it's going to be more complicated than multiple mutations. It's going to depend on what those mutations are. There's some mutations like U2AF1. If you've got that, then you probably don't have CHIP. And I think we still have to figure out which ones those are. If you've got, and it's true, most people who have CHIP only have one mutation, but there are some that have more than one. And I think we just have to keep getting data and determine which ones are important and which ones are we're just going to have to ignore.
Thank you.
That's okay. Another hematopathology question. I'm just curious how your institutions, what kind of prelim wording do you use in B-cell lymphomas that appear high grade? They look like a diffuse large B-cell lymphoma, but obviously the molecular is going to possibly change that categorization. So when you still have FISH pending, looking for a double hit, your BCL2, what word do you rent? We have to send ours out, so I've got to sign out a prelim. We used to use a term called high-grade B-cell lymphoma until now that's actually a diagnosis, and so it's that generic term that you use when you're waiting for your FISH to come back. I'm just curious. Yeah, I mean, I typically use, and we had this discussion recently, and I guess we don't have a uniform answer to that as the answer, but I typically use diffuse large B-cell lymphoma and then say, no, we send this off, and then if it comes back, then obviously I change the diagnosis to high-grade B-cell, but I defer to Dr. Arbour because...
If it looks like diffuse large B-cell lymphoma, I call it diffuse large B-cell lymphoma and say, those studies are pending, and I'll change it if they come back with a double hit. If it looks like a so-called gray zone thing, I call it, instead of high grade, I now call it aggressive B-cell lymphoma, see comment, and say that we need these studies. A lot of those, though, even if those studies come back, could go into the high-grade B-cell lymphoma NOS category.
I have a question for Dr. Schwartz. For the HPV positive head and neck squamous cell carcinoma, traditionally we think actually the HPV positive ones are the basinoid type, actually fully differentiated. Here you demonstrate the data, actually there's no difference for the survival. I'm just curious for the HPV, high-risk HPV subtypes compared to the basinoid, and what's the predisposition for the well-differentiated squamous cell carcinoma? Are they more such as, have other types of high-risk HPV, except HPV, 16, 18 type? Do we have any, data about that?
Well, I cringe a little bit when I hear poorly differentiated, because I think that if there's anything you're going to get rid of, it should be the term poorly differentiated when you're talking about a high-risk HPV oropharyngeal carcinoma. And as Bill Wester has pointed out, if you want to think about them, you can think about it as well differentiated because they're replicating the reticulated epithelium of the tonsil. The bottom line for high-risk HPV oropharyngeal carcinomas is that 90 to 95% of them are HPV 16. I don't know anybody who's found any difference in morphologic or prognostic features as far as if it's one of the 5% HPV 18 or there's been a few 31, 33. So there is no significance for that. And I think the real bottom line, and I have fallen in that pit at one time, is to dismiss the likelihood of a high-risk HPV positive oropharyngeal carcinoma based on morphology. So if it's in the oropharynx and it's squamous cell carcinoma, do the high-risk HPV type.
Okay, any other question? Oh, I'm in the back.
Could you hear that? Do you score the HER2 in, say, colon or endometrium or any other tumor type? Do you score it more like breast, or do you score it more like GEA for the IHC?
So in the colon, they use more of a GI grading system with the basolateral staining, but the cutoffs for going to ISH in situ hybridization are different than in the upper GI tract. I don't know about anything else outside my world.
Is that pretty standardized, the scoring in the colon? Is that consensus?
I'm sorry?
Is it considered consensus that use the GEA for? Well, like the basolateral scoring. I mean.
So the paper from the Heracles trial, they used the basolateral staining, and basically the grade 1, 2, 3 are pretty much the same as the upper GI tract stuff, but if you have 3+ staining in less than 10% of the cells, that's considered negative, and you don't have to do anything more, which is different than the upper GI tract. And then if you have 10 to 50% 3+ staining, then you repeat the IHC, and if it's still high, then you do the in situ hybridization, and if it's amplified, then they can get on the trial. So what you do after you get the result is different than in the upper GI tract.
And I have to say that's really a good question. I think we still need to develop some guidelines, collect more evidence in that regard.
Yeah.
Right. Any other question? Second time. And motion approved. Well, thank you very much for staying with us. Phil, you have any comments?
Tangled in this thing? Okay.
Yes. So we take a few minutes, then there's a topic that we hope to have a little bit of debate. Okay. You may now go up to the Dr. Lindemann, Dr.
basic, please. We're just going to try and, up here at the... On the platform. On the platform here.
Right, very good.
Yeah. And LJ, you want to join them?
Sure.
Yeah.
We're forming a barbershop quartet.
We're getting a few people to do this here, but anybody else want to volunteer to come up here to discuss the guidelines? Okay. You want to come up? Oh, you got the question. Oh, no. Well, okay, we'll do the question in a second. But okay, so now we'll do this was about the it's called conceptual considerations of guidelines and their implications for patients. That is, not everybody's happy with the guidelines of various types as they exist. And we do already have a question. If you'd like to go ahead and do your question, I think there's a microphone over here, and maybe someone can either help you with that, or you can...
I can just speak up.
Okay.
We, as a field, in our section, we base a lot of the clinical reporting templates for our NGS and other studies off of the NCCN guidelines. I couldn't help but notice that the latest version of the NCCN guidelines, as well as proceeding, did outline for non-small cell lung cancers KRAS with explicit language about prognostically adverse survival outcomes and being therapeutically predictive of resistance to anti-EGFR TKIs. But, since that's the therapeutically predictive resistance to EGFR TKI therapies is mostly in colon cancer. But the way I was trained is always, that's true in colon cancer, definitely not true in non-small cell lung cancers, although 20 to 25% of non-small cell lung cancers do have recurrent alterations in KRAS. But the prognostic and therapeutically significance of KRAS in non-small cell lung cancers is not the same. But there is explicit guideline language in the NCCN guidelines. The presence of a KRAS mutation is prognostic of poor survival when compared to patients with tumors without KRAS mutation. The NCCN guidelines also say mutations in KRAS have been associated with reduced responsiveness to EGFR TKI therapy. Do you agree? In your institutional practice, is the therapy or prognosis in non-small cell lung cancer altered by the presence of KRAS mutations? I found this a little bit peculiar.
Yeah, I can talk a little more probably about the role of KRAS in the EGFR mutation, in the EGFR targeted inhibitor story. So originally what had happened was, and it's been known for a while, that the KRAS mutations tend to be mutually exclusive with the EGFR activating mutations. And so if you go back 12 years, what people were doing was they were testing for KRAS, and then if it was wild type, they'd give EGFR inhibitor. And the problem with that was that, yes, patients with KRAS mutations don't respond to EGFR, but EGFR inhibition, but neither do people who don't have the EGFR mutation. And it wasn't an appropriate surrogate for what needed to be done at the time, which was an EGFR test. And so the original recommendation was looking at this from the positive standpoint, right? If there's an EGFR mutation, that's who should get an EGFR inhibitor. And KRAS itself, the absence of KRAS, should not be the reason that someone gets an EGFR inhibitor, because those patients don't do well. And in point of fact, though, the KRAS mutations are mutually exclusive. If you do have a KRAS mutation, you shouldn't respond to an EGFR inhibitor, but that result isn't adequate to make a decision about how to treat with an EGFR inhibitor. So it's a little parsimonious, I guess, but it didn't make sense to do that. Where we put the KRAS mutation in the guideline was essentially because most of these are mutually exclusive, and I know that there's small numbers of patients that have both, but in general, they tend to all be exclusive with one another, is in the context of trying to decide between the positive markers that indicate a treatment should be given, EGFR, ALK, and ROS, and we can talk about BRAF, which was a timing issue, and when to send someone on to, if you're not doing it yourself, a larger panel to look for investigational markers and things that may route someone to a clinical trial, that's where the KRAS test comes in. Because if those patients have a KRAS mutation, then they shouldn't have the other targetable oncogenes, and that there's no reason to continue doing a larger panel at that time. In our practice, we do a larger panel up front from the very beginning. We get KRAS, we get all the others, so we don't make that distinction. But we weren't prepared to make an international recommendation around the world. Everyone needs to do a panel. So in the context of where they're done sequentially, it's important to do EGFR, ALK, and ROS straight away. And then you have a decision point if those are all negative. You can do KRAS, and then if it's positive, stop. Or you can just send someone to a panel at that point. Did I answer your question, or did I just ramble?
I believe so. I see that the language in the NCCN guidelines is based on sort of like, it's more relevant for the sequentially ordered cascade testing patterns as opposed to like comprehensive upfront panel analyses. So that language makes sense in the setting of a cascaded algorithm, I think.
Yep, that's correct.
I think maybe everybody's ready for dinner. Okay, so the dinner, to remind you, is at the Marriott. You just follow the hallway going back. You have overpasses and stuff that you walk on the second floor.
Shortest panel discussion.
Yeah, it took us longer to get up here. Yeah.
Escalator up to the third floor. Everyone have a good dinner, and we'll see you tomorrow.